Good morning, everyone. It is absolutely fantastic to see many of your familiar faces in person today, and welcome to everyone that's joining. A very warm welcome to everyone that's joined online for our Antimicrobial Awareness Week, week of festivities. And it is festivities because as an antimicrobial steward for over 20 years now, I just know how passionate all of you have been in with your work to continually improve the judicious use of antimicrobials, and I thank you for all your contributions. We have a fantastic program today, and I welcome Professors Wendy, Chapman and James Gilkerson and Lisa Hall, who'll be driving our session this morning. Before we start, I would like to do a welcome, first of all, to show this beautiful piece of artwork about Indigenous bush medicine and thinking about the contribution to our First Nations people have made. We acknowledge the traditional custodians of the country throughout Australia and recognise their continuing connection to land, waters and community. We pay our respects to them and their cultures and to elders both past and present. In lieu of presenter gifts, we've decided to provide donations to two charities today. And the first is on recommendation of our veterinary colleagues, the Vets for Compassion, who provide direct emergency care in times of crisis, lost, mistreated, and also rehabilitating. So they were very active during the bushfires, etc. So thank you. I think it was Ri, that was your suggestion, wasn't it? The second one it was interesting to think about what we would like to do, and I thought providing some funding towards Indigenous Literacy Foundation was a really lovely idea. And this foundation focuses on literacy in young children and also in publishing and developing children's books in first languages. So I hope that you agree that it is a really nice idea. I spent last week in Singapore at the World One Health Congress, where I had the opportunity to see presentations from across the globe discussing the challenges of One Health. And there are many challenges, but there was one takeaway that was quite, I guess, an epiphany for me. And as a human health physician, much of what I've done has always had the lens of human health, as that the human being was the most important person in our universe, and that everything in our healthcare, in animal health and human health, was really always going to relate back to the health of the human. You know, One Health was, you know, reducing antimicrobial use in animals so we don't get resistance, so that we protect the human. But in actual fact, I think that's really the wrong lens. And what I took away from the conference last week was that we need to be ecocentric, and we need to equally consider animal health, our environment and human health in how we approach the AMR strategy, how we approach antimicrobial stewardship. And it is a two-way street as to how we're going to protect these resources for our lifetime and our generations. During the Congress, they presented the quadripartite strategy. You would have heard previously it was a tripartite strategy. Now it's a quadripartite strategy, bringing together the environment, the humans and animals. And really, it was actually the first conference that I went to where they openly started talking about implementation. In the past, many of these conferences have been talking about surveillance, how do we do surveillance, how do we aggregate it, how do we use our data. But this time around, there were many discussions around implementation, the challenges of implementation, social science, behaviour change, and no mistake, it was recognised that it was going to be a difficult challenge. And part of today's, the reason why we have chosen the Learning Health System framework is that because I think it is a fantastic framework to think about how we use our data, to create the knowledge, how we use that knowledge to create the clinical pathways, models of care that can improve prescribing, and then how do we effectively communicate and implement those into clinical practice. And not just in our own institutions, but thinking about the ability to scale those to other organisations so that those of us who are experts in the room can create a greater change for good, because we can develop systems that are going to be fit for purpose, that have engaged our community our stakeholders and our learning communities to continue to improve. And it's not just in our human health, but it's across all the sectors. And we needed, and as I said before, we need to be taking an eco-centric approach here. I thought before we went forward, it'd be nice to update you on the National Centre for Antimicrobial Stewardship and what we've been up to. And it's been a wonderful journey the last couple of years. Even during COVID, we have been extremely active, and particularly around the advocacy, mentorship and sponsorship in our training. We have resumed our monthly webinars again, which are extremely popular with both international and national visitors each month. And we have been very active in both advising and supporting national committees, such as AMS Working Party for the Commission. We have continued, the NAPS data, of course, is a core element of the AURA program and is being used to drive policy and practice, and we have had ongoing funding for a further 3 years. We have been very active in our Fleming Fund program, mentoring fellows from Bhutan, PNG, Timor-Leste, and also through the Combat AMR in the Pacific. And we very much welcome many of those who are actually online today and who will be speaking at a session next week. And then, of course, our veterinary colleagues, who I always say to everyone, you know, when we first established NCAS, and they were in an environment where there really wasn't much out there in terms of veterinary resources for AMS, they've definitely come up the back straight, and they're actually overtaking us. And it's actually the veterinary team who have done enormous innovation and, you know, conducted the largest ever randomised controlled trial in stewardship implementation. That's something many of us could only dream of in the human environment. We are very proud of our PhDs who have completed and have continued on as postdocs, as well as our current PhDs, and I welcome them all today. Courtney, of course, finished her PhD in surgical prophylaxis and has returned to really take a leading role in NCAS as a postdoc, and thank you for all your efforts for the last few weeks and months organising. And then, of course, we've been able to represent our work at many conferences, both nationally and internationally. Social media has become something that we have really enjoyed. The NCAS Twitter feed, I curate. I'm very strict. I block anyone that does any silly stuff. And so if you jump on the NCAS Twitter feed, you'll find hopefully that it's something that's meaningful and helpful to you. Our website, thank you to the team and to Arjun, many of whom have spent a lot of time updating and keeping up to date. It's not easy to maintain a website, and there are important resources there. And then, of course, the world of podcasts with Ri, who did a very successful podcast this year. There are a number of active research projects, and just to call out a few key ones, Nolene Bennett, where are you, Nolene? Is leading right up the back, is leading an MRFF where we're establishing a national surveillance platform for infection antimicrobial surveillance in aged care. This is a collaborative project, including the ROSA team, the Register of Senior Australians in South Australia. It's very exciting and it's been a wonderful journey. Anna Khanina, who'll be talking later today, is working with me on a digital project where we are utilising data science to support automated surveillance of invasive fungal infections in high-risk patients. The veterinary team have got many projects underway, but key, the Green Cross trial, and there'll be an enormous amount of data and opportunities following that, and you'll hear from James soon. We are involved in an ARC grant with Mark Davies from Monash. Arjun is our postdoc on that, and it's been a very revealing project. We have done, I don't know how many, 100 qualitative interviews with GPs, vets and patients around sociology and understanding of antimicrobials. Fiona Goddison, with her important work around the role of nurses, and then of course Ruby and Joan Mansky-Nankervis, who are leading an enormous amount of work in stewardship, and that's a photo of Ruby receiving a prize for one of her projects around with patient co-design. The foundational requirement for stewardship is really to understand appropriateness of use. Without that, it's very hard for us to understand how we're going to address it. And the approach that we have taken is really to jump into this concept of the learning health approach. And here we start to think about the opportunities in our emerging digital environment. How can we effectively collect patient animal data? And we need to understand the indications for use in order to address it. How do we aggregate that data from multiple sources? How do we use that information to understand and to benchmark, to assist individual institutions, jurisdictions in the national program to understand where resources need to be directed, where is the education knowledge growth need to be directed, and then how do we use that to inform practice change? All of you do that on a micro level with your own organisations, I know. One of the things that's often missing is actually evaluation, and we're focusing on that this afternoon, and particularly with digital, and this is perhaps one of the things that I've learned so much from Wendy and her team, is there are really great frameworks out there to undertake digital evaluation and patient outcomes, cost effectiveness. These are expert resources. We don't always have access to those, and hopefully we can start to build out toolkits that will support all of you. And then, of course, that really fundamental piece around effective communication and feedback, so important and needs to consider the challenges of behaviour change. We have some data to show you from our 2021 NAPS platforms. You have to remember that the NAPS is actually a voluntary program. It is done voluntarily by institutions across Australia, and each year the numbers continue to grow. It is really extraordinary that this is a community of practice that people see as highly valuable. We already know the challenges in aged care. It's no secret in terms of the requirements in building up support for these aged care homes. And we know that there are major issues with prolonged prescriptions, high use of medical prophylaxis, particularly in urinary, and an enormous amount of topical antimicrobial use. And we look forward to the impact that NISPAC is going to be having in driving the change. In surgical prescribing, we have typically said overall there's a 50% inappropriateness rate. This is an area, it is the most common reason for antimicrobial use in our Australian hospitals. There is an enormous amount of work to do to think about how we're going to improve surgical prophylaxis, and it's quite a different domain and a different framework, and will require a different approach to the typical antimicrobial stewardship that we do. Finally, the hospital NAPS. And again, these are hospitals, the 400 facilities are those that have agreed to benchmark the results, but many of us use NAPS during the year for directed surveys, and they may not be included here. But again, large numbers of prescriptions. And while this, 1 in 4 of our prescriptions is inappropriate, this has actually increased over time. Small changes are very significant in the NAPS, and we continue to see surgical prophylaxis, airways disease as targets of interest. But when you look at aggregated data like that, it doesn't really tell you the whole story, does it? So if we look at changes over time in hospital classifications, and here we have the principal referral hospitals who are already starting at quite a high baseline. But look at the women's and children's hospitals and the very high rates of appropriateness. And here we see other hospitals that have significantly improved over time with narrowing confidence intervals. What did they do? What did they do in those organisations? I think it's important to recognise that hospital classifications also reflect the type of services that they have. So typically principal referrals all have expert ID physicians. They all have well-funded AMS programs. Many of them have EMRs, an additional, 24-hour ICUs and EDs. And once you come down to the smaller hospitals, I think the improvements that they have made are really clearly very important, because many of those do not have the on-site expertise. So teasing and understanding how they improved, I think, is really important. And then finally, our veterinary colleagues have undertaken a national Delhi survey, which really has highlighted some important things here. very high numbers of our vets recognise the importance, and that 2/3 feel that they can actually make a positive difference, and that many of them are considering the risk of AMR. I would love to ask the same question of all our human prescribers to see whether they have the same reaction, and maybe we need to be doing the same survey with our human prescribers. Just before we move on, I am announcing our successful MRFF Research Data Infrastructure Grant, which we have just commenced. And this is a very exciting opportunity to look at the opportunities for utilising data science to actually help our colleagues undertake antimicrobial audit. And there are many challenges of doing that. First of all, it is voluntary, it takes time. It requires expert personnel, and while that can happen in hospitals, it's quite the challenge in busy veterinary and general practices where they don't have in-house auditors, particularly in aged care. So, the requirement for NAPS at the moment does require some expertise, as we know, to help undertake the appropriateness assessments. And I do want to say again that appropriateness assessments, what we have achieved in Australia, is not replicated anywhere else in the world. And to have national reporting on appropriateness prescribing is really incredible, because I think it's very meaningful, and we find it's significantly different if you just simply look at guideline compliance. And Kaz Chen will be talking about the NAPS later on today, how we're going to be transforming that with the redesign. The other challenges is that people working in varied environments, paper and electronic, but we do know that there is definitely a move towards electronic, and we know in the veterinary practices and GPs there's very high rates of EMR use, so we should be able to leverage EMR systems. We know that the data to do NAPS is often unstructured free text, hard to find, or just missing. So how can we leverage systems such as data science, like natural language processing, to help pull that data together? And, how can we use machine learning algorithms to assist you? And we don't want to take away human intervention, because I don't think data science will ever be able to do that. But we know that digital health can support the processes. And so we have established a broad data research collaborative. It's really exciting. We already have wide collaborations, but it's brilliant to have the Centre for Digital Transformation of Health co-sponsoring today's event. And I know that you'll really enjoy Wendy's talk and their team, and also RMIT, who are going to be supporting us. Building the building blocks of NAPS so that we can have automation requires establishing definitions and common data models that we need to establish, and then utilising information, reformatting it in a way that can be supported in machine learning to assist with that automation process, as you know. And this is going to be done in a supervised learning way. And then we will be making that available in a research data platform to drive research in this area. And then finally, we have a translational committee where we'll have consumers, prescribers thinking about how we're going to bring that data back to change behaviour. This is just a snapshot of the relationships that our team already have and our new collaborations. And as you can see, we are widely collaborative, and with the NAPS being adopted internationally as well, it provides enormous opportunities to think about how what we do translates internationally to our low middle income country colleagues, and how generalisable this data science actually will be. This is a graphic just describing how we're building the groups together in a common pathway. We have our hospital and surgical and aged care NAPS already developed over, 10 years or so as individual systems, because there was an iterative process, but how can we aggregate that data and how can we use that data together? We are working with our GP colleagues at the university, utilising the Patron data set, which is an enormously rich data set, an exciting opportunity to undertake the work on that. And we've already done very important pilot work which demonstrated that it is actually indeed feasible to take passive data out of GP systems and to undertake machine learning. We know that from our little dipped our toe in that a couple of years ago, which was one of the reasons why we knew that we could proceed. And then, of course, the animal colleagues have done already some very important work in natural language processing of prescribing data out of Vet Compass, which is a university collaboration across Australia with a huge amount of veterinary data. And so with that, we will federate that data and undertake our analytics and provide that data to our national researchers and hopefully translate that into clinical practice. Just a slide shot of some of our collaborators, many of them are either in the room or online, so it's very exciting. Before we, we'll show again at the end, but today's event is a collaboration of many of our friends and colleagues. So before I finish, a thank you to all of them in advance, and we'll thank them again at the end. Yeah. So welcome, James. James and I have been working together for a number of years now. So he's one of our animal stream team. He's internationally known as a your equine as well. Another equine. We have a lot of equine vets in our team, but maybe they're the cream of the crop, like the race horses of vets, are they? Anyway, you will definitely enjoy James's talk today. He has been working with our animal leads such as Laura Harderfeld, Kirsten Bailey, Ri and Anna, and who are PhDs and postdocs in our team in antimicrobial stewardship, was instrumental in looking at the use of data, working with the natural language processing with Brian Herr, who has completed his PhD with us. So I'm looking forward to listening to you talk this morning, Jane.
Sorry, I just want to move this and make this. There we go. By the 10th time today, I'll still won't get this right, but now let's do it.
Thank you. And just on the equine thing, I was at a conference years ago, and one of our delegates was there, and our equine vets president said, "Hey, we're equine vets. We don't get sheepish. We get hoarse. We get horses. We've got something to say, and people need to pay attention." So that's probably where we're coming from. But anyway, so yeah, sorry, I'll walk away from the microphone. That's not good. Sorry to our people online. So I guess given the MRFF and the theme of the conference today, we're looking at learning healthcare systems, and I guess that my question to myself was, can a learning healthcare system be applied to antimicrobial use, data collection, antimicrobial stewardship in a veterinary science setting? And I put as many of my colleagues up there as I could think of. It's, I guess, partly to emphasise, and Kaz, I think, emphasised that this is not something you can just do by yourself. This is a real team effort. Just on the data science side of things, I did like the fact that when Kaz was saying we got so much to learn, Laura and I went to see Tim Baldwin and Karin, who are some of our data scientists here at the university. And we just thought it was as simple as, is there just some sort of software patch where the data can go from the electronic medical records in the veterinary practice just into, I don't know, like an Excel spreadsheet or something, and we could just have a look at it. And after they'd finished laughing at us, which was probably about half an hour, they said, no, you can't do that. And here's how we can do it. So I thought I'd just take you on a little bit of our journey. So I think it's an aspirational goal. I like the idea of the learning healthcare systems approach. I like that formalized approach. And I think we've sort of serendipitously found ourselves in that sort of area. And I think it's the sort of thing, I think, as a researcher, I spent my entire, I was going to say adult life, probably my entire adult life, once I eventually grew up, looking at research and trying to see how my research can change how people do things in practice. I was a PhD student, and I gave a presentation, and an equine veterinarian, because we had stuff to say, said, that's an excellent presentation. That'll change how we see this disease and how we deal with things. And I thought, at least you can have an impact as to how your research gets. Am I too soft?
Yeah, a bit too soft.
That's something that's never been said to me before. But you know, I think as researchers, we sort of often tend to fall into the habit of, well, the publication's been accepted, tick, next project, you know, next project, and I think that closing the loop and actually seeing how your research can actually be fed back to practitioners, how it can influence practice, and then how that changes the data that's collected, and then in evaluating that data, how we can feed that back to researchers. I like this. So it's an aspirational goal, but I actually think it's been the aspirational goal of researchers for a long time. We've just not probably realised it. I did suggest that we could do this as an interpretive dance. So Kaz, I've got my tutu and cue the music. Thanks, Courtney. And no, but I think it's one of these things that I think is probably, I do tend to wave my hands around, so that's probably as interpretive as it's going to get. Moving along. So where to start? So I did what everyone does when they're going to present a talk, and I put a definition of a learning healthcare system, and I like it where it's an environment where knowledge is generated, and then we use that knowledge to embed in clinical practice in order to continually improve the quality, safety, and outcomes in healthcare delivery. The problems that we have then when we start to look at veterinary science is that there's no government system where we collect the information. Right, so veterinary practices in Australia, even the corporate practices, are private small businesses. Right? So they're private companies, or they're owned by 1 or 2 or 3 veterinarians. And so all of them are essentially a small business. There are some university practices. Some of them were more successful than others, but there's no. Sorry, that's a bit of a private joke for the university people. No government funding of services. So there's no PBS data. There's no Medicare data. There's no underpinning, overarching, depends how you want to look at it, system where you can start to pull the data out. And so we talked to Kaz about what happens in the hospital settings, and there's all sorts of records, you know, and then we've got to try and work out. And so a lot of ours, and I think Kaz was right, a lot of our data collections rely on goodwill and people wanting to do the right thing. And thankfully, we've been quite successful. So how do we get the data? Where do we go to? So we tend to think, when we think about antimicrobial use in animals, the first thing that most of us would think about is antimicrobial use in farming animals and food production. You know, antimicrobial residues in food, the perception that antimicrobial use in animals is bad, or particularly in food animals, is bad. And I think that's where I've liked a lot of the stewardship work that we've done here, because it's around appropriate use. And so I tend not to worry too much about the total volume of use. I tend to worry about the proportion of that use that's appropriate. And because sick animals need antimicrobials just the same as sick kids need antimicrobials, or sick grandparents need antimicrobials. If we could prevent that illness, then we could prevent the use, and then everyone's a winner. So, but we decided we'd start working with companion animals, partly because it was easier to get the data, and partly because companion animals tend to be part of the family. There's a more and more, you know, I remember my parents and my grandparents' generations, dogs were something that was kept out of the house, or my grandparents' generation out of the house yard, down at the shed, you know, and that's where they kept the dogs, because they were working dogs and you didn't actually socialise with them. And this is my cat on my daughter's bed. So things have moved along in a couple of generations. So they are family members, they do live with you, and there's some pretty good evidence around circulation of various pathogens between animals and their humans. And I also think it's a really good opportunity for us as an infectious disease community to start to engage with the general public, because Australians and generally around the Western world, people are moving further and further away from where their foods is produced, but they're having more and more to do with pet animals. And so I think if we can start to talk about stewardship and antimicrobial use and appropriate use in animals, companion animals is a good vehicle, if you like, to start this discussion. So Laura, who's not here with us today, started looking at you know, we can look at a practice, or we can look at, you know, a week's worth of antimicrobial use in a couple of practices or what have you. But big data gives us the opportunity to sort of start to look at trends and to start to really get a good handle at a population level. And the first big data set we were able to get our hands on was some pet insurance data. And so what she was looking at there, we were able to make an estimate around antimicrobial use. So there was some 530,000 prescriptions of antimicrobials, and we could get a use figure around, so for an individual animal, there was about 5.8 prescriptions of antibiotics per 10 dog years, and 3.1 prescriptions of antibiotics per 10 cat years. And I think that sort of gave us a bit of an indication as to where we're sitting relative to people, because it's quite low compared to what you see in the human population. But a pet insurance population is not the general population, and so we thought we could potentially go out into veterinary practice, and this is where our software patch came into. Laura and I, in our naivety, sort of, at least we amused Karin and Tim. This must have been about 5 years ago, and they're still amused by it, because I was talking to them the other day, and they go, "Oh yeah, remember that time when you're talking about the software patch?" Yeah, thanks very much. So the other thing I think we need to thank is Google, because I don't know about you guys, but if you're talking at home, I think your phone listens to you. And I was talking with Laura and I said, what we need is a veterinarian who has some sort of computer science background, you know, natural language processing or what have you. And 2 days later, this guy rings up and says, "Oh, g'day, my name's Brian Herr. I'm an American veterinarian with an interest in computer sciences, particularly natural language processing. And I'm wondering if there's a PhD. Someone said that you're looking for a PhD student in this area." I'm like, "Yep." And so we signed Brian up quick smart. And as they say, the rest is history. So Brian came up with a natural language processing approach, and we were using some companion animal work from data from Vet Compass. So as Kaz was talking about, Vet Compass is a national consortia of all of the 7 veterinary schools in Australia. We got together, we got a LEAF grant to put this data set together, and it's been basically able to pull data from, there's about 150 vet practices that have been contributing data, and they've got agreements in principle with another 260. So they should have the large proportion of all of the veterinary practices in Australia sending their information in here. We've just got to try and make sense of it. So as Kaz was saying, the great thing about it is that there's electronic health records. The really good thing from a practice point of view is that with these electronic health records, you can customize them to suit your own practice. And the really bad thing about it from a researcher's point of view is they can customize them to fit their own needs. So hence the use of the natural language processing, because most of the information is in free text in the clinical notes. So there are multiple clinics involved, there are multiple years. Part of the issue around the end is that it's companion animals rather than food producing animals, and a lot of our trading partners aren't interested in companion animals. They want to have data about that. There's no set nomenclature in veterinary practice, so people have their own little abbreviations, and they have their own little ways of saying things in their practice, which is different from their practice and different from someone else's practice. So there is the veterinary nomenclature codes, which would be nice if everyone used them. It would actually be nice if anyone knew what they were. So hardly anyone uses them. So it's a bit of an issue for us, but at least it's a start, right? So it was a good start. I won't lie. Brian did a really good job with this work, and he was Tim and Karin were excellent guides in this area. So someone said, "Oh, have you got a bit of how big is your data set? You know, you need to have a reasonably big data set. You know, at least 100,000 records." And Brian said, "Oh, well, we've got 4.4 million consultation records." And he did a nice natural language processing approach to try and go through the free text and evaluate dose, indication, and a whole range of things. So I thought I'd just quickly describe some of our work describing antimicrobial use. So this was the first paper that we produced. It was at a conference, and we were able to look at the different rates of prescribing according to the age. These are cats, these are dogs. And you can see, I won't go through it all, but you can see that the rate of antimicrobial use changes as the animals age, and then important antimicrobials or less important antimicrobials across. We were able to look at it on a state-by-state basis. Again, the sort of total use of antimicrobials, and it's about, so it ranges between 123 to 141 consults where antimicrobials are prescribed per 1,000 consults with dogs and cats. And then with high importance antimicrobials, about 40 was the median consults where high importance antimicrobials were prescribed per 1,000 dogs and cats consults. And so it's about 4% and then about 14%. So it was encouraging, and it was nice to be able to sort of present some of these data to some of our medical colleagues, because I think they found it reassuring that at least we were able to describe what we were doing. The nice thing as well was that you could do it on a clinic by clinic basis and look at this as sort of all antimicrobials per 1,000 consults. These dots are the individual clinics. And we were able to identify that these sort of high antimicrobial users were our specialist and emergency clinics in the data set. And then we looked to see whether they were the ones that were also using the critically important antimicrobials. And you can see, I should have I didn't have these highlighted. Yeah, I don't know if you can see them, you can see the mouse there. So you can see that they're spread through the whole data set. So some of them, even though they're using lots of antimicrobials, some of these guys down here are using hardly any highly critically important antimicrobials. So I thought that was really a really interesting finding. If you're going to talk about appropriate antimicrobial use, you need to be able to calculate dose, you need to be able to identify the indication, and we need to be able to try and assess them against guidelines. So Brian did a lot of work trying to work out how we could do this, and he was quite successful at being able to identify an indication, the dose of antimicrobials, and I guess in the difference between animals and people is that it's often milligrams per kilogram. And part of the problem we had with some of these ones here that there was no way we could define dose was that they didn't record the weight. And so we couldn't actually evaluate whether they had an appropriate dose or not. And we could look at duration of antimicrobial use. The disappointing thing for me was that less than 40% of veterinary consults had all of these characteristics that you would need to be able to assess whether they were appropriate or not. But the comforting thing was that the majority of them had a lot of them. So that was good. Worryingly, there was about 2% that had none of them. So I guess all research is about iteration and reiteration. So we're able to have this discussion with the profession about how they're recording their information. We're able to look at the different diagnoses for dogs and whether they did or didn't have antimicrobials, the same for cats. And the scale is different, so it's not like there's heaps of cats getting antimicrobials. And then we're able to look at, again, the different conditions that are being treated and then the different antimicrobials. And the nice thing here when we talk to some of our medical colleagues was that these are reasonably low importance antimicrobials. There's enrofloxacin in here and cefavecin. But there's none of the imipenems and meropenems and stuff like that emergency clinicians are quite concerned about. So I think that was really helpful for us to be able to demonstrate, not just assert, that we don't use these in veterinary practice. And we are able to do the same sort of thing with cats. And interestingly, when you look at the difference between cats and dogs, you'll see that there's a colour difference. The light blue is amoxicillin clavulanate, and that's in here as well. But the apricot colour is cefavecin and the reds are enrofloxacin. So there's more highly important antimicrobials being used in cats than there is in dogs. And I think this is it's a reflection of how difficult it is. Can I just get a quick hands up if you've ever tried to medicate a cat? And did you need a blood transfusion afterwards, or was your cat quite nice? Right. So cats are not particularly easy all the time to medicate. And so there's an antimicrobial, so cefavecin is marketed as Convenia because it's convenient. You can give it once in cats. It's highly protein bound, lasts for a couple of weeks above the MIC. Problem is it lasts for a couple of weeks more just below the MIC, and a couple of weeks more, a little bit below that, and a couple of weeks more. So it's not a great, it's good for the cat individually in the short term. It's bad for everyone else in the long term. So anyway, we were able to look at dose and to see how, and so these sort of vertical lines are the dose range in the guidelines. So we're able to see whether they were compliant with the guidelines. There's some underdosing. There was a bit of overdosing depending on the antimicrobial, which was interesting. And we're able to sort of, again, engage in a discussion with the profession. So all of our research primarily, though, was to establish a baseline. So this sort of linear approach to describing antimicrobial use. And in a learning healthcare system, that you need that sort of circular approach where you close the loop and report back. And as a university academic, I go, well, I'm talking at a conference, of course I'm closing the loop and reporting back. But apparently it's more complicated than that. It's that iterative, reiterative process. And so we were sort of engaging in that to say, well, can we use our data and the systems that we've set up to influence the use of antimicrobials in practice? Can we close the loop? And so Laura and Kirsten did a great job engaging with the Green Cross practices. And I gave this talk. The reason this has got the One Health program there, I gave this talk for Laura the other day at the conference in Singapore. 135 practices were enrolled in an antimicrobial stewardship trial. We initially started with 152 and we ruled a few out because they were new or they had staffing issues and what have you. We randomly allocated them into a control group, stewardship group 1 and 2, and then we went back to the regional directors and said, how does this work? And they sort of reshuffled a little bit, saying, I don't think this practice actually can cope with this, or this practice has too many turnovers and we'll move them around. So we eventually reallocated them into the control and the 2 treatment groups. This one size doesn't fit all. And I think this can be pretty much put across just about everything to do with antimicrobial stewardship. I think one size doesn't fit all. And I think you need to think about the system that you're working in. We looked at the different levels, and I'll run through these in more detail in a second, and Kirsten will talk about these in a lot more detail this afternoon. I'm just talking about what we did. Kirsten's actually going to tell you what the results were. So everyone got a guidelines poster. All of the 135 practices got distributed with a guidelines poster. We actually went around and make sure that some of them had their guidelines posters up, and that was quite nice. They all got access to various webinars from international and national experts in their fields to talk about the use of antimicrobials and stewardship and infection control. So that was sort of the baseline. Everyone got something. It's like step right up. Every child wins a prize. And then some people had to do some more. So the first level of AMS, the stewardship trial was to, they'd appoint a champion, changing the culture, leading the implementation. They had to implement a traffic light system, and Kirsten, Ri and Laura did some nice graphics. They decided that my level of graphical design was just, well, it was a low level, let's just say that. And so they designed these nice things. So there were coffee cups, there were stickers, there were little posters and what have you, and you can see in here that the posters went up. And I thought this was one of the things that was easily implementable. So they could put these little sort of posters up, they could put them around in consult rooms, and they then put stickers against the different antimicrobials as to whether they were lower level, medium level, high level, critically important antimicrobials. And so that I think was a really good initiative. We tried to incorporate diagnostic testing guidelines, and then at the higher level, the posters were able to be customised, and so we asked that the stewardship champion in the practice conduct meetings with the clinicians to sort of say, in our practice, we're going to do this with these antimicrobials or this with these sort of disease syndromes. And you can see maybe on the thing that these are actually filled in. That might have been the only practice that, no, there were some practices that didn't, but most of the practices that had to do this did. And then we wanted the champion to review the antimicrobial stewardship with some audit and feedback. And we were able to sort of provide them with some evidence that from outside, so looking at appropriate use, so local antibiograms. So Ri did a nice work and some nice publication here, looking at using this Vet Compass data to indicate that although this might be your practice in the clinical practice in your practice, the use of amoxicillin clavulanate or just amoxil or just TMS would be potentially an appropriate use as an empirical treatment based on what we'd seen in some of the culture and susceptibility of around more than 6,000 urinary isolates. So we're able to provide people with some data to back up as to some evidence as to support why we're asking them to do these particular practices. And then Amy's doing some work as well, looking at to see whether there are some barriers to people doing culture and susceptibility and providing their own evidence, but also she's going to be looking at doing the resistance and doing some whole genome sequencing on the isolates that she's getting from these urinary tract cases in these other clinics. So we're trying to provide that evidence base and then continue to do that reiterative type of process. We did ask in the higher level AMS2 groups that they ask permission from their antimicrobial stewardship before they used highly critically important antimicrobials. Apparently vets aren't altogether keen on asking permission. It might be around that horse vet thing, but these are all small animal veterinarians, but there wasn't a lot of uptake of this. 15% of respondents adopted the strategy, but those that did said it was good. And delayed prescription was the other thing we asked them to do. So just quickly, there were 135 clinics that were enrolled. Interesting, when you look at all of the consults, there was just under 250,000 consultations where systemic antimicrobials were used, but only 8 antibiotics accounted for about 94%. And so doxy, amoxil, and you can see the list down there. Thankfully, cefavecin sitting here at about 10% and enrofloxacin about 5%. So 15% of the consults had the highly critically important antibiotics that we're concerned about. And then the rest were sort of the medium or low. So overall, this is the high level results. Kirsten will talk to you a little bit more about the results, but there was an overall decline in antimicrobial use of about 50% over the period of the implementation of and the post-implementation period. Interestingly, in the pre-implementation period, just going around and organising it actually resulted in a reduction in antimicrobial use during the pre-implementation period. From the beginning to the end of the pre-implementation, there was a shift towards the use of lower importance antimicrobials from the high importance ones. And thankfully, the greatest impact of the stewardship program was seen in the high using clinics. So I think this was very reassuring to us. It's nice to know that stewardship actually can make a difference, and it can make a difference where it matters most. So again, with the learning healthcare systems sort of framework, Ri said, I said, tell me everything you know about this. She said, well, here's a nice slide. And I'm sure Ri knows heaps more about that, but I had to look at the slide. And I actually think this is sort of where we're at. It's serendipitously, we sort of found our way looking at the data from the practice, trying to understand how things are going. Can we change the practice with what we've known and what we're doing? And I think we're sort of sitting in this sort of area. And I think it was in some ways serendipitous, although Laura and Kirsten are much smarter than me, and that may actually be that me not understanding their design and driving the whole process. And me just being oblivious. So I think this is the sort of area that we're at the moment. And some of the work that we've been doing is sort of actually coming back and just using a natural language processing. So I'm going to go back to some of Brian's work because it's not published yet. But just identifying a digital phenotype. And I like the idea of the digital phenotype. So Brian was sort of interested in being able to use the data to define the patient's disease journey. So there were multiple consultations for most things. You know, you come in, you have a checkup, you have a follow-up and what have you. Sometimes the disease resolves, sometimes it doesn't. So he was able to look at the length of antimicrobial administration and understand the effect of the treatments for a given disease. And we used cat bite abscesses because we thought they were pretty readily identifiable. I do like cat bite abscesses. You can tell the fighters from the runners. The fighters get abscesses on their heads, and the runners get abscesses on their bum. And sometimes you need surgery to put drains in and what have you, just to keep the wounds open, because drainage is key for all management of all abscesses. But the guidelines suggest that, you know, if it's draining and there's no dependent accumulation of pus, then you don't really need antimicrobials. These things should go well by themselves. So we were able to sort of look at, and apologies for this, you know, I'll give you a minute to write this down. But Brian went through and looked at, you're going in for the consult, and he was able to sort of categorize the consultations based on, you know, whether it was the first consultation or it was a follow-up consultation, whether any action was taken, when the antimicrobials were prescribed, whether any surgical interventions were used. And he said there's, I forget how many of them there were, but he looked at 7,000 patient journeys, and I forget how many is in this group here, but he was able to group them into 9. And I said 9 was too many. And so he was then able to group them into 2. And it was so whether he was able to look at patients, whether there was antimicrobials plus surgery versus antimicrobials alone or no antibiotics, right? And then all the different scenarios that went in here. And then he was able to look at, which I thought was interesting. So given that it says that you don't need antibiotics, you can see how few cases veterinarians were comfortable not prescribing antimicrobials, antimicrobials only, and antimicrobials plus surgery. And so with the surgery, I think there's probably some more reason to use the antimicrobials because you're actually doing a surgical intervention, putting a drain in, all those sorts of things. But there's quite a lot in here that are antimicrobials only. Antibiotics dispensed, no additional antibiotics or surgery required, or 2 different antimicrobials dispensed. So again, with that sort of circular, iterative, reiterative approach, I think this is a good discussion to start having with our profession. He was able to look at the different antibiotics used, and then as to how long they were being used for. And you can see things like amoxicillin is here, and it was the lowest duration of treatment, whereas things like cefovecin, you give an injection of cefovecin, it's there for 2 weeks, and so it starts to become a bit of an issue. He was also able to group them into simple cases, which was basically just antibiotics or surgery, and then difficult cases where there was changes in therapy needed because of the animal's condition. And again, there are no antibiotics here. And again, able to look at the differences in terms of how long these antimicrobials were being administered for. So in one sense, we're able to start this sort of circular learning healthcare systems approach. The other way of giving feedback to practices is actually using the electronic medical records. And so Ri is very well connected in the veterinary world, but is also very well connected in the real world and has friends that are outside of veterinary science. So Adam and his team at Make Data Useful were able to, am I doing something wrong? No. Okay.
Natural.
Act natural. Adam and his team at Make Data Useful were able to get them a small subset of the Vet Compass data, and to see whether we can start to provide some sort of, maybe not real-time dashboard, but a dashboard that will give them some feedback. So 150 clinics, 500 different billing items, drug billing items, and 300,000 consults. We said that should be a big enough sort of, well, Adam said that should be a big enough sort of data set for them to be able to provide us with some sort of information, again, with the Vet Compass data. So they were able to get clinic ID, consultation ID, patient ID, the species, age and sex of the animal, and then the drugs and the breed. And so we're able to come up with some things there. And just as an instance here, so they're all systemic enrofloxacin. They were able to give them the ASTAG rating, the WHO rating, but these are all the different types of amoxicillin enrofloxacin that's available in the data set that Adam was given. So he's saying, you know, surely there can't be this many, but yes, there are. And so some of them were oral solutions and injectables and tablets and what have you. So he's able to class them all as enrofloxacin. Again, antibiotic consultations per 1,000 consultations, and to look at the sort of proportion, excuse me, the proportion of antimicrobials delivered, whether they're cats or dogs, and then this could be your practice, and you could start to see against this different states or what have you. So we're able to look at clinic by clinic, and so if we could, these are actually the clinic identifiers in the data set, but that doesn't really mean much to anyone else. And then looking at this, we'd be able to identify this is your clinic, and you can start to see that you're using more antimicrobials per 1,000 consults than everyone else, or fewer, or what have you. And then I think the nice thing that I was really impressed with when Adam was presenting the data was this is sort of level of use, and this is the proportion of highly critically important antimicrobials. So this is the area of the graph that you don't want to be in, where you're using lots of antibiotics and they're all highly critically important. These are the ones here where they're using not so many antibiotics, and then not so many of them are highly critically important. So I thought this was a really nice way, and the size of the circle reflects the actual amount of antimicrobials that you're using. So there's 3 different measures in there of antimicrobial use that we're able to provide feedback to the practice. So I thought this was really clever. So just to finish up then, can a learning healthcare systems approach be applied to antimicrobial use, antimicrobial stewardship in veterinary science? The answer is probably, and fingers crossed, and hopefully in some future antimicrobial awareness weeks, we'll be able to sit and talk to you about what worked, what didn't work, and go to from there. So you said 30 minutes, it's 31. So thank you very much. Oh. Best acknowledge all of my collaborators too.
James is going to be on the panel discussion actually, so we might deep dive into some of these issues when we're on the panel, and we'll bring Wendy up once her talk's set up.
Yep, it'll just take me a second just to
Now you
load.
see what I mean. Now you see what I mean when I say the vets have come up the back straight, because it's very impressive, isn't it? You know, so many things that they've done. I have reflected back on even the coloured stickers in the dispensary is just great, right? So simple.
Yeah, we'll just camera on, share screen, desktop. Oh, that would probably help if I put that on as well. And then I'll just make this. Small.
Are they seeing this?
No, no, they're
they're seeing
sharing,
that?
they're seeing
Okay.
that one. I just need to move that out of the way. Sorry, one sec. I need to make it smaller first. I'm getting quicker.
Yeah.
Okay.
Thank
Take
you.
it away, Wendy.
Okay.
Thank you.
Oh, thank you for your patience. And I'm really happy following that talk because it's so excellent. And if I would have known though that I was following your talk rather than starting it, I would have put pictures of my 3 huskies throughout the presentation, but now you're just going to have to imagine them. Okay. And I did have a lot of flashing thoughts about career changes. And is it too late to go into the veterinary space? All right, well, this is the third learning health systems cycle, the version of it that you've seen so far this morning, and I'll show you another one later. And they come in many different flavors, but we all know the basic idea of data to knowledge, knowledge to practice, and then practice to data. And I want to talk a bit about an informatics powered learning health system. What does that mean? And this is a theorem of biomedical informatics, where the human plus the computer plus the scientific method are greater than the human alone. And so I think all of these ingredients are part of what I would call an informatics powered learning health system. And an example, and I know Kaz knows about this, and maybe many of you also do too, but I trained at the University of Utah, where I got my PhD in medical informatics. And I worked at LDS Hospital there, and they installed their first electronic medical record in about 1960. And had decision support, had it for decades. And so Scott Evans did, develop the system called the Antibiotic Assistant that would run in the background when a patient was hospitalized, and you're already collecting all this data, and it's secondarily, monitoring the data to see if a patient got a nosocomial infection, while they're in the hospital. And then it would alert the physician. It would also suggest the best type of antibiotic based on their age, renal function, et cetera. And the physician could drill down and accept it or change it, but also act on it. And so this is an example of gathering data, getting insight from it, that maybe there's a new infection that the patient has, bringing that to the clinician to the point of care to practice and making it actionable, and then collecting information afterwards about the outcomes of the patient and learning from that. They were able to show that it improved care, it decreased length of stay, it decreased costs, and it was improved experience for both the physicians and the patients who had fewer adverse events and fewer excess drug dosages. And so this has been scaled across many hospitals in the US. I put that up there because I see someone's taking a picture. So Scott told me a story that after this was published, he received an envelope with a blank CD in it. And it was with a letter from a woman in Florida who said, my husband's going into the hospital for a knee replacement. And I heard about the antibiotic assistant. So I called my hospital to see if they have it, and they don't. So would you copy it onto this CD? And then I'm going to give it to my doctors, because I don't want him to, get an infection that goes unobserved in the hospital. And so this is just like your software patch. This is what we want, right? But it's so much more complex, and the environment really matters in where you're doing this, because your data is different, your workflows are different, everything's different. And so it's really fantastic to see the great work going on in Australia in this space, that it is not, just mimicking what other people are doing, but it's learning from it, and then it's adapting it and growing it and doing fabulous, fabulous work. So, I want to just show a few examples of things that have been done on the different parts of the cycle in the learning health system that I think are inspiring. So one is you've got clinical practice, and from practice, you're generating data. And so how are some people using that data? This was an exciting project at Stanford by Chris Longhurst and Nigam Shah called the Green Button. And this is based on the idea that, you know, a lot of the decisions that clinicians make are not relevant. There have been no clinical trials that, you know, either for that population or for that condition. And so you're making a lot of decisions without evidence. But there's a lot of information in the electronic medical record about patients who have been treated with anticoagulation or not, or this type of anticoagulation or not. And couldn't we learn from that to help make decisions for our own patients? And so the green button is you put in a request, you know, here's my question, and here's the patient, the information about the patient. And now within a few days, it takes a few days, but they mine all of the records and they find patients like your patients, and they show the outcomes based on the different interventions that can now inform your care of that patient. Well, then you've got data, and how do we gain insight from that data? Some of you probably know about this by Ronaldo Bellomo at the Austin and his team in using EHR data to do pragmatic randomized clinical trials. And so to be able to test for things that you're never going to do a clinical trial on. And there's so many choices that are made that you're not going to do clinical trials on, but you could do those retrospectively and potentially also in a more forward-looking way, you know, prospective way, to answer questions like, you know, should we have low tidal volume or conventional tidal volume for these types of patients? Another way that people are using data that's already being collected for care is to monitor and redesign the processes of care. And this is work that Daniel Capurro, who you'll hear from later on today, and is the Deputy Director of the Center for Digital Transformation of Health, did in Chile, looking at the processes of collaboration. And so, you know, no additional data is collected. This is already in the electronic medical record, and being able to see that diabetes patients who are cared for by teams that collaborate more have better HbA1c management. When you gain that insight, then how do you put it into practice? I also really loved those stickers, just these really practical ways to help people quickly apply that insight into practice. Lots of research about how to do that. And this is a study by Guilherme Del Fiol, and acknowledge him for the slides. He looked at clinical questions that clinicians have when they're with patients. And for 20 patients, they have 12 questions that they don't know how to answer. They pursued 6 of those on average and answered 4 of them. So many unanswered questions at the point of care. And that's because there's not the time to be searching the literature and the guidelines and, you know, for every question that you have. And so this was developed in the late 90s, I think, the info button, and it's been deployed across the US. It's in Epic, it's in Cerner, it's in the VA, the Veterans Administration system. And so if you click when you're, you know, prescribing a medication, for example, and if it has a little I next to it, you can click on it and it will ask questions of your database that you point it to. And that database may include PubMed. It may include local guidelines that you want to follow, whatever that database is that you want it to follow. And it will pull information about that for you. And that information is personalized because it knows, because you're doing this in the EMR, it knows the patient that you're working with, how old they are. It knows their diagnoses. It knows who you are and what your specialty is. It knows what you're doing. Are you adding to the problem list? Are you ordering medication? And it knows about your healthcare setting. And so it formulates a question when you click on that info button, and then it goes out and it pulls the data and highlights the places that are, you know, relevant for that, to bring this knowledge from research to the point of care. And so they showed that if physicians that were using info buttons took about 35 seconds to answer their questions, compared to 2 to 8 minutes for unaided search, and answered, you know, more of the questions. This is a really cool project at New York University, and based on the idea that there's quality improvement going on everywhere, and we're constantly implementing new techniques, but we often don't measure how well they work. And so we keep investing in things that might not be working, and we could, in theory, reinvest those in new things. And so they implemented this rapid cycle randomized practice embedded trials. And so if you say, you know, we wonder if we're going to implement something to send out letters to people to remind them, or emails or texts to remind them of an appointment. And in theory, that should result in fewer no-shows, right? But then they often don't measure it. And so you randomly assign, you know, some clinics to sending out the text messages and other clinics not. And within a few weeks, you can start to see, is this actually helping or not? And then make decisions about whether to continue it or grow it or move on to something else. So I want to particularly address, you know, what's the university's role in the learning health system? And it's the healthcare organizations, the veterinary organizations that are doing the healthcare delivery, but those clinical needs can be driving, you know, the problems that researchers can help solve and partner to solve on. And what researchers bring, they bring methods like natural language processing. They bring education and training, and they also bring, you know, the helping with the infrastructure and the processes to validate the things that are being put into place. And so I see this as a really synergistic partnership where it's better when we're working together. At the Center for Digital Transformation of Health, our approach to building learning health systems in Melbourne, it has 3 pillars, and one is training the workforce. The second is research-ready data and infrastructure to help us, it's the D to K part. And the third is the knowledge to practice part, which is how do you develop, implement, and evaluate new interventions. So I'm just going to say a bit about the training the workforce, and we have a short course that some of you have already taken or are in right now, and that's the Applied Learning Health System short course. It's a 12-week course that's to help you really dive in more deeply to learning health systems and how they work. And then we have an academy, which is a fellowship program. It's a year-long program where people are selected from their healthcare organizations to grow as digital health champions. And we work with them on their projects for a year. And so we're just getting the names of next year's cohorts and finishing up our first year of that. But I really want to focus the rest of the talk on the knowledge to practice part of the pipeline, because this is where we've spent the most time. If you're developing a new drug, it's very clear to everyone what the process is to get that to market. Everybody knows what to do, what to measure, and it's there's no questions really. But in the digital health innovation, there's a big gap. Nobody knows how to get it from that idea or that prototype into practice for evaluation. It's very rare that that happens. So we're developing something called the Digital Health Validitron. And that is to help, it's a set of processes and tools and methods to help you go through that gap of, you know, exploring different possibilities and what the problem is and how to solve it, designing solutions, prototyping them, and then testing them. So I'm going to using a case study of remote monitoring as I talk about the Validitron. And then the explore phase, here's another learning health system diagram. This is from Monash Partners. And this is a very different type of diagram, but I think it's really fabulous in the type of evidence that you need to gather as you're going through the learning health system. And so the first quadrant is about the stakeholders, and it's learning from the stakeholders and you know, engaging the partners, learning about their priorities and their needs and their pain points. The second quadrant is evidence from research. You know, what's already been done in this space? Are there guidelines for this? And it seems obvious to researchers that we would do this, but if you look in, you know, clinical practice, this is not always done. And you reinvent the wheel and solve problems that maybe aren't even problems. The third quadrant is about pulling evidence from data. And we saw that in James's talk, you know, lots of work up front about what is the current situation, where are the problems happening, and developing that infrastructure to collect that data. But of course, this is all going to be iterative, and you might collect very shallow data in the beginning that would help you, you know, design the initial solution. And then you go back and you collect deeper data depending on where you're at in the cycle. And then the fourth quadrant is the implementation. It's really seeing how is it working now? What are people doing now? And so I really like this model for the explore phase when you first have a problem, to really think about what that problem is. And then you start to say, okay, now I want to design a solution. And in designing that, you want to think about it, you know, is your solution desirable? Is it feasible? And is it viable? You know, how is it going to be funded in the long run? Is it going to fit into the workflow? All of those types of questions. Oh, and somehow this slide got all screwed up. But you want to ask things like, what are the implementation enablers and barriers? And we saw that in the previous talk of, this clinic won't be able to manage that, so let's not do it that way. What do decision makers want measured? What value are you trying to demonstrate? What do you really want? What do you want to measure to demonstrate value? What's the workflow that this is going to fit into? Do you need technology? Not everything's a technology-based solution, but some things technology could be really helpful. And how do you avoid increasing the digital divide as you do this? And so we are using a framework called the SARIS roadmap. This is a fantastic framework that really talks about the stages that you go through in design and validation, but the really practical things too, like the business model and the value drivers. And so we're building the Validitron using multiple frameworks, but this is our core framework that we're using. All right, so then you decided what you're going to do, and now you want to start prototyping it. And so there's lots of great work on co-design and prototyping, with paper and getting people's ideas. And so that's a really important first part of it. But what we've developed is something that takes you from this part of the prototyping into environments that are more real, closer to the real environment. Because we believe that as you do that, you're able to uncover kind of the hairy points that will, the gotchas that you might not realize when you're sitting in this room brainstorming with your sticky notes. And so that's the Validitron sandbox. And this is a virtual environment where you can run demos, you can co-design, you can develop, and you can test from the very beginning of your prototyping new ideas that have digital innovations. And it's based on the idea that you have this app, for example, or you have this decision support system or this dashboard, but it's going to fit into some environment that's already there. It might be, interfacing with the electronic medical record. There might be a remote monitoring app that the patient has at home. There's all kinds of different scenarios. And so you want to pull together that environment and mimic it as well as you can. So as you're doing your prototyping of your new intervention, you're seeing how it fits into the workflow and developing the interfaces, the data exchange interfaces for those. And so it's based on this idea of like Lego bricks, and you're able to drag and drop the pieces that you need to do your study. So for example, with remote monitoring, we built this example with Northern Health on their virtual ED. And so you have a patient who's been sent home with a pulse oximeter, and she has COPD and a couple of other comorbidities, and she's kind of a frequent flyer to the emergency room. And so she's part of a program where they send her home, and she has this app that collects her information and her symptoms. And then if she starts to decline, then she's supposed to call into the virtual emergency room. So she sees some declining values on her oxygen saturation. And so she calls into the telehealth virtual ED. And so this is all, simulated, but they're real apps inside the Validitron sandbox. And so she logs in, and this is what she sees. And you are able to put your own apps inside here if there's things you want her to do while she's in the waiting room, for instance. So you might ask her to fill out a survey of her symptoms, or a COVID survey, or a mental health survey. There's all kinds of things that you could do while they're in the waiting room. Now this is what the physician sees, and she sees a waiting room and a queue of patients, and she can see that for Casey, there's some data that's available and so she could look at that data before the visit, before she brings Casey into the telehealth room. And so she signs on to be able to access the data. And now she can see the heart rate and oxygen saturation levels. She can drill down, and now she's kind of prepared so that when she brings Casey on, she knows what's been going on. And so now she joins and brings Casey on, but she also wants to share that data with Casey and talk about it together. And so she pulls that into the telehealth visit, and we could do this on Zoom. We could pull your remote monitoring data and we could put it into our Zoom window. There's the capabilities there. And so, but people don't know it's there. And so this is, it's also in this prototyping of digital solutions, a way to really experiment with things that you may not have even realized you could do, and to show people things. But that now the physician and the patient can be on this call together looking at the data, and we can evaluate and have them, you know, give feedback on, is this useful? Is this visualization useful? Did it come at the right time? What's the right workflow? You can look at the survey that she filled out. You can use real apps, or you can drag in wireframe kind of Figma drawings into it so that you can do this, you know, quickly and iteratively from the very beginning. So you're really thinking about how this would work in the real world from the very beginning. All right, so along with that, we have a physical simulation lab in Melbourne Connect. And if you want to do a tour, let us know. We're happy to give tours. And this has a hospital room, a GP or outpatient clinic, and a patient home. And the idea is now you've got the patient and his pulse oximeter there on the left side of the screen. You've got the GP on the right side of the screen, and we can see both of them through the windows. And on those computer screens, we can see what they see on their computer screens. And so if you're simulating using this virtual emergency room telehealth app that views the remote monitoring data, we can, you know, record and have, this is a real GP and a simulated patient, to really look at, you know, for the GP, is this workflow working? How are the interfaces? Are you seeing the data that you want to see? Is it actionable, et cetera? So that helps you really prototype in a more realistic setting so that you are prepared to put it into the real setting and do the evaluation. And so then you work on the evaluation. I'm not going to talk about this because a couple of speakers later, Olivia and Hassan, are going to talk about digital health angle for evaluation. So in conclusion, I really like this book, The Digital Doctor. If you haven't read it, I highly recommend it, even though it's not brand new. I mean, it's a good 10 years old. It's still very relevant about, you know, when you put digital interventions into healthcare, it's not just replacing the font or, you know, replacing the paper with a digital form. It's transforming everything that people do. It's transforming the work, the relationships, and with patients and with clinicians. And so you really have to think about that when you're developing interventions and going along the learning health system. And if we think about, like, what are practical implications for antimicrobial stewardship from this, is, you know, when you're translating this knowledge to practice, you know, looking at exemplars that other people are doing, but the context is really critical so that what you're building fits the people that you're working with. And that's why we need these ways to prototype and try out new things. That technology can be and often is a really important part of your new interventions, but it should be seen as an enabler and not an end in and of itself. And that the scientific method is a really important part of it, because you need, if you don't have rigor, you're making decisions that are often less than optimal. And so you got to have rigor in your design, in your validation of what you're doing with the users, and in your evaluation about whether it's really providing the outcomes that you hope it is. So thank you for that, and thanks for your patience.
Thank you. So we have got some time for questions before morning tea. So I invite our participants online to pop some questions into the chat.
Yeah, I'll stop the share.
It's so inspiring every time I hear you speak, Wendy, because, you know, I remember my own research career. I talked to Wendy about this, started on the back of the Evans paper, because it was described by the editorials that the antibiotic system was going to be the holy grail. And of course, I thought, wow, this is so amazing. Can we buy it and put it into Royal Melbourne Hospital? And of course, it just wasn't possible. And hence my own journey with developing clinical decision support systems. And, you know, you may or may not have heard me talk about this before, but the very first thing I did was to put in a human factors engineer and psychologist called Michael Mayamoff. He's off making squillions with London banks, I think, these days. But anyway, I said, can you go into the intensive care unit at the Royal Melbourne Hospital and come back and describe to me what are the processes around antimicrobial decision making in the ICU? And he used a methodology called contextual analysis, which it was previously applied in businesses. And what I got back was this incredibly complicated diagram with lines going all over the place, and the patient wasn't really in the center here. But it really highlighted to me how complex it is to go from a real live prescribing environment to then creating a digital solution. After that, we did a lot of work in prototyping with multiple stakeholders in the RCU and in ID, trying to understand what it was that they actually wanted. And it turned out that the thing that they actually wanted was the data coming to them in a way that was going to help them make decisions. Because at the time, the residents, this is pre-EMR days, would spend 1 to 2 hours collating information before every ICU round. It was 2 rounds a day. So it was at least 2 hours a day of writing and transcribing, creating lists around their specimens and tests to make the decision about the antimicrobials on their rounds. So then I was very fortunate to get a very young hacker developer who called Brongon Wana. Again, he's often a CEO and, you know, some big thing these days. But what he did was actually use Perl script to pretend as though he was running reports out of a pathology system. We extracted data, represented it in a very simplified tabular way. They could see all the positive, negative results, the sensitivities. We had the antibiograms, and it was groundbreaking for them because it actually reduced that time down to a few minutes to visualize. And with decision support, negative information is just as important as positive information. So seeing a negative blood culture is equally as important as a positive blood culture, right? And so here we were, you know, and then I've spent months and months writing knowledge algorithms to assist with choice of antimicrobials based on pathogens and combinations. And if I reflect back on my experience back then, and I think, well, was my time well spent hand coding decision support for the ADVISE program, which is what it was called. This is pre-guidance. I think it was actually the data visualization piece that was the most profoundly impacting for that system. And so that was really my learning in how important it is to assist decision making. That is where our efforts should go, I think. And it is a holy grail to develop decision support that might be predictive, et cetera, but you know, this is something that we've really been very involved in with guidance, because there's a slippery slope between what is a supportive decision support versus a medical device. And a medical device is something which is a decision making that actually directly influences patient care, that may not be so transparent to the prescriber as to how that decision is made based on the technology behind it. So that was my piece. I don't know whether you want to comment on that, Wendy.
I just love that story because it's the one size fits all, and it's really understanding that workflow. And it made me think about the stickers, which I already said I love. That what if you said, oh, let's build a digital way for them to know that this is high, medium, or low, and but then you didn't look at their workflow, and their workflow is they're going to the shelf and they're picking one, not their, I mean, I don't know, maybe they do, but like you really have to know what's going on the ground in order to, and then work with them to figure out how to solve the problem together. It's not one size fits all, and that's why everyone wants some great AI tool or thing that an NLP that you pull off the shelf and plug in, and it just doesn't work.
Any comments or questions from the audience? Yeah. Anna. Yeah.
Well, I was just thinking one of the things that is and people are I was just thinking, how do we make sure that having doesn't detract from people in this because there are people that carrying out this directly as an environment or like for life.
That's a really, from my point of view, that's an interesting observation, because both a GP and a vet is unusual, because not only are you looking after the patient, examining them, but you're also actually prescribing and taking the medication yourself. So you provide a complete holistic service yourself. GPs, of course, examine the patient, write a script, and then they go out to community GP, of which there is an opportunity for further information sharing or decision support. And Sajal Saha, I don't know if he's here today, but he did his whole PhD on whether there is a GP community pharmacist model for stewardship. Are we engaging our community pharmacists effectively in antimicrobial stewardship? I suspect not. And you would have seen the headline news last week about pharmacy prescribers being able to prescribe antimicrobials in New South Wales. Now, my personal opinion is that in many ways, in all my years, pharmacists are incredible. And in fact, their ability to adhere and manage and drive protocols, I suspect that they're going to be very good prescribers, but it's challenging to the medical profession for how that might pan out. And I think we need to think about those models. And in fact, in the UK, in practice, pharmacists are a key part of their national strategy. And we don't have that yet, but I actually think that's really important. Similarly in aged care, So, and then in hospitals, of course, care is disaggregated across multiple people. And that's why for hospital stewards, hands up if you think it's like herding cats trying to do anything in your hospital. It sounds stewardship, right? It's actually quite hard, isn't it? And so how do we bring all the key stakeholders together? Surgical prophylaxis is a perfect example. It's a completely different domain and requires different intervention and skill sets.
Yeah.
I don't know if that answers your question, but I think vets are particularly unique.
Yeah, and I think it's a really important question. And I think the key word is support. It's decision support. It's supposed to support you. And so being able to co-design that and how that will work, but also having kind of an open mind, like knowing it's going to change your workflow and thinking about what's really important to keep and what's not important to keep. And if you look at quotes from the past of like when the stethoscope was introduced and how everyone, it sounds like people talking about AI now, this is going to take away all the, all the great skills that the physicians have. And anyway, and it's just a stethoscope or even a thermometer. Like all new technologies confront and change what you do. And so be part of the design, but with an open mind.
James.
Most consistent, the only whole area is the composite. Then you have to think about the network that you can afford that they're not giving you more work. They're giving you work without something that you do. But you may even do the right thing. You don't do that. And the things I like that for the fun and for the red is offshore. Put away the step up.
Oh, yeah.
So, and
For those people online, James Gilkerson's talking about needing a step ladder to get to the highly restricted antimicrobials in the dispensary. But no, that just made the comment that one size will never fit all, actually.
But making it easy to do the right thing. That's what decision support should be doing.
So I want to make a plug for the Learning Health Systems short course, actually. So not only is there the Learning Health Systems Academy, where at the moment it's been offered to hospital and general practice candidates, and we have had a couple go through Peter Mac, and we're about to have another couple start this year. But part of their academy is doing the 12-week short course, and have a show of hands of who's done it here. We've got quite a few. So I am pretty much recommending all my clinical staff do the short course. The reason why it's important is because exactly how we've talked to you today, understanding the challenges that you need to take into account when you're doing an improvement activity. And it definitely translates so well to antimicrobial stewardship, which in fact is very learning health focused actually. In fact, maybe we're the original learning health system practitioners, I suppose. So I guess, you know, Anna, who's going to be talking later, do you want to talk about how you found it important? It's a very, very cost-effective course. It's really not an expensive course to do. It's a community of practice. You work, it's both participatory in groups as well as fantastic resources and workshop. It runs over 12 weeks, and I found it fantastic for me in my learning, and I would strongly recommend that if you're interested in doing something which is really targeted to the things that we need to know, I would encourage you to enroll. And it's run twice a week, isn't it? February,
Once a week,
twice
twice a
a
year.
year. 3 times
It's
a
going to
year.
be 3 times. a
3
year.
times a year. Oh, so definitely.
No, maybe it's twice. I'm not
maybe
sure.
it's twice.
I do have slides from the Senate, like, so during the morning tea and lunch break, I'll have them up for people
Yeah.
online to see and screen.
Okay, great.
Anna, do you want to make a comment on how you found it?
While you're doing work, kind of going along and doing the courses, I actually inadvertently followed the learning but the course helped to perform like what we were doing and to improve the way that we make it more scientific and less rapid. And I think it was really, it just followed our journey.
Yeah, great.
Awesome.
There is a question back there.
Oh, yes, Tabish.
Whenever they are talking about developing prevention or change or design, they encourage all the researchers to come up with an established tool either from healthcare or from non-healthcare disciplines. Because what we found over a number of years that if you develop an intervention that is based on a response tool, the chances of success are quite remarkable. What's your position in the sense about 3 days?
I'll just repeat that for the people online. So Tabish Saidi, who welcome today. So Tabish has been a long-standing colleague and a stewardship expert who's spent quite a bit of time in the NHS in Leeds, has asked about or has made a comment that in the NHS that they support theory-based interventions underpinning new innovation, and was just asking Wendy her thoughts.
Yeah, I mean, I completely agree. And that's, so the learning health system is one framework that we're using. And like you were describing, like just having that framework and that language, it helps you enhance and really be more rigorous in what you're doing. And then we're using all different types of frameworks in the different parts of the Validatron. And that's really what we're doing right now, is really pulling together all of those so that we can build out the processes, kind of synthesize them. So I think it's really important.
And the other thing to mention about the Validatron is that the sandbox will actually have an EMR, a full EMR to play with. So those of us engaged in digital design and development with, you know, our team with the NAPs and guidance, will have the opportunity to look at how we can more closely integrate them, which is really exciting. So,
Yes.
Alrighty. Well,
Okay,
thank you
so
everyone.
much.
Thanks, Wendy. Thanks, Kaz. There's no questions online as yet. So I think everyone has earned a nice break. So for those of you online, I'll share those resources about the learning health system. Go for a walk, stretch your legs. And for those here today, there is some morning tea provided back up there. So we'll start again in 30 minutes. Thanks, everyone. So, yeah, I will. So we're very fortunate enough to have Lisa Hall chairing the next session. Lisa is a wonderful colleague of the NCAS, the NCIC, Peter Mac, University of Queensland. She does a bit of everything. She's joining our Melbourne health team as an epidemiologist. So she's very entwined with all things NCAS and the NAPs now. So we're very lucky to have her here today. I'll just get Anna's slides up and
Great.
then we can go from there. Okay. Oh, stop, it's actually working. Let's go.
Right, well, my name's Lisa Hall. I'm both an epidemiologist and an implementation scientist. So this is really exciting for me, the whole learning health system thing, because I've been doing this for decades, but we never had a name for it until the last few years. But, you know, the important thing for me is really seeing real life examples of how we're doing and embedding this research. So I'm thrilled to be here today, chairing two sessions. One, we've got three amazing talks in our data to knowledge part of our cycle. And then we've got a really fascinating panel. And so as we're starting to process the talks in our minds from this morning, come up with some good questions for our panel around how, you know, you can see this working in practice, and all those burning questions that I'm sure that will come to you before we get to the panel session. But without further ado, I'd love now to introduce Anna Khanina, who's an experienced clinical pharmacist and early career researcher specialising in quality improvement for antimicrobial prescribing and management of infectious diseases in hospitals. Anna's our guru in all things antifungal, and she's now starting a PhD with the National Centre for Infections and Cancer, but has also been leading the redesign of NAPS to include an antifungal module. So over to you, Anna.
Thanks, Lisa. So today I'm going to talk a little bit about how we have gone about, I guess, creating an evidence-based way to translate data around antifungal use in hospitals, to gather that data and to make it translated into meaningful knowledge. So the antifungal NAPS, for those of you who don't know, it's a deep dive quality audit around the quality of antifungal prescribing in the hospital setting. And we, up until now, we didn't have anything locally that was available that really allowed you to focus deeply on antifungal prescribing. What I'm going to talk about today is I'm going to talk a little bit, just for some context, around what antifungal stewardship is and why it's important. I'm going to talk about what guidelines exist for implementing antifungal stewardship and the importance of using data to create knowledge and to change practice. I'm going to talk about how we at the NCIC and NCAS have worked to develop an evidence-based quality audit tool. And I'm going to talk about how that tool, the antifungal NAPS, can be used to generate data. So why is antifungal stewardship important? So firstly, invasive fungal infections, they're relatively rare infections, but when they do occur, they have really big impacts on our patients. They have a high morbidity, high mortality. We are also, as time goes on, seeing increasing groups of patients that are at risk of invasive fungal infection, more patients being diagnosed with cancer and undergoing immunosuppressive therapy for cancer and other reasons. And therefore, we're seeing greater use of antifungals for both treatment and also prevention of fungal infections. When these patients do develop an infection, it can really impact on their underlying management. So if someone is undergoing chemotherapy, for example, we suspect they have a fungal infection, you might need to reduce the intensity or delay or slow down their chemotherapy potentially. And that not only impacts on their infection management, but also their cancer management. So we want to make sure that we're treating these infections optimally and preventing them wherever we can. We are starting to see increasing antifungal resistance. And we only have relatively limited treatment options for the treatment of invasive fungal infection. There's not too many classes of antifungals. There are some new drugs on the horizon, but not too much coming up. And these agents, we know can be quite expensive, and managing an infection in hospital is quite costly. So we want to make sure that we're optimizing our use and reducing the cost. There are also limitations to the use of antifungals there that can be tricky to use. There's lots of drug interactions, lots of contraindications, lots of pharmacokinetic issues that you need to consider for patients, where stewardship becomes really important. And we do know from international studies that the quality of antifungal prescribing is variable and it can be quite low. There are some studies that have shown only about a 30 to 55% appropriateness rate of prescribing, and some problems that have been found internationally in studies, things like prolonged duration of empiric therapy, prolonged prophylaxis, high rates of drug-drug interactions that aren't managed well, inappropriate selection of drugs, and people that are not prescribing the correct doses, for example. So what is the goal of antifungal stewardship? It really is to optimize the use of antifungal agents. In order to improve patient outcomes, of course, we want to reduce the adverse sequelae for our patients, ensure cost-effective therapy, and conserve the agents that we have available to us today. And this very much aligns with antimicrobial stewardship as well. And there are guidelines that have recently been published for implementation of antifungal stewardship in hospitals. There are these guidelines published in 2020, international guidelines for core recommendations for antifungal stewardship, and then Australian guidelines as part of the Haematology Oncology Consensus Guidelines for antifungal prescribing. There were guidelines around antifungal stewardship as well. And what was common amongst these guidelines is that they really do focus on the importance of utilising data to drive quality improvement. And they say that the hospital should audit antifungal prescribing and management of these infections and utilise that data to be able to drive quality improvement. But what they don't talk about specifically too much is how to do that. So we want to translate that into practice, I guess. So what we first did was we went and had a look at the hospital NAPs, something that a lot of us will know very, very well and have done every year for many, many years now, to think about, well, can we use the hospital NAPs to look at the quality of antifungal prescribing? And what we found was that the point prevalence methodology for the hospital NAPs only allows us to look at a relatively small volume of antifungals for that particular audit. You're only going to get a handful of patients on prophylaxis, probably in your haematology ward. You might get a few people on being treated for infection. You can also only assess the patient's treatment at one point in time. So we don't know what's happening through their journey. When they come into hospital, perhaps they're on prophylaxis, then they become unwell, they start empiric therapy. We do some investigations and it might either stop or continue towards directed therapy. And we're not able to follow that patient's journey and their antifungal prescribing journey with the hospital NAPs as it is at the moment. We also don't collect data on patients' history and their risk factors for infection, so it limits meaningful data interpretation and local action. There are some metrics that are missing specific to antifungals, such as has therapeutic drug monitoring been done, were there any drug interactions, that sort of thing. And we don't currently correct outcome metrics in the hospital NAPs. So it limits the ability to monitor things like the rate of infection in our patient groups, breakthrough infections, mortality, that sort of thing. So what we found was that unfortunately the hospital NAPs isn't quite enough for us, and we needed to develop or to look for a deep dive audit specifically for antifungals. So this is our development process. We started off with a literature review. We wanted to see what quality metrics exist, what audit tools exist, what methodologies are there. Can we directly implement them in our practice here? And what we found was that there's a lot of metrics that are being used around consumption of antifungals, also the quality of antifungal prescribing, so many different types of metrics that are being used, and also patient outcomes. So when you look at the literature, you have such a large diversity of measures that have been used, methodologies that have been used. It makes it really hard to compare between different hospitals, even within one hospital. If you do the audit slightly differently from year to year, it's really hard to compare. So we really felt that there needed to be clear guidance on the comprehensive assessment of antifungal prescribing that didn't necessarily exist. So what we wanted to do is we wanted to develop an evidence-based way to do that. We don't want to just add another type of audit to the literature. We wanted to make sure that ours was evidence-based and was high quality and could be used nationally and also internationally. So the first thing we did was what's called a Delphi study of international experts. And what this what we aimed to do with this study was to achieve international consensus on a core set of metrics that were important for monitoring antifungal prescribing. We looked at consumption metrics, quality, outcome, and we also wanted to know whether or not collecting these metrics were feasible. It's important. It's one thing to say, yeah, this is good to collect, but can you actually do it? So the way that a Delphi study works is that you have a facilitator, and that's us, the project steering group, I guess. We have a group of experts. We had international experts, people that were had published in the area of antifungal stewardship or worked closely in the area of invasive fungal infection management. And we asked them a set of questions. So do you think that these metrics are important? Basically, yes, I think it's very important, or not important at all. They gave those answers back to us through a survey. We analysed that data, and then we sent it back to the experts. And we said, in the last survey, 30% of people thought that this particular metric was important. Does that change your opinion? And so we start to narrow down opinions. But the good thing about this method is that it's anonymous, and it prevents having one or two really dominant, strong voices in the room that are guiding everybody else. So you kind of keep going through this process of gathering responses, providing feedback until you come to your pre-agreed consensus, and then you produce a final report. So to do this, you start off with a literature review. We extracted what metrics existed in the literature. We had a steering group of experts that came together to create sort of a final list of metrics. We sent it around for the first survey to look at importance. We then confirmed importance with a second survey, and a third survey to look at feasibility and barriers for implementation. So I won't go into too much detail about what the results were, but we had a list of about, I think, 38 metrics that were found to be important. And a lot of these, encouragingly, in the quality area, aligned with what we already had in the NAPs, which was encouraging. But then there were additional metrics that were specific for antifungals that we didn't already collect. For example, appropriate prescribing in the context of drug-drug interactions, or appropriate prescribing in the context of contraindications, whether or not antifungal prophylaxis was prescribed in a high-risk patient. So it gave us insights into new metrics that we should be including that are not currently in the NAPs, and things like therapy drug monitoring. We also had outcome metrics and that sort of thing as well. Overall, there were 38 metrics found to be important. 21 of them had moderate to high feasibility. And it really kind of set a framework for us. So we knew what questions we should be asking when we went on to develop our own antifungal NAPs around the quality of antifungal prescribing. So after we did the Delphi, we then came together and did a lot of co-design work with experts in the area, with pharmacists, with clinicians, with epidemiologists, to develop the content of what the antifungal NAPs, what the questions would be, to define the questions, make sure that we had a right balance, so that we were asking enough information, but also not overwhelming people with too many questions. We developed it with the wonderful team at Guidance. We then piloted it across 8 different hospitals who tested out the methodology, the usability, gave us a lot of feedback, and we've had to kind of go back and fix lots of things up, and we've produced our final antifungal NAPs. So what the antifungal NAPs looks like today, based on those processes, is we have a really flexible audit methodology. You can audit, drug-based audit. You might want to focus on a particular unit. You might be interested in what's happening in your hematology unit, or you might be interested in an indication like what's happening with our candidemias. You can assess each phase of prescribing, as I spoke about before. You can look at prophylaxis, empiric and directed for one patient as they go through that journey. You can gather detailed patient information and risk factors, so you know what immunocompromising condition they have, how it was managed, and you can stratify their risk. And that helps us to analyse the data in a more meaningful way. We have some new quality metrics that came about from the Delphi study. We have some new outcome metrics that also came about from the Delphi study. And we've developed some reporting and benchmarking, or are developing reporting and benchmarking. And if you've done the hospital NAPs, you'll recognise this. It's a appropriateness assessment matrix, which I think is so important. And we've updated this to include specific things for antifungals. So we've gone about creating all of this, but do we know if it's a good audit tool? I guess is what I wanted to know. So we wanted to validate it. We wanted to make sure that what we've created isn't just going to add noise to literature, but it's going to add value, and it's going to be something that can be used consistently and accurately between hospitals, between different kinds of clinicians from year to year to year. It's going to be a consistent tool. And we can't just put it out there and just assume that it'll be great. We wanted to validate it. We wanted to study that and to really define that and say, have we achieved what we wanted to achieve? So we aim to do what's called a validation study. We wanted to know if the antifungal NAPS is valid and reliable. So in terms of validity, what we mean is, how does an auditor's assessment, so I've got Dan over there at Hospital B doing his audit of quality prescribing, how does his assessment of quality of prescribing compare to a reference standard or a gold standard? And then also reliability is the next question, is how does Dan's assessment compare to Jane's assessment? They work at the same hospital. Dan's a pharmacist, Jane's a ID physician. Are they getting the same answers when they look at the same prescription? Is it reliable? Are the different people going to come up with the same answers, basically? So the methodology, just briefly, is we went about creating some case vignettes. So we looked at real patients and we put these into little case vignettes, and it had, Jane, whoever was admitted with this condition, this is what happened, these were her test results, this is what she got prescribed. And we did this in 4 different domains with high antifungal use. We then had a steering group. So we had 2 physicians, usually an ID physician plus a hematologist, for example, an AMS pharmacist, and then a pharmacist who specialised in that clinical domain. So for example, a hematology pharmacist came together, they looked at those cases and they thought about, is this prescription appropriate? Is it optimal? Is it adequate? Is it suboptimal, inadequate? Why? Is it guideline compliant? And we came up with what we called a gold standard. We then recruited other pharmacists, participants. So we had ID physicians, AMS pharmacists, and specialist pharmacists in those domains, look at the exact same cases. And they did a survey to say, yeah, based on the information you've given me, using the antifungal NAPS appropriateness matrix that you've provided us, the guidelines that you've provided us, what do I think? Is this optimal, adequate, suboptimal, inadequate? And then basically we compared their responses to what our gold standard came up with. So these are the results. So what we measured was accuracy. So the accuracy overall for all of the data was about 77%, and we had high sensitivity, which meant that when a prescription was appropriate, the external people usually also thought it was appropriate. But where a prescription was inappropriate, the specificity was lower, it was 68%. So if something was inappropriate, they were kind of likely to say that it was still okay. So we kind of had to look and see, well, why are people thinking that these inappropriate prescriptions are appropriate? We did some stratification. We found that specialist pharmacists and AMS pharmacists had the highest rates of accurate assessment. And I think that partly that's because pharmacists tend to follow guidelines more clearly and will stick to a protocol. If you tell me to use this appropriateness matrix, I'm going to use it, whereas a doctor may be a bit looser, I think. Also, years of practice, people that had longer years of practice in their area had slightly better performance, but it wasn't statistically significant. And we asked them at the very beginning about their confidence. How confident do you feel about rating antifungal prescribing? And irrespective of their confidence level, it didn't make a difference. So often the AMS pharmacists were less confident because they weren't specialised in haematology or paediatrics or transplant. And they weren't quite as confident. And as an AMS pharmacist, I personally would not be as confident as probably a haematology pharmacist. But the really encouraging thing was that it didn't make a difference how confident you were. And specialist pharmacists and AMS pharmacists had really similar results anyway. We also looked at this inter-rater reliability score using Kappa statistics, and we found really we had fair reliability. Specialist pharmacists had the greatest reliability of all. And when you broke it down into the types of cases, pediatrics were more reliable in assessing. Directed therapy was easier to assess often because you've got really clear guidelines for directed therapy. If you've got Cryptococcus, this is what you need to be treating it with. It's less ambiguous. Drug classes, generally, it was about fair and indication. Cryptococcus was almost perfect because you've got a really obvious guideline. There's not too much deviation there. It just provided us some really interesting data. But I wanted to kind of understand, well, why are people getting the answers wrong? So we found that in a lot of the cases that they've said, well, yeah, I think the dose is wrong, but they've still called it optimal or adequate, and they haven't followed the appropriateness matrix. So really highlighted the importance of encouraging people to use the appropriateness matrix and to use that so that we've got good quality data, reliability and consistency. We found that there were some common knowledge gaps, for example, around echinocandin dosing in renal impairment or dosing of fluconazole when you've got a susceptible dose-dependent organism. People didn't have necessarily the knowledge to make that assessment. A lot of the time people were not familiar with the prescribing area. A lot of the AMS pharmacists felt that they didn't have the confidence to assess somebody's risk of infection and therefore whether or not prophylaxis was appropriate. Where there were no guidelines, people had difficulty interpreting. Sometimes it was just that the case had like a really specific detail that nobody noticed. So that was probably my fault in my subtlety of case writing. Sometimes people just made assessments based on their own experience rather than using the guidelines. Sometimes the cases were a bit complex, and not infrequently the assessors actually found additional issues that our gold standard group didn't find. So maybe our gold standard was not gold, almost silver, but I think it just highlights the complexities. We had 4 people sitting in a room looking at it and really putting effort into assessing it. And there's always going to be additional opinions and other things that not everyone's thought about. And I think that's just the reality. It's a complex area. So how can we go about improving it? What we have done is in the NAPs online, and the antifungal NAPs is if you put in that the dose is incorrect, you can't choose optimal. And if you want to say adequate, we're going to question you and say, are you sure this is adequate because you said the dose is wrong? Hopefully that will help to improve consistency. We've developed an e-learning module, which has incorporated some of those key learning areas or those knowledge gaps that we identified. We've made some case examples that highlight these knowledge gaps. And really, really, probably the most important thing is to do these audits in a multidisciplinary team, is to have not just your AMS pharmacists and your ID physician do it together, but include your specialist pharmacists as well, your specialist physicians as well, because everyone brings different knowledge and we can work together to make that assessment the best that we can. I'm almost finished. So what sort of knowledge will the antifungal NAPs generate? So we talk about data to knowledge. It's not just about collecting data for the sake of collecting data to show when people come around. Yes, we do antifungal stewardship, but you need to convert that into something meaningful. So that shouldn't be there. Sorry, it's in the way. Too late. Quality of antifungal prescribing. You can look at developing quality improvement interventions. If you look at guideline compliance, are we using national versus local guidelines? If there's a lot of local guideline use, you might say, well, why do our local guidelines differ so much from the national guidelines? Should we be looking at our local guidelines and updating them? If there's high rates of infection, it might prompt you to review your high rates of breakthrough infection. It might make you look at your prophylaxis strategy. You can benchmark performance with similar facilities and get a feeling of where you are compared to others. Yeah, and basically the antifungal NAPs is available now for all Australian hospital use. So if you're interested, do jump on the NAPs website and get started today. These are our collaborators. Thank you.
So I think we've got time for one quick question.
Yeah, one question.
Yeah, if we've got a burning question in the room or online. No, well, Anna's going to be hanging around at lunchtime if people have got specific questions about antifungal NAPs. But, you know, it's really going to be interesting to see how the rollout goes and we move into reporting and evaluation phase and continual refinement. But it's a huge step forward from trying to put the antifungal stuff into the hospital maps are not really working. So well done, Anna. Okay, so our next speaker is Anna Shri. So Anna completed her vet degree at UQ, so a fellow Queenslander, glad to see, and worked in small animal practice while completing a MPH with a focus on One Health and Epi. She has experience in local government animal management in remote Northern Territory communities, and now is completing a PhD through University of Melbourne on antimicrobial stewardship in the veterinary setting with a focus on high importance rated antimicrobials, which is what she's talking to us about today. Welcome, Anna.
Thank you. Can you all hear me? I'd just like to acknowledge the traditional owners on land that we meet today, the Wurundjeri people. And I'd also like to say I'm really glad that we're supporting the Indigenous Literacy Foundation today. So I'll be speaking about the use of high importance rated antimicrobials in animals. Given the extremely serious situation that we face with AMR and the dynamic situation that it is, it's really important that all sectors take responsibility for mitigating further development of AMR. So timely implementation of antimicrobial stewardship interventions could delay or prevent the development of increased levels of AMR in animals and people in the future. So today I'm going to share the results of 2 studies that we've completed in relation to the use of high importance antimicrobials and talk about how we've used the available information to progress antimicrobial stewardship in veterinary practice. So some of you may be aware, obviously, that in Australia, antimicrobials are given an importance rating by the Australian Strategic and Technical Advisory Group on Antimicrobial Resistance, which is just shortened to ASTAG. So this rating system is based upon and it takes into account the World Health Organization's critically important antimicrobials list. However, ASTAG has rated some antimicrobials slightly differently depending on the local situation in Australia, what we use them for and our resistance levels as compared to other parts of the world. So these ratings are low, medium or high, which corresponds to green, orange and red. And those that are rated as high importance are antimicrobials that are essential for the treatment or prevention of infections in animals, in humans, sorry, where there are few or no treatment alternatives available. So it's really helpful document if you need to look up any importance ratings or registration status of antimicrobials. I've just put some example pages there so you can just see how it's quite clear what's low, medium and high. So in Australian veterinary practice, use of these high importance antimicrobials in food producing animals, such as sheep, pigs, cattle, it's really largely restricted to Virginiamycin, which is a streptogramin, and a 3rd generation cephalosporin in individual pigs or cattle only, which is called ceftiofur. In equine practice, some examples of high importance antimicrobials that are used regularly include ceftiofur, enrofloxacin, sometimes rifampicin is off-label, sometimes used in foals, and amikacin, also used off-label and usually intra-articularly. In companion animal practice, as James mentioned, cefavecin, which is the 3rd generation cephalosporin, and fluoroquinolines are the main high importance antimicrobials, and it's mainly enrofloxacin, that's the fluoroquinoline that's used. So the use of fluoroquinolines, gentamicin and colistin has never been permitted in food producing animals in Australia. And as a result of numerous factors, including that we've had quite good regulation and residue monitoring in the past, and we've got widespread good use of biosecurity and vaccination, Australia's levels of AMR are relatively low. And the low levels of fluoroquinoline resistance that we have in Australia in the human population compared to a lot of other countries could also be a result of well-regulated use of this class of antimicrobials in people and domestic animals in Australia since the early 1990s. But at present, there's sufficient evidence that all antimicrobial use in animals, humans, or agriculture drives resistance at some level. So improving the quality of prescribing for therapeutic use and reducing unnecessary use is of utmost importance. So unfortunately, assessing the quality of prescribing, particularly in a private veterinary setting, can be difficult. We have a lot of gaps in knowledge about what is considered reasonable use across all sectors of veterinary practice. And currently there's no regular, systematic, ongoing surveillance of antimicrobial use in veterinary practice in Australia. So we're missing a lot of the data that we need to make better decisions. And there's scope to improve the quality of prescribing in food animals in Australia, but we still need more publicly available knowledge about the volumes of antimicrobial use and the disease presentations for which these antimicrobials are being used. But the companion animal sector, including horses, it hasn't been subject to the same strict regulations that govern veterinarians treating livestock in Australia. So the use of high importance antimicrobials is a bit more common, but it also means there's more potential for rapid improvement in prescribing and guideline compliance in these areas of practice. So to better understand Australian vets' attitudes about the use of these high importance antimicrobials and whether any restrictions should be placed on these, we carried out a survey from June to December in 2020. And this incorporated demographic questions, Likert scale questions, and also some minor qualitative components. And this survey was designed to establish the proportion of vets who agree or disagree with the use of high importance antimicrobials in given situations and clinical scenarios. And it provides information about what Australian vets agree is acceptable use. I also asked questions relating to the restrictions and what kind of situations they should apply in. So we saw this earlier this morning. Vets were given information about high importance antimicrobials and links to the classification of these, like as low, medium, or high, and how it corresponded to the color coding. Of the 278 veterinarians who were working in clinical practice, 49% had heard of the ASTAG rating system, and 22% used a traffic light system like these cards in their workplace. So they might have been color coding antimicrobials in the practice or referring to the posters regularly. Vets that were that had postgraduate qualifications were 1.7 times more likely to have heard of the ASTAG rating system compared to veterinarians in clinical practice without postgraduate qualifications. However, the difference in the actual use of a traffic light system wasn't significant. Similarly, recent graduates were slightly more likely to be aware of the ASTAG rating system compared to more experienced clinicians, but this also didn't impact their use of a traffic light system in practice. So participants were asked about the appropriateness of various restrictions, and this figure just shows the responses for all participants. The bar at the top, which has 81% agreement, is for use to only be allowed after culture and susceptibility testing, has confirmed that the pathogen is resistant to all low and medium rated antimicrobials that could be used to treat the case. And clinical vets were more inclined to support the use after failure of treatment with low and important medium rated antimicrobials. So it's not on this chart. On here, you can just see the treatment failure is 63% supported use after treatment failure. That's without doing a culture and sensitivity. That's just the animals come back. There's been no response, so they're changing antibiotics. But there was a difference of 66% agreement compared to 47% agreement amongst those who weren't in clinical practice. So obviously you can see the pressure there for clinicians when they're confronted with a patient that hasn't got better and they have to do something basically. This is the results from one of the case scenarios that we had in the survey. So James talked a little bit about cat bite abscesses and treatment. So this is a question about a cat that comes in with a draining abscess and it's febrile and inappetent. You think antimicrobial therapy is indicated, but you don't think that the infection is life-threatening. And under which circumstances would it be reasonable to treat this cat with cefovecin, which is a long-acting third-generation cephalosporin? So there was high agreement once again that if there was resistance to other low importance antimicrobials that you could use cefovecin. So that's the second line. And this is split up between those vets that had prior knowledge of the ASTAG ratings and those that didn't have any knowledge of the ASTAG rating. And it was also concerning because you can see that difficulty to medicate. That changes quite significantly between people that know of ASTAG versus don't, but it's still around half or a bit more than half that think that justifies the use of this drug. And because there is strong owner preference not to give tablets to their cat, and also it correlates with the marketing of this drug around convenience. And also other research has shown that cefovecin is used quite frequently for traumatic injuries and abscesses overseas as well. And it's evident that these situations can be really divisive and difficult for practitioners, and those working in clinical practice will understand the various pressures placed on vets when making these choices. But overall, what we found with this study was that there is a need for further targeted research to provide guidance on how restrictions could be used to support the use of more appropriate use of high importance antimicrobials. And supporting vets through practical policies and AMS interventions is key if efficacy is to be preserved into the future for both humans and animals, and that we really need education and a non-punitive approach. And that came through very strongly in some of the qualitative comments, given all the pressures on vets at the moment. And vets are really open to restrictions and improving their prescribing. If you wanted to read more about that particular study, our paper was published just in time for Antimicrobial Awareness Week, so you can scan the QR code and have a look at that, or just send me an email. And moving on to the second study, which was a Delphi study as well. And this was really because we know that we have to have a balance between restricting use, but also enabling the timely and effective treatment of animals when they need it. So with complex challenges, such as the development of antimicrobial resistance, where current knowledge doesn't indicate a clear path forward, gaining experts' opinions from the field from human and animal health can be really beneficial in just moving us forward in that conversation. So as Anna already described a little bit about the Delphi process, ours was quite similar in that we got a group of experts together, but instead of looking at kind of indexed items already, we really just posed a few questions and developed consensus items throughout the rounds. And the key question we were starting with was, what are the circumstances under which antimicrobials with high importance to human health can be used in animals? So we did 3 survey rounds, and potential participants were identified through our group's professional networks, as well as for searching for published authors in the field of AMS. So we sent out surveys to 119 experts across human and veterinary medicine. And the response rate to the survey was just under 37% for round 1, with 44 experts taking part and 1 partial response. And then for the second and third rounds, we just sent it to the people who participated in the first round. And there were some people who dropped in for round 2 and then didn't complete round 3, or they missed round 2, but they came back for round 3. And overall, it was pretty good response rates. There was a higher proportion of respondents from a veterinary background in all 3 rounds, and almost 60% of respondents were from Australia. Other experts were from Canada, Denmark, the Netherlands, New Zealand, the UK, and the US. 48% of the respondents were prescribers. They prescribed antibiotics in their current positions. However, most of these were veterinarians and not from the human health sector. So one of the questions we asked was initially, do you think it's important to reduce high importance antimicrobial use in food producing animals and then also in companion animals, just to make sure that everyone was on the same page? And it's great to see that everyone thought that was important or very important, but similar to what James alluded to earlier this morning, there's slightly less emphasis placed on companion animals, but given how close people are with their animals, it's important not to lose sight of this area as a risk for transfer of resistant bacterial or antibiotic resistant genes from animals to humans or vice versa. So at the end of the study, we managed to reach consensus on 6 items. We defined consensus as 80% or more of respondents selecting the same option for a question. And over the survey rounds, consensus was reached by getting the results, amalgamating them and feeding it back to people and asking if they'd like to comment or alter any of the responses in light of the group's response rates. And we also really took a lot from, there was a lot of space for free text comments. So we incorporated a lot of those questions and points that needed clarification into the subsequent rounds. So the first item was that the country-specific rating systems should take precedence over any other rating systems. So for example, the World Health Organization rating system, when vets are making decisions about antimicrobial prescribing choices. The second item was that when using any international prescribing guidelines that are available, these need to be adapted to account for the country-specific rating system. So for example, we have the International Society for Companion Animal Infectious Diseases, which releases prescribing guidelines, for example, on urinary tract disease. We also have British Equine Veterinary Association that has guidelines as well. And they're really helpful for vets in practice, but we need to make sure when we're looking at guidelines that potentially have been produced elsewhere where resistance levels are different, to make sure that we're also adapting that to account for our country-specific rating system. Thirdly, that vets should be able to create local practice-specific antimicrobial use protocols, but they shouldn't be able to create their own practice-specific rating systems. It just adds confusion and also potentially is a way for vets to try and minimize their use of high importance ones by just re-rating it lower in their own system. So there was consensus that that shouldn't be done. Fourth, and this is what also came through very strongly from the survey of veterinarians, that the use of high importance antimicrobials is allowed after culture and susceptibility testing has confirmed the pathogens resistant to lower or medium rated antimicrobials that could be used to treat the case. And this was the only item out of a lot of different factors, like if the animal was critically ill or if there had been a treatment failure. This was the only item where there was consensus about when the use was appropriate. We said there was consensus that the use of high importance antimicrobials should not be banned. And this was a response for some of the legislation that had been coming through Europe about potentially banning a lot of high importance antimicrobials in animals, and the recognition that as long as we're keeping these animals or using these animals for food, we have an obligation under animal welfare to make sure that we're treating them appropriately. And in some situations, we do need these antibiotics, but it just needs to be only when absolutely necessary. And the final item was that any use of high importance antimicrobials not registered for use in animals must be reported to a central authority. So for example, use of something like vancomycin, amikacin, or imipenem should be reported, because currently we don't have a good understanding of how often these kind of antimicrobials are used, particularly in equine practice, but also companion animal practice. It's not that common in companion animal practice, but for example, things like amikacin potentially used in equine practice, and there's no way to kind of report that or record that at present. There wasn't consensus about where that data should be reported to. There was most consensus, and it came through the comments as well, about some kind of independent federal body for antimicrobial resistance, such as like a Centre for Disease Control type of organisation or a One Health central authority. And in a follow-up question about this, though, there was consensus that the purpose of this reporting is really for record keeping over time and surveillance, and auditing or investigating high or frequent users in order to assist them in finding ways to reduce that unnecessary use. So not as a way to kind of punish people, but just so that we know what's going on and we can try and minimize it. Also, our group's previous work has found that veterinary medical records are often insufficiently complete to make a judgment on the quality of prescribing. And this is an area that can be improved. So this was just a question on the last round about medical records. And there was a lot of consensus on that any high importance antimicrobials particularly, but it should be with any prescribing really, that you need to have a clear indication recorded in your record and justify that, as long as including the appropriate dose rate, duration, and a time point for reviewing the condition and any other antimicrobial therapy or treatment that you're giving. So free text comments we had, this wasn't one just talking about the importance of giving vets agency and supporting them, so that giving them option to describe why they're doing things would help them not feel micromanaged and be able to support them in their decision making. We also had a couple of comments, like this first comment showing how having to provide indication and justification has been effective in human hospitals as part of the prescription, and consider it as part of the prescribing process in facilities with pharmacies. But veterinary practices, as you may be aware now, don't have any additional pharmacists. It's just the vets, receptionist, practice manager, maybe nurses. So there's not that additional checkpoint. We have had in the trial appointing like a stewardship champion, but in most practices, there's no additional pharmacist or someone that in the practice you could justify use to. There was another comment about needing basically more evidence on, if we're actually going to reduce MR by using alternatives to the high importance antimicrobials. But this is really why we did the Delphi study, because we feel that if you're waiting, you know, a long time to get this more, I guess, strong data that it would have been helpful if we'd reduced time points antimicrobials. It might be too late at that point because we're in a really good position in Australia, particularly compared to a lot of other countries. So if we can move forward rather than waiting until it was absolutely important, but now it's too late. So I think that maybe some people missed the point of that a little bit. In conclusion, vets are really open to restrictions and improving the quality of their prescribing. The expert consensus supports some practical measures in the consensus items, but we do need further studies after trial implementation, supporting education and further consultation with vets. And the use and regulation of antimicrobials in veterinary medicine to combat AMR can't really be separated from a lot of the other challenges facing vets now and into the future, which includes disease outbreaks like the impact of COVID-19, but also foot and mouth disease, African swine fever, Japanese encephalitis, climate change impacts such as the current flooding and previous bushfire impacts that impacted on a lot of animals and veterinarians, and the significant workforce challenges that are facing the profession at the moment, which I'm sure are prominent in other health sectors as well. So strategies that are holistic and provide a sense of ownership and empowerment are likely to be the most successful. I don't know if there's any other clinical vets there, but there is some things you can do as a veterinarian. If any of you are pet owners, making sure that you're really up to date with their preventative care, nutrition, providing them a good diet, good husbandry hygiene, biosecurity, more relevant for large animal practice owners or people keeping, I guess, breeders and things like that. But if we can do all those things, we reduce the need for antimicrobials in the first place. So I'd just like to acknowledge my other NCAS colleagues and members of the Vet Microbiology group, my excellent supervisors, Kirsten, James, and Laura, and all the Delphi participants who consented to being publicly acknowledged. And I'd also like to thank Anna Khanina and David Ormiston-Smith, who helped with me with the red cap for my Delphi study. Thank you.
We have one, there's room for one question. We have one question.
Is there a question? I've got a question. Oh no, there is a question. Great. No,
You go.
Yeah, I mean, I think it's difficult, and obviously we'll have to see what happens with Amy's trial and if it actually improves things, reducing the cost. I do also think there's a large proportion of clients that you see that they'll say they can't afford something, but that they don't want to, necessarily. Like if you don't have to spend $150, you're not going to spend it, are you? So I think potentially that's where maybe restrictions could come in, where we could say, we can't do that unless we do this first. So we're not going to use these high importance antimicrobials unless we've done culture first. So maybe that's where that kind of thing could come in a little bit, like talking about taking it out of people's hands so that you're not blaming the vets that you can't do it. That's, oh, it's a rule, so that kind of thing maybe could help a little bit as well. Thanks.
And one quick question from me.
Yeah.
She's prerogative.
Yeah.
Did you get pushback from some of the vets saying this is a human health problem? Why are we looking at restrictions? We've already got low rates.
There was a couple of comments saying, the problem is that there was a bit of like resentment or resent vets being blamed when it's human medical people, or like in other countries where you can just get over the counter, or, people are just giving large amounts of antibiotics to animals. But there was also, I would say, probably more comments saying we need to do something. We seem incapable of, regulating ourselves. And also people with colleagues, there was a lot of people being like, my colleagues are always doing this and I can't stop them. So yeah, I think there was less than I thought, actually.
Yeah, that's good. It shows that people are starting to think from that One Health kind of perspective, which is what we want.
Yeah.
Thank you. Round of applause for Anna. Well, now we've got a lovely showcase of work that's been happening for many years now in the statewide antimicrobial stewardship program in Queensland. So we've got Dr. Minyon Avent and Dr. Sarah Boyd. So Minyon's an antimicrobial stewardship pharmacist with the Queensland statewide program, has many years of experience in developing and implementing programs for the appropriate use in a range of settings, Minyon, tertiary, rural, regional, GPs, et cetera, and really strong research interests around, interestingly, implementation of interventions where one size does not fit all. And I've worked with Minyon on that in the human health space. So I'm great that that theme has also come through this morning in the vet space. And then we've got Sarah, who's recently joined the program as she's an ID physician and clinical director of the Queensland statewide program. Sarah has a strong interest in AMS and innovative ways of delivering infectious disease and stewardship support to diverse patient populations. So thank you to Minyon and Sarah.
Thanks, everyone. Thanks for the invitation to present in Melbourne today. It's lovely to be back down south again. So presenting on the Queensland statewide AMS program. So as we're aware, a significant proportion of healthcare takes place in small hospitals, many of which are located in rural and regional areas where on-site infectious diseases or microbiological support isn't available. So these facilities often don't have adequate resources to implement an on-site AMS program with high rates of inappropriate antibiotic prescribing in comparison to the major city hospitals. Aura surveillance data also highlighted the impacts of some of the challenges for health service delivery in rural areas, which also incorporates the long distances required to travel to high-level services and workforce shortages, and how this affects antimicrobial stewardship. So data from hospital NAPS has also shown lower appropriateness and higher use of antimicrobials in Group D hospitals in comparison to tertiary facilities. And as such, novel AMS models and strategies are required in rural and regional areas to support prescribers and also address barriers to program delivery and ensure sustainability. So the Queensland statewide AMS program was established in 2016 and implemented in January 2017 on a business case for a sustainability model. So the program consists of a multidisciplinary team consisting of ID physicians, AMS pharmacists, a nursing CNC and a program support officer. And the program provides a tailored AMS program for these rural and regional hospitals and health services in Queensland. And the program's really designed to be a collaborative decision-making process with local AMS champions from each hospital and health service involved. So as mentioned, we're a centralised service and provide in-hours specialist ID and AMS pharmacy support, in addition to weekly telehealth ward rounds for each of the hospitals and health services that we support, which really incorporates Torres and Cape, Northwest, Central West and Southwest Queensland facilities. We also participate in site visits to promote engagement and involvement in quality improvement activities, in addition to local NAPS auditing and feedback to facilities, and coordinate a comprehensive education program. So we work closely with local AMS champions in each of the HHSs that we support to develop and implement locally applicable program activities to improve patient care and antimicrobial prescribing, in addition to building capacity locally for AMS interventions with local HHS governance oversight. So from 2016, a suite of interventions been implemented over time, both to provide AMS support and build capacity for the hospitals and health services that we support. So these have included development of local AMS policies and procedures, which has been also incorporated interventions such as routine day 3 review of intravenous antibiotic therapy to facilitate directed antimicrobial therapy and consideration of switches from IV to orals. There's also been the provision of real-time ID physician support, as well as expert AMS pharmacy support for prescribing. From 2019, we also commenced weekly telehealth ward rounds for all of our 4 core hospitals and health services, which are attended by local senior and junior medical staff, as well as pharmacists, nursing and infection prevention CNCs. So data from the 2021 Aura report demonstrates that, as previously mentioned, the appropriateness of antimicrobial prescribing in public Group D hospitals throughout Australia is much lower than other comparator larger hospitals. So Group D hospitals are acute public hospitals that offer a smaller range of services relative to other public acute hospital groups and provide 200 or more separations per year, and are mostly situated in regional and remote areas. So since 2013, from the Aura figure above, there have been ongoing improvements in the appropriateness of prescribing in Group A hospitals in particular, whereas the appropriateness of prescribing in Group D hospitals has remained, I guess, relatively static over this period of time. Since 2017, within hospitals supported by QSAMs, we've seen significant improvements in antimicrobial prescribing within this hospital group. So importantly, from 2019 and the introduction of weekly ward rounds, we've seen a marked improvement in appropriateness of prescribing since this time. Overall, appropriateness of prescribing has improved from a baseline of 53% in 2016 to 85% in the current year, and coinciding with this is a similarly marked reduction in the rates of inappropriate prescribing from 42% at baseline to 12% in 2022 thus far. So these data really demonstrate that directed and specific advice to local clinicians can improve outcomes in antimicrobial usage. And it's particularly the case when the advice and support remains consistent over time and is further sustained by auditing and feedback, resulting in change in practice and prescribing habits. With the COVID-19 pandemic and interruptions to usual on-site auditing practices, QI NAPs were instituted at facilities that we support as well. So these QI NAPs audits are ongoing and submitted weekly by local AMS champions in each of the participating facilities. Data from 2022 is incomplete at this stage. However, since instituting QI NAPs in 2019, there have been significant uptake in this intervention, and can measure it with this uptake, an appreciable difference in guideline compliance has also been reported. With regards to the annual antimicrobial usage across 3 of our hospitals and health services that we support, since 2016, the program aggregate data has demonstrated significant improvements over time. With regards to additional interventions and resources and support programs, these have included a comprehensive nursing education program in addition to specific interventions on topics such as community-acquired pneumonia and also vancomycin prescribing, which Minyon will go through shortly. Some of our education priorities over time have included skin and soft tissue infections, respiratory tract infections, and also urinary tract infections, in addition to sepsis, both incorporating empirical and directed therapy. We also provide a comprehensive nursing education program, which is led by our clinical nurse consultant, Stephen Notcher. And our presentation topics over time have been directed by nursing staff on the basis of feedback received, with a focus on case-based discussions with AMS principles embedded within them. And they have included topics such as directed versus empirical therapy, IV to oral switches, durations of therapy, and the use of guidelines and clinical pathways, in addition to microbiological sampling and interpretation of results. Just going to hand over to Minyon. He's going to go through a few aspects of our program as well.
Okay, thank you, Sarah. So it's really lovely to be here in person as well as see all of you online. And so what I'm going to do now is showcase 2 strategies that we have implemented using the learning health system approach that Wendy Chapman so nicely outlined. So how do we use data to gain further insight for what strategies we should implement at Queensland, and particularly at a local level, as Sarah has outlined? So utilising the NAPS data, we know that community-acquired pneumonia is not prescribed very well, and the NAPS data shows that less than 80% of any antibiotic in this area is prescribed appropriately. Having a look at our local data, looking at the disease journey, and so that was something that James alluded to in his talk. So what we were able to show that actually the appropriateness decreased during the disease journey for the patient at hospital, and actually on discharge we had the poorest prescribing for these antibiotics. So we had developed a project utilising the person-based approach framework, and this project was led by Gabby Grossfeld, and Gabby's in the audience today, and she's an AMS pharmacist that was with our program and has now moved on to work in Sydney. So it's a loss for us and a gain for Sydney. And utilising this approach, we had a look at an evidence-based approach to a number of interventions, and we use the co-design process where engaging with the local clinicians to further tailor interventions that they would like to utilize and implement. So one of them was the pathway, the community pathway that was designed, that was multidisciplinary and could be used across the journey, the disease journey. It was also supported by some patient information resources, as well as utilizing some culturally appropriate resources, some education strategies around fact sheets. We knew that duration of antibiotics was a particular problem, so we developed the duration of therapy flowchart for clinicians to use. And so this suite of interventions was supported by the local champions, where they did a fantastic job of educating their prescribers, as well as making sure that they were utilized at site. And then they was also supported by real-time feedback, utilizing a dashboard that was developed by one of our program support officers, Karin. And what we were able to show is that although guideline compliance had increased over the years, it wasn't really that much of an improvement. But this intervention was implemented in 2020, and looking at guideline compliance in 2021, you can see that there is a great improvement. Also having a look at the ongoing appropriateness of therapy within the last year, we were able to maintain that above the national average as well. So another strategy that I would like to showcase with you today is vancomycin. We know vancomycin is a drug that is universally poorly prescribed and has many challenges. It's a tricky drug to dose, and clinicians find it challenging. So not only does the disease that it manages have a high hospital mortality, but also the monitoring of this drug is not done very well. So utilizing the IPARIS framework, we conducted a number of focus groups, multidisciplinary focus groups, and these were then mapped to the theoretical domains framework for various trigger points for vancomycin. Along the, once you decide to prescribe vancomycin, what are the trigger points? So utilizing these, we were able to develop some action strategies. So the overall arching action strategy was developing adaptive guidelines, but these need to be supported by other interventions as well, including education and training, and then the different disciplines like to utilize different interventions and tailor them to their prescribing and practices as well. This was also supported by the monitoring aspect of this medication, which is important. So we've talked about audit and feedback and how important that is. And it also really needs to be targeted to the different disciplines and what they like to know. It's interesting enough, when I was conducting the focus groups amongst the junior clinicians, they said they weren't really aware that their prescribing practices were being audited, although we do NAPs every year throughout the nation, and they said they didn't get any feedback on how they were prescribing, and they would like to not only celebrate how they were doing, what things they were doing well, but they would also like strategies put in place so they could improve their prescribing, because they want to do the best for their patient. And the key thing was, we don't want to make mistakes. So I think that's a good learning lesson for all of us of who we were providing our feedback to. So one of the things that this strategy is being supported by is, and to upskill the clinicians, is a e-learning module that's supported on a statewide basis, a learning management system, where clinicians can choose their own education adventure and tailor it according to their discipline, their knowledge base, and what they would like to achieve. And so we've just started the rollout of this strategy, and there are a couple of people in the audience that have been very enthusiastic supporters. So there's Catherine Wilkes here from the Sunshine Class, and then we've also got Georgie Keys, who's here, came all the way down from Thursday Island, and so they have many challenges up there as far as getting access to resources and monitoring strategies for their patients, particularly MRSA. So it's great to have the local clinicians supporting us in these strategies, because without them, you wouldn't have the uptake that's required. So our program's been going for 6 years now. And throughout these 6 years, it's really about that journey, that implementation process and engagement. And it takes time with whatever you do. But one of the key successes is the collaborations that we've been able to form over the years. And many of you are in the audience today or online. And we'd really like to thank you for your support, and a big shout out about how we can work together. And I think one of these forums is really so key, that we can come together and share our knowledge and also support one another. So this program, obviously there are two of us here today, but it wouldn't be possible without many of the other people within our program. So we have Stephen Notcher, who's our CNC. We have another pharmacist, Sarah Ashley, and then we sort of supported and really helped along the way by Bonnie Smith, who's done a wonderful job in doing our program management. And also we'd like to acknowledge the expertise and the enthusiasm, the drive of the clinicians who have been in our program. So particularly Crispin Harkovich, who set up the program, and for his enthusiasm, Catherine Davison, who brought her wealth of experience and knowledge, and then Trent Yarwood, who was a great educator and good at engaging people, especially in the more northern regions of Queensland. And we've also been fortunate to have a number of wonderful pharmacists who've worked with us over the years, and they've gone on to become AMS pharmacists in their own right at their own facilities, or taken on new roles, as well as leadership roles within the organisation. So it's really been a win-win for all of us. So thank you, everybody, for listening to our story, and it's been a wonderful experience. And thanks, Sarah, for your leadership skills. We appreciate it.
So
we have a little bit of time.
we've got some time for questions. Now, have we got any questions coming online?
No, not yet, but I will just remind everyone online that if you don't want to type a question, you can raise your hand and we can unmute you. And I understand it's a bit tricky. By the time you've written it all out, it doesn't sound exactly as you want to say it. So that's totally fine. But I do believe Kaz has a question. So take it away, Kaz.
So this is a question about scaling, which is the Holy Grail. And any of us, you know, we want to get scaling. So I'm just interested in when you've gone from hospital to hospital, what are the challenges you find as you go to each hospital each time? Do you feel like you need to go back to ground zero when you go into each hospital, or do you feel as though the learning health community that is set up allows you to? I'm just interested because I think that's a challenging thing for all of us. How you translate something you know.
I might leave that to Minyon because Minyon's been with the program a little bit longer than I have. But yeah, lots of challenges certainly there has in terms of engagement of you know, different groups within hospitals, and then building on that, on those relationships over time, and also building local capacity as well. But Minyon might have some further.
Yeah, it is a challenge. I think that all of us do face is the scalability, and I think that's really the important key question here. Is you spend a lot of time and effort developing an intervention, but ultimately you don't want to keep it for yourself. You would like to share it. So I think the important part is that co-design and that collaboration, and realizing that another facility might have their nuances and what's important for them, and listening to them. I think offering, when you develop a strategy, having a suite of interventions is so key, because then people can then take what they would like to use and implement it according to their practices, which might be different. So each clinician has different ways of doing things, but also the patients at hand might be different as well. And so that picture in the middle with the IV to PO switch is quite a key example. So that's where we work with pediatric groups throughout the state, developing a simple strategy, but having a number of different interventions within that they could adapt.
Yeah, I'll just for the audience. So there was a question online from Kate. What was the engagement like from nursing staff in regards to weekly education sessions?
Yeah, sure. So we run a nursing education program, which is monthly, and we've got really good engagement with regards to nursing staff attending. It's all online, so they're able to log in from remote sites as well as engage within that as well.
Yeah, and just to add to that, so we do run the weekly ward rounds, and nurses are invited to come along, and particularly the infection control nurses and the facilities have great engagement, and they bring their patients that can present as well. I think as they get to know us and feel comfortable with us and trust us and feel more confident in their presenting skills as well, they realize it's a great learning. We kind of market it as a learning strategy, so you can present your patient, but you'll get a lot of education at the same time. And we get really good feedback from particularly the junior staff that come along, because they say, wow, we don't get this at our own facilities.
Yeah, fantastic.
Yeah, you know, the ones that rotate through from the tertiary care facilities.
Yeah. Excellent.
And I think there was a gem in there, the importance of linking AMS and infection control. And too often we have silos. So it's great the work that you do in your Queensland program to bring those concepts together. So well done. Any further questions? Yeah.
So the question was from Tavish, and it was, why have only seven people completed the training program?
It's only just started, hasn't it?
Yeah, it's just started, but
Yeah.
I was actually having a look at my slides and keeping us honest.
So, but you've had lots of people already express interest, and
A
already
lot of people have signed, so it takes a bit of time to go through it, and we just started it a few weeks ago.
yeah. So hot off the press.
Yeah.
And then before we go into our panel, there's one more question online from Teresa. Do your collaborative efforts with the Queensland AMR strategy include working towards an improvement in stewardship programs in regional and remote settings? So, yeah, do you guys, like, what's your collaborations like with the Queensland AMR strategy? Have you guys, Teresa, if you want to,
Do you want to take? Good question.
I can put the mic on.
Maybe take the mute off, Teresa. Have you got a chance to elaborate?
I can put her on.
Certainly something we'd really look forward to being involved in.
Yeah.
I
think
you're allowed to talk, Teresa, if you want to.
Hi, can you hear me?
Yes, we can.
Hi. Yeah, I suppose, I mean, Minyon, you mentioned something about one of your collaborations with Queensland's AMR strategy. I know that's been developed. I just wonder whether there's opportunity there to raise the important issue of improving stewardship activity programs in
Oh, sorry, Teresa, just 1 second while we get this audio sorted.
I can recap anyway.
Yeah, okay.
So yeah, so Teresa's comment was there's a lot of development ongoing with the Queensland AMR strategy, and just I suppose a little bit more detail around, do you see opportunities to really raise the profile of the importance of the rural remote work? Because so often when we develop statewide strategies, we focus on acute large facilities, I suppose, Teresa, don't we? So, you know, you've been doing so much great work and rural, regional, remote. Is there something that you wanted to keep pushing?
Yeah, I think that's really important in terms of an overall AMR strategy for the state, to make sure that it is, you know, involving the entire state and all of those facilities as well. Because You know, AMS is really important, I think, on a statewide basis, not just with larger hospitals, and it's really important to involve those rural and regional sites.
And you've got a great way, I think, of raising and promoting the voices of those rural remote sites, because certainly there are some very loud voices coming from Brisbane.
Thank you so much.
So well done. So one last question, Kaz.
Question around.
Mm.
Do you want to just come up and, yeah.
Right, so I don't have to repeat
Other
it.
time, yeah.
Sorry, it's Kathy. I do want to highlight something that Queensland has that none of else have in any other state. So do you want to give a bit of a summary of the way they can access data to drive or understand areas of improvement that we certainly do not have in Victoria? Take it away, Sarah.
As someone who's fairly new to Queensland, who is actually a Victorian originally, so it's really remarkable, as Kaz has mentioned, with regards to the data sets that we do have available to us in Queensland, in particular the use of Queensland pathology, which is across the state, and really means that we're able to access all of that microbiological data as well. Which is an incredible data set that's obviously available.
And pharmacy as well.
Pharmacy as well.
And you can see patient movement between any hospital.
Yeah,
right?
that's right. Yeah.
So, you know, the holy grail for us to take a really advanced learning health approach here is to be able to track our patients between community and hospital. They can do that a little bit in the NHS. So we've seen some stuff coming out of the NHS, particularly in AMR, where they've been able to track, you know, resistance between aged care hospitals, community and the NHS. I mean, maybe Tabish can comment, some of the data they can get out of the NHS, we still can't get. So I think we're quite digitally immature in some ways. And in terms of moving forward, and we can take this up in the discussion because we've got our digital health colleagues here, what are the building blocks that we need in order to progress from where we're going? And some of it will from top down, you know, what are our health departments doing and actually creating data linkages, universal, you know, and unified identifiers, you know, all this stuff that we've all been waiting for forever. And then I guess for everyone in the room to be aware that you've seen the announcement about the CDC that's been planned. Some of you will be involved in the consultation process around that. We need to have a voice for that because stewardship is actually the implementation arm of the AMR strategy. We need a strong voice. It's not just about AMR surveillance, it's actually about implementation. And some of us obviously will be involved in that. But we need to collectively have a voice to say that in order for us to support the AMR strategy, there needs to be funding models in our healthcare, in primary, veterinary and hospital and aged care that are actually going to properly fund stewardship. Because at the moment, all of us, put your hand up if you feel like your stewardship program's under-resourced. Pretty much
A lot of hands.
A lot of hands in the audience, and I suspect a lot online. So, you know, we I think will start to have an increasingly important role. And so because we are so under-resourced, the digital...
There are hands going up.
Oh yeah, lots of hands going up. Yeah, so a lot of things that can provide our decision-making or data aggregation or reporting, all those things can reduce that possibly quite heavily manual work that many of us have to do to provide reports back. Because a lot of, you know, it is exhausting, and all of us, you know, standard 3, you know, AMS accreditation is a mandatory cycle every 2 years, and we all know what it's like. And what we want is a situation where stewardship data and reporting are just part of what we do, and it's not something we have to sort of have a huge amount of effort into every 2 years when that cycle comes around. And that's speaking for hospitals, you know, how do we do that in veterinary care, and primary care is another question altogether.
Absolutely. Anything you'd like to add, Minyon, Sarah?
Just like to add, just to build on that. Okay, so on just a bit of a shout out on it's Antibiotic Awareness Week. Obviously starting today, but we've got a number of great programs coming out, and we've got one on Tuesday, and we're going to showcase the data and how it's used on a statewide basis to inform practice. So we'll have Sonali Coulter, who's done a lot of great work in this area, and then we've got Naomi Raniger is actually going to take it to the next step and show how you can apply it to a patient-specific level. So if you'd like to hear more, come along to our session.
I do have a little plug at the end of the day.
Teresa was,
Yeah.
And of course, Teresa with her incredible
Yes.
work in.
Yeah, Teresa and I are running an antiviral session on Tuesday as well, if you're interested.
Yeah. Well, I think you've pretty much half started the panel anyway, Kat.
All my questions are gone, Beth.
Yeah. Well, thanks,
Thanks,
guys.
Mark, for stopping you asking questions. So please contribute to this conversation online and in the
So
Great.
we'll just give us a minute just to switch the audio over for the panel. And
And I
then
can probably do intros to
you
people
can
on the panel. while we
definitely
get
do
started.
that. Yeah. So just
So very fortunate now to have, we've got a panel with 4 people from a broad background and high level of expertise for us to really do a deep dive on clinical informatics, learning health systems, how we actually get data to knowledge, all those nitty gritty philosophical questions and practical questions that you might have. So firstly, we've got Professor Jim Buttery, who's an infectious diseases clinician at Royal Children's. He's the head of epidemiology and surveillance for SAFIC and the inaugural chair in child health informatics at University of Melbourne. There's a whole lot of other committees here as well. However, I think the most interesting thing in his bio is Jim's background in One Health AMR research includes feeding antibiotic-laced feed to chooks on his farm when he was a teenager, as well as describing GP antibiotic prescribing over time using large data sets. So welcome, Professor Buttery. We've got Dr. Daniel Capuro, who's an internal medicine specialist and health informatician. Daniel's currently based at the School of Computing and Information Systems and is also Deputy Director at the Centre for Digital Transformations of Health, both at the University of Melbourne. Daniel has over 10 years of experience in clinical medicine and clinical data analytics, including electronic medical records, clinical informatics, digital phenotyping, clinical data mining. The list goes on. So welcome, Daniel. And then welcoming back to the panel, Professor James Gilkerson and Professor Kaz Thursky, who we did intros for earlier.
so we need the mics.
Yeah.
Is that right, Kat?
Yeah, so one for me. One for Castle. So we heard this morning about health systems, this approach to actually get data to knowledge and then hopefully to practice, cycling through. I want to start right back at the very start of that process around the importance of co-design and working with clinicians. So I'm just wondering if perspectives from people, whether you're from the vet or the human health sector, how important it is and what approach do you take to actually engage with people as a start?
Right, I'll start. First of all, thank you for the invitation. That's a hard question. I think that, especially if I think from the point of view of designing health information system, for example, electronic health record, involving clinicians is absolutely key from the very beginning, because we always run into this tension between wanting to capture every single data element in the most structured format, but on the other hand, that is really detrimental for clinical workflows and the time clinicians spend working on their electronic health records, usability, and so on. So that's a tension that we need to acknowledge, and we need to find the right balance between what information we're going to collect and what's the best method to collect that information. We always
tend to default on asking the clinicians to, document more things. And I would say, in terms of co-designing, how do we bring patients into this equation? Because a lot of the information that we need to make these decisions about whether I'm, writing the right prescription, information about the patient is key. Sometimes, clinicians become just a middleman or a middle person in collecting this information. We ask the patient, and then we enter that into some, system. So I would say that bringing clinicians and patients and researchers and health services administrators from the very beginning, when we design these systems, is really, really critical. Back in we did one study in the US comparing 3 different hospitals with the same electronic health record and seeing how many of their surgical quality metrics they were able to calculate automatically, and it ranged from one academic medical center, which was around 10% of those metrics, which is really a failure in terms of spending all this money in an EMR and being able to capture only a tiny subset of their metrics, all the way to close to 90% of different hospitals with the same EMR, just different implementation strategies. And that speaks about the power of engaging clinicians, having a reason why to capture the data, and make sure that everybody understands why we're capturing that information.
So I'll use an example why it's important to engage outside of AMR. I listened to a Hendra virus podcast a few weeks ago from a vet from Queensland. The vet was describing the difficulties in doing accurate Hendra virus surveillance because of the realities of the relationship between the consumers, the horse owners, and the vets who had to go out to see sick horses that are potentially living on verge, the forested areas where Hendra is active. And it was the practicalities of the day-to-day business as a private vet versus the needs for horse owners was critical to understand why we're not ascertaining that appropriately, and the steps you need to mitigate those risks you're only going to get when you do full consultation at every level of that component. AMR is very similar in understanding the barriers of the limitations and developing ways to get over those. You can only do through that consultation.
It's a great example.
I guess there are I think about 100 people online, so this wonderful group of you listening in right now. It's like, well, what do you mean? Because a lot of people throw around this co-design. It's absolutely overused. I'd encourage you to hop on to Google and have a look at the Improvement Olympics. And that happened last year, and it was a Twitter competition comparing the best method to actually undertaking improvement activity. And I went through all the frameworks. Tish mentioned how important it is to have a framework in which to get going. Many of us will be very familiar with the PSA type improvement cycle, and that actually won the Olympics. But that in itself means you need to plan carefully and understand. The second one was what matters to you. And that what matters to you question is a simple but powerful message. But if you're looking at doing something around stewardship, you've got to ask the executives, the managers, and prescribers at all levels. And one of the challenges I find is it's very hard sometimes when we do stewardship interventions to actually get to the real decision maker. We speak to the HMOs, but it's actually been the surgeon who's been doing the same thing for 20 years. We haven't designed a program to fit that surgeon. And the fact that there are 10 surgeons, all of who do different things. So, and each of them are absolutely right, of course. And so if you have a look at that, if you deep dive, and it's a wonderful website from Horizons in the UK, it'll deep dive and explain to you and set you through to all the resources. And I think it's a wonderful resource. It's sometimes hard to find out how do I get to improvement methodologies? Where can I go to actually click through and find resources?
So I guess I can only really speak to my experiences, and in the veterinary sphere, I think we're a little bit less formal, and so the idea of a formal co-design consultative type of process is not what we've undertaken, but in some ways it's actually what we've undertaken. So we've said that you can't influence stewardship if you don't understand use. My colleague Ben Browning, who's not here, because he's in B&G with the Fleming work, made a really nice observation that measuring AMR is great, but it's a little bit like measuring the sea level when you're concerned about climate change. So by the time you notice that there's a problem with AMR, or the sea level's gotten too high, you're sort of stuck. Right? And so we've taken a pragmatic approach. We've been able to access records, and we've been able to describe usage. In describing usage, we've been able to engage with practitioners. Engaging with practitioners, we've been able to implement stewardship programs. In implementing the stewardship programs, we've been able to do that sort of feedback. And so I think that's been our sort of informal co-design sort of process around how do we go and how do we inform ourselves. And we were talking with the Make Data Useful team about how we can use the dashboard. We were doing some presentations back to the Vet Compass board, and they said, well, where do we go with this? And I said, it's the beginning of a discussion that's going to be ongoing. So in some ways, it's a very informal co-design type of process, but I think the discussion is really important. And the broader the group of people participating in the discussion, the better. And from a veterinary point of view, I mean, in a particular hospital setting, there's a well-defined staff, and so you can actually have quite targeted discussions. But in a loose affiliation of different practitioners around the country, all of whom are private business people, all of them trying to make a dollar, because if they don't pay the staff, then it's hard to engage them. So it's a long-term informal process.
So many really interesting themes there around the benefit of a formalised theoretical-based approach, but with real conversations. I think that's what it comes down to, and real relationships. It's not a tick the box. We've done a survey. Let's move on.
I think it's actually it sounds trite, but I actually think it's one of the One Health benefits that we've gained from working with Kaz and the team here, is that we've been able to take a lot of well thought through strategies that have been shown to be useful or less useful or more useful in a human health setting, and be able to apply them, and to, like a smorgasbord approach, pick ones that we think might work and try those. That one didn't work as well as it seemed to work in the human setting. We'll find someone that's already been tried. So I think in that way, that sort of the fact that we've been able to work together is quite a nice One Health story.
And really that's what we need, isn't it? We need more and more conversations, communication between sectors to build that consensus rather than silos. So moving on in the kind of the data journey, so we've got our lovely EMR or program or SMART system. As an epidemiologist, one of the things that I find the most challenging is how you actually turn that data into useful information. So I'm just wondering about reflections on that process around reporting and interpretation and providing that context when what everyone wants is traffic light, but a traffic light doesn't tell you everything you want to communicate. How do you address that? Do you want to start?
I guess I can reflect back on our MAPS journey actually, because back in 2013, when we had Rob James, who I think is here somewhere up the back.
He's hiding up the bag.
And maybe it'd be great for you to come down and actually contribute. He's been across the entire journey of the MAPS, and part of what we've done is saying this, and we'll hear from Kaz later today, but at the very start, we took what was out there. And what was out there is typically what we would do is we run around and do a compliance audit. We have the ETG guidelines, we do an audit, and we'll see how we're going against the compliance. Well, actually, when we look at guideline compliance in the MAPS, it sits around about 50 to 60%. However, when you do an appropriateness audit, it sits between 70 to 90%, thereabouts. Now that's very powerful, isn't it? because that tells you that our guidelines cannot fit every patient. And our approach in NAPS, I think, was groundbreaking in that we recognise the fact that you know, prescribing is complex. Now, in actual fact, our veterinary colleagues have presented the NAPS concept to them, and they actually like it. It's much easier to talk about appropriateness, optimal prescribing, than talking simply about guideline compliance, which is a little abstract. So, in my view, that informed really how the NAPS has been developed, and now what we'll do is have this continuous improvement process to understand, well, what do our users want? And you know, I guess a good example was that the clinical care standards were put out by the Commission. And we didn't want our NAPS auditors to be doing 2 audits, clinical care standard audit and an NAPS audit. Why not incorporate a clinical care standard report into the NAPS so it's all in one? You know, this constant trying to make life easier for you. Why can't we import EMR data straight into NAPS and then actually be appropriate? So that has informed the way that we've tried to help not only with what data is going in, but what data is coming out. And the NAPS has always fairly and squarely been focused at the end user in the hospital, not so much for like this abstract national reporting.
I guess I'm focused on the other end too, is that the concept of surveillance is literally information for action.
Yeah, absolutely.
But even if you're taking the same information, the way that the different users within the system want to see that information presented in a way that will make them do something in either their behaviour or their policy or whatever is almost always different. But the modern BI systems are such that we can essentially manipulate that information to be presented in a visual format that is appropriate for the different users, and we should be doing that as aggressively as we can and thinking about what are the needs for each of the levels of users we're talking about, so that they're seeing information in a way that's meaningful for them and helps them do whatever change they need to do, whether it's provide funding or whether it's change their behaviour and how they think about antibiotics when they're going to see their GP. As effectively as we can, so maximise the efficiency of the information we're collecting at the other end.
And I would add from the data collection perspective, and as a clinical informatician, I think it's about also letting go of the idea of a perfect system that will solve all our problems, because that's what tends to lead us to this analysis paralysis. We can't decide, you know, what standards are we going to use, what is the perfect format, what's the perfect interface, and we may spend years agreeing, and we're not going to agree. So I think, and I commend the effort that I see here with you know, guidance, because it's been iteratively designed to fix and address specific problems over time, and you can see that a robust system has been built over time. And that's when you look at systems that are successful across the world, that's precisely the kind of system that you know, make it to that stage. It's not about, you know, a group of, you know, wise people agreeing on what's the best standard, what's the best interface. It's about this iterative design, and it goes back to, you know, including all the necessary participants in this journey. I think this is an amazing learning community that has been able to produce that kind of output.
I'll just take up on what Kathy's talking about around appropriate use, and I think for us in veterinary science, I think that was one of the things that was actually critical to being able to engage people in a discussion around stewardship and how do you collect the data, because I think where we tended to start with was gross tonnage. And gross tonnage is fine, you know, but then you start to say, well, there's heaps more antibiotics going into agricultural food production than there is treating people. Except then you've got to think about, well, there's the biomass of food producing animals that we have in Australia
dwarfs the biomass of people. And so how do you come back to make some sort of, and appropriateness has to be the key. We were at a conference a few years ago in Queensland, and there was a presentation about, you know, in Europe they're reducing their antimicrobial use, and it's just,
Oh, it's always about the Danish.
how did you know? And so we had this gentleman there who was talking about, you know, in the Danish pig industry, they reduced their antimicrobial use by 40% or whatever the number was, and that was only equated to a certain increase. You know, it was only a 2 or 5% increase in mortality. Then you realise how many million pigs they have in Denmark and how many hundreds of thousands of pigs extra that meant that died from a disease that they could have not died from had they been given antimicrobials. And we quickly came to the conclusion that just looking at antimicrobial use in terms of how much you use is nowhere near as important as how appropriate is your use. And so I think that's where we've sort of had to start thinking about how you design the system. And it's been useful being able to have the companion animal data to be able to show this is the proportion that's appropriate, this is not appropriate.
And that's, you know, one of the challenges that we have as we move to a one health approach is, I suppose, trying to work out what's at the centre. In reality, everything's at the centre, it's all interacted. As that beautiful picture from that you put up earlier has very eloquently demonstrated. Okay, so I'm now thinking around that appropriateness and AMS is one thing that we're doing. Yeah.
Can I just interrupt one second? One thing that has bugged all of us in this space, particularly those that are contributing to the National Surveillance Program, is that we still work with siloed information. So
that's my next topic.
We work with siloed information. So there's siloed administrative data, there's information out of clinical records, often which is free text incomplete, miscommunications. We have the Norse data, which is becoming more and more sophisticated. Then we have the MAPS data, and we have some AMR data, really. And the holy grail for all of this is to think, well, how do we bring that data together? That's probably a question for you.
Wow, yeah. Well, I'm going to be the facilitator. But it is a really interesting concept. I'm going to add an extra around infection data and the challenges that we have and environment data. So the challenges we have in actually identifying the obsession people have with the definitions and getting the definitions right, which is blocking us moving forward. And it's a little bit like what you were saying earlier around how perfect does it have to be before you start. We've had, I think, 25 years about arguing around what the definition should be for key infections, and just in our hospitals, let alone in our communities, we are still not there. And as a result, we don't have a national surveillance program for infections and human health, let alone focusing on AMR, let alone integrating it with antibiotic appropriateness, let alone moving it to One Health viewpoint. So I do think we do have to kind of go pick something, a few things, start somewhere, and then start and integrate and innovate and move forward, or we'll never actually progress. Because you need both ends, right? Don't you? You can't just be monitoring resistance, and you can't just be monitoring usage. You've got to have animal care, environment health, and human health. That whole, well, in human health, we talk about person-centered care, right? Putting the person at the centre. Well, if we don't do that, what's the point? We're just going to continue to have people putting comments like, was on one of those Delphi survey presentations before, why are we doing this? What's the linkage between usage and my vet clinic and resistance? The thing is, well, will we ever know truly with all the biological mechanisms what the true link is? But if you wait until you know how to measure those things, it's going to be too late. It's a little bit, as you're saying, with sea levels and climate change. So that's probably not answered your question, Case, but I'd be interested in other people's viewpoints around how do we break down the silos between data custodians and people who are super protective of their patch.
Yeah.
I think
And then I'm going to go around some more questions.
I'm really going to look through the article and come down to the pumpkin.
I think there's a fundamental mistake that we also is, and there's an example from primary care. So about 7-8 years ago, there was no primary care data set. And then somebody, like a group of people, went to UK and they talked to CPRD. So now CPRD has, like, CPRD make millions selling the data that is government data, but they are just getting money from people who are doing research. So all you need to do is make whatever data is available as it is. Instead of worrying about whether it's accurate or not, you make it available. Then a lot of PhDs and professors will jump on that data and they'll do the hell of research out of it. And that will make the data quality better. So for example, the NHS England has systemic chemotherapy database, so SAT database. They charge you 10,000 quid just to access that data. And data is created live from the whole hospitals. So all you need to do is you don't need to create a separate system. You basically ask individual hospital to pool their data centrally, and you left that for IT researcher or healthcare researcher, and you need to link it with payments. For example, Medicare has mandated online products. So every pharmacy in Australia, if they don't have access to online claiming and online ordering and everything, even online finding out patient information, they don't get money. So by January next year, everybody must comply. NHS did one simple thing. They tell all the laboratories that if you are going to get claim back from government, you need to populate data on the NHS backbone.
So getting those incentives right for it's really pivotal for data supply. If
you don't pay, you don't get paid.
So that don't give the microphone back. That works great for the medical side of things, but
commercial competence.
Well, in veterinary practice, the practitioner owns the records. They're obliged to keep them, but they're not obliged to give them to anyone else. And so trying to pull them and stuff like that. So I absolutely 100% think it's a great thing. You tie it to the money, stuff happens, right? But from a private business point of view, there's no incentive. And then they look at these guys in the medical profession are charging $10,000 to access this database. How can I monetize my data? And that becomes really problematic for us. So.
And I'm going to
probably be primary care,
but I'll probably just put a caution in here around the challenges we have with legislation, regulation, ethics, governance, and data availability in this country. That I think we're probably years away, because people even if they're putting data into a system, how many hundreds of contracts do we have even just for apps? And yet we then do not have, there's extra levels to be able to then report and identify, etc. And even just creating a de-identified data set, it's a huge effort. So there is a lot of work that has to happen in the regulation of data accessibility, reproducible research kind of space as well. I think that hopefully we're getting a better technology for that now. But yeah, anyway.
Despite all this, Medicare and Optus lost everybody's data.
Yeah, well, this is
all about the price.
Yeah, exactly. You know, so but it's almost set us back, right? Because there is a data privacy is really important, but accessibility of de-identified data for quality improvement and research purposes is also really important. Ruby, do you want to just give a bit of perspective from a primary care viewpoint?
Yeah, are we talking about challenges? Barriers?
Yeah, challenges. Oh, yeah, well, I'd love to talk about enablers actually, Ruby.
We could be here all day talking about primary care data. The first thing I want to say is the data is as good as whoever puts it in there. So that's the main point. So in general practice data, which we have, one of the main issues is that we do have a lot of We've got two EMA databases that are taken out maybe 80 to 85% of general practice. However, they don't really talk to each other. So when you're talking about data being extracted, so that's one of the challenges, being able to select the fields and things like that to suit the data itself. GPs are not mandated to put specific data in there, so reason for visit or reason for prescription may not always be there. So then it's really difficult for us researchers to say, well, it's the antibiotic prescribed for, I don't know what condition it was for, was it appropriate? So that's an issue as well. And privacy, I was going to say privacy is an issue because you are looking at very closely patient data as well. And there's a lot of data governance, as you already said, Lisa, around data privacy. We currently at the University of Melbourne, we do have the paper data set that we're taking out for the over 130 general practices. We take the identified data that we can actually answer research questions. So that's an enabler that practices are happy for us to do that. But there's a big data governance around there. So whatever research that we want to do, we have to go through the data governance to make sure that everything's through ethical conduct, that we're not asking anything that is inappropriate, and all the data is identified as well. So we do have a lot of issues with primary care data, but I'm really excited that there's a lot of enablers in there in this space that I think we can do a lot of good.
And I think now it's probably a good time to give a shout out to our colleagues at NPS Medicine Wise, who have been doing a lot of work on use of data and academic detailing and helping people to. And here's hoping that that doesn't all just go to the wayside with the defunding of that organisation. But thanks so much, Ruby. We look forward to hearing a bit more later on. I'm now probably going to think about when people get that data information report back that we've customised using BI, but basically whether they're an executive or a clinician or a regulator, how do we support and upskill and train and educate those people to actually be able to understand what they're
I think we heard in one of the talks that this probably needs to be, multifactorial. Prescribing antimicrobial is a behavior, and so multiple things influence that behavior. And knowing what I need to do is probably one part of doing the right thing, but that's just one part of doing the right thing. And I think that providing meaningful and actionable information is very relevant, and part of some of the projects that we're involved in entails designing these information devices or products so they can be meaningful to whoever is making decisions with them. But also there's a lot of tools available that make it easier for clinicians to do the right thing, clinicians and patients to do the right thing. So I think understanding this, BI or information visualization as one of the many different ingredients that we can put into the blender and try to make decision making easier. I think it's part of the challenge and the opportunity that we have with all these digital tools.
I'm not sure I've got anything terribly clear to add. I accept that don't underestimate the value of a blunt instrument. And so when Indonesia made a simple, hard to get, but simple legislation that they changed from being allowed to buy antibiotics over the counter that it had to be prescribed, and that radically changed the level of community antibiotic use in Indonesia. I think the other thing we need to understand is all the dynamics that come with what it takes to prescribing, including the consumer pressures. So we did some work in a Shenzhen Children's Hospital, and the reality of prescribing in Shenzhen Children's Hospital, where the hospital is the primary care, over 5 million outpatient visits a year just for children, is that the families will stand over the doctor and yell at them until they give them the antibiotic they want. And so you have to understand the dynamic of each part of the prescribing process to understand where you need to give, how you need to package that information so that the families can yell for the right thing.
Absolutely.
One of the, some of the things that my observation has been, particularly in an EMR environment, so in primary care, the current GP systems do not ask the indication until after you've already chosen antimicrobial. So if you do that, that happens after the order, and it's not mandatory, you lose that opportunity to initiate decision support. Epic, CERN and other EMRs do not typically allow you to do pre-order decision support because things only happen when you order the antimicrobial. And so, for example, in our experience with our guidance implementation, we've been able to partially integrate to prompt the fact that you need to get approval. But it's a next level to say, well, we want to integrate that actually into the order and right back into the EMR. And we're somewhat bound by the business rules of these big EMRs as to what they allow to happen. So there are serious digital structural things that need to happen. Some of the things that we've done is to actually make indication mandatory, which I actually think should be everywhere. And we've also mandated approvals for obviously our, traffic on antimicrobials. And that certainly makes people think about what they need to do. Got a question with you?
I worked in a hospital that had a digital EMR for 10 years, and the first EMR fell out, basically, so they 4 years into the project they had to introduce a brand new one. And I was gobsmacked that the EMR on lots of requirements all across all the national standards, the EMR was not designed around standards. And what you're saying about prescribing information was just one small detail, but there were other factors that led people to fail and significantly harm patients by making medication errors. That was just one example, leading to fatality. So how do we know that we're purchasing an EMR that is fit for purpose, that is designed around all the mandatory requirements of what we have to provide in healthcare?
It's a fantastic question, and Daniel, you comment proud of you, but in actual fact, an effective implementation of EMR is 1.5 times the cost of the EMR itself. So,
and it's not just supplying muffins at the launch.
No, you can have an absolute army when you roll out Epic in children. We did not have an army, but we had to emergently roll out Epic in our precinct, which meant that decisions were made around how we set up the EMR that were suboptimal, and we've taken 2 years. And I hear from a number of those executives who have watched the EMRs, it takes 3 or 4 years to get to a point, like a stable point, I suppose that's right, isn't it? Like takes years. I've been heavily involved in, implementing a clinical acceptance pathway in Epic. It's been a real journey with fortnightly meetings with the Epic team to actually make sure that it's fit for purpose to do exactly what we want, because you don't really know what you get. And it actually takes a while to understand the data, how to use the data, how to get the data, how to actually even get the buy-in to make a change to the workflow. You actually have to put a formal request in. It gets onto a whole lot of, a shopping list of things that they will be prepared to do. Some things I say, look, that's too hard, it's too much of a rebuild. We'll put it at the end, we'll do it sometime next year. So it is actually clearly a requirement for AMS teams to be well and truly embedded with the EMR rollout team at the start to make sure that you are engaged in the process. And we were fortunate in the other hospitals to be able to do that. So we actually mandated the fact that there was going to be an approval system. Yes, though they couldn't fully integrate it, but it would be there. We would mandate approvals after 4 months, so we've been able to sort of drive what we've required. But you're completely right. These systems I mean, our clinical practice in Australia is very different, for example, in the US. I think we have to acknowledge that. And we have highly skilled clinical pharmacists and nursing staff, which is also very different. So you might, I don't know.
Yeah, just to add to that, buying or implementing an EMR without having this ongoing clinical informatics, line of service it's like buying an MRI machine and not having radiologists, and expect things to get imported and it's just not going to work. An EMR is only an enabling technology. And it's it's very expensive, but it's way more expensive to just buy it and not use it for any meaningful purpose. And so I think that at least in hospitals that have deployed their EMR, after the initial trauma of changing the ways you do things and adapting and learning, then we realize that we need to start doing interesting things with it and with them. And EMRs are pretty powerful in terms of the kinds of things that we can do, and as a powerful tool, they can screw things up pretty badly. And I'm gonna blatantly advocate to have clinical informatics as a line of service in hospitals. It's just it's hard to believe that an EMR is gonna just operate itself, and we need highly trained clinicians that understand, as Cal defined, what are the nuances of deploying these systems, how can we tweak them, how can, if I make a change, how can I let the data that's telling me that I'm doing the actual right thing and not, making a mess down the road. It is an ongoing process. Again, it's just like buying an MRI machine. You need, you need people to know how to operate it. You need people to understand how it works, how it doesn't work. How can you harm patients by using it in the wrong way? And clinical informatics is, I believe, a clinical specialty that should spend time doing that kind of thinking.
It's a two additional minor point. Important to realise that most of the EMR systems we used in Australia grew out of billing systems, not clinical systems. And so they were originally developed largely around accounting and billing software. And so it would be a mistake to assume that they grew out of the birth of considered clinical thinking originally, although they've evolved in often really good ways. And I guess the other component to add is that whenever we think about how do we get the information we need to do what we need to do, humans are humans. And so if we ask for too much information, they will gain it. They will put in whatever it takes to get their workflow done. So it's important that we don't introduce components that are going to be gained and actually may produce incorrect information.
I think just to come back to your question about what training you need to give people.
That was the question, wasn't it?
Just to answer the question. I think it has to be tailored. And so when you're talking about large teams and having clinical informatics support and infectious disease support and specialist pharmacists, and I think that's a very different setting to the an ambulatory veterinary practice where you might have 3 or 4 veterinarians who hardly see each other during the week because they're all off in the car dealing with all their clients and what have you. They come back to the clinic, they're sort of ships in the night, if you like. And so, and then you go, well, here's your AMS report.
They go, oh, I don't believe that.
And if it's in hard copy format, it might sit in the tea room. If you're lucky, it gets unwrapped. So I think we've been, as I said, we've been focusing on companion animals where the people are actually tied to the clinic a lot more. But I think that was one of the discussions we're having around how do you provide this feedback in a way that's actually helpful. And it's the benchmarking me against you, our clinic against their clinic or a similar type of clinic. And it's that dashboard sort of thing that I was putting up where went through with the pilot, looking at how do I evaluate myself against, and it's very visual, it's very quick, and it's quite effective.
And it needs to be cognizant that the people looking at it get value from it and believe it, and it's not condescending.
Yeah.
So if anyone was involved with any of the stuff that's happened from the Commonwealth sending out letters to GPs that basically just said, you're doing a bad job, stop. And didn't go down very well with kids. So, you know, that's a lesson of what not to do.
But I think we should learn from where you could put a team together and where you can get that benefit of different people's specialist expertise and coming together. But I think in the veterinary setting, we're at the beginning of the conversation. And so it has to be useful. They have to engage and they have to be able to see that why am I prescribing heaps more highly critically important antimicrobials per 1,000 consults than everybody else? And what's going on here? And then the question is, what can I do about it? And it's a conversation. So
the conversation. So we're kind of heading into lunch now, but I've got one final question I'm going to paraphrase. Teresa Wozniak, who's one of our key champions, has asked a question, and I'll paraphrase it now because I've got a similar question I think is a nice one to wrap up with, is what actually has to happen at a national level in terms of funding, resourcing, regulation initiatives to actually get integrated One Health stewardship in Australia?
Yeah, I think so. Just grab the microphone before so I can give it up.
Don't be last this time.
Don't be last. You talk about the money, you've got to get in first. So I think from an animal health side, I think the One Health approach has to be what we're talking about. We're worried about antimicrobial resistance. We're worried about whether it's antimicrobial resistance and enteric pathogens that might come out of the food producing industry, or what's happening with my cat, or any of those things and how that's affecting my kids. I think you do need a One Health approach, because what we've tended to do in the past is try and identify our most vicious problems and fund it and put our funding towards that. So there was a massive announcement around, a huge increase in funding for AMR, and the health department said, great, we'll take 100% of that and you can have whatever's left over for animal health. Oh, nothing, don't worry about it.
Oh, we'll invite them to the committee.
But the pie is only so big and it can only get carved up so many ways. But I do think we need to, we've been talking about silos and we've been talking about just in where the information is from. We do need to take a step back and really take a One Health look, because it's one thing to think we're at this sort of level in medicine and human health, and then realise that we've just been bitten on the bum by the problem that's coming out of animal health, that had we actually applied the same focus to, we could have prevented.
And then our colleagues in the environment space, back here.
Well, what I want to say is we did not throw the baby out of the bathwater. We actually have some incredible groups around the country.
Absolutely.
And with serious expertise and existing collaboration, because perhaps not formalised or visible to everybody. We have groups like AGA, the genomics work happening here and across the country. The veterinary stream here, I think, really are incredible leaders in Australia and what they've been able to achieve in 6 years. What you saw today in 6 years, Minyon said, my goodness, imagine if we had tried to get to where they've got to, many of us have been doing this for 20 years. So I think that the requirement is that we need to have enabling governance, enabling digital infrastructure that can actually support the groups coming together so that we can actually have meaningful data usage presentation. We may not be able to aggregate it, but at least we can bring it together so that people can see what's going on across all the different sectors.
I would add, from the informatics perspective, I would say we need a rational de-identification policy, because right now we are in this paradox where my data was hacked by the Optimise hack and the Minyon hack, and I'm pretty sure my data is not being used for any research purposes or anything. It's floating in the dark web right now, my email address, my whatever, and I can't give my data to research. And And so I think a rational identification of data that puts the right approach in terms of balance of risk and benefits. Right now, we're reducing the benefits almost to zero, and the risks are still there. So I don't think we have the right balance yet.
I guess just two additional points. So one is we don't have to have perfect data, and how can we maximally use whatever data is gettable, but also understanding the reasons why data may be withheld. We just had a salutary experience in getting microbiology information from private labs, and we were thinking they just didn't want to share their data full stop. And the primary reason was for the private labs is that they wanted it to be an all or none phenomenon, because if only one lab gave their data, the other companies would understand their business profile far better, whereas they just wanted everyone to contribute, in which case they're far more happy to contribute. They weren't averse to helping research, they were averse to helping a research in a way that might compromise their business position, which was a salutary lesson for us. And I guess the only other thing I'd like to say is in terms of having, if you like, a One Health approach, that One Health approach needs to also occur at a funding and a policy level so that those structures can facilitate that.
I think that's a great final word. So I'd like to, no? I'd just like everyone to join me in thanking the panel. That's great.
We have lunch now, but I just wanted to promote the fact that all the catering today has been provided by the Australian Asylum Seeker Resource Centre.
Yeah,
so enjoy.
Welcome back, everyone. Okay, take it away, Sri.
Hi, I'm Ri. I am part of the vet stream of the National Centre for Antimicrobial Stewardship, and you've heard from some of my colleagues already today. Very excited to have people in the room, all of these antimicrobial stewardship champions in one place. And in this session, we're going to hear from 3 different settings where antimicrobial stewardship is happening. First, we're going to hear from Ruby talking about the general practice. Then Kirsten, who's one of my supervisors for my PhD, talking about some companion animal work that we're doing. And finally, we're going to hear about aged care from Nolene Bennett. But first I'll introduce Ruby. Ruby's a research fellow at the Department of General Practice at the University of Melbourne. She's from a microbiology background. She's been a microbiologist in hospital and community. And she did her PhD, just as I was starting mine, on exploring the knowledge, attitude and practice of primary care providers and parents on managing and preventing respiratory tract infections in young children. That is a mouthful, Ruby. Her interests are around infectious diseases, antimicrobial stewardship, vaccination and hand hygiene. So she's been monitoring everyone using the alcohol at the entry. So she hasn't really, but thank you, Ruby, for talking to us today.
Funny story, but it's real. When I did my PhD at Monash University, I had an office just outside the male's toilets. I have also a whiteboard on the side, and I would document how long they took in the toilets as opposed to whether they've washed their hands or not. So that sparked my interest in hand hygiene. No, that's not true. The rest is true, but it wasn't the only thing that sparked my interest in hand hygiene. So thank you, Ri, for that. It was a warm welcome. Thank you. Before I start my presentation, I really do want to thank all the collaborators that we've been working on. So of course, the National Centre for Antimicrobial Stewardship, big collaborator with our department. Also therapeutic guidelines, as well as the Northwestern Melbourne PHN as well. So if I leave anyone out, I apologise in advance, and this is the only reason only my name's up there. If I start talking, naming all these people, staying with Cass and Kirsty, then I'm going to miss everyone. I'm going to mention Joanne, who's my supervisor as well. So anyway, so I just want to acknowledge everyone that I've worked with. This is also a rare conference or symposium. Sorry, I should stand on the stool. Rare conference and symposium that I don't have to explain to everyone what is antimicrobial stewardship, what is microbial resistant, why is it a problem in in our healthcare, and why should you care? So I'm really glad I don't even need to do that. So let's make a start. So my topic today is digital health solutions to optimize antibiotic prescribing in general practice. So this is a lovely picture that everyone should know and will able to, reiterate to everyone. However, we've seen 3 wonderful speakers and a lot of panels talked about data to knowledge this morning. So we're going to start on knowledge to practice, which is this part. So what I'm going to do is talk about 2 knowledge to practice studies that we've actually done. And the first one is around co-designing and evaluating a clinical decision support tool. And the second part, it's about building and evaluating an interpretable machine learning model. And also, thank you, Ri, for that long title of my PhD. So if anyone are really good at acronyms, come and see me after. So I just want to put our study into context first. So I'll quickly go over our program of work in the past 4 years. So we started with a qualitative study, running a focus group to explore how GP use electronic medical records and guidelines to make these antibiotic prescribing decisions. Around the same time as that study, we also conducted an audit and feedback of antibiotic prescribing by GPs, where we sent a AMS pharmacist to collect 550 antibiotic prescriptions from 11 general practices across the east coast of Australia.
I've just realised that the Zoom's got it on presenter view. Sorry, Ruby. Pause.
Oh, now they know I've been reading off.
There, yeah, word for word.
Oh,
come on. When I finally thought I had everything under control.
Yeah, it's always me, Courtney.
Yeah.
So I could probably read off my notes here. It won't make any difference.
Where did it go?
I don't know. Do I get a few minutes back?
You do get a few minutes back. I'll permit it. Hold on, let me just go quick help me. Oh my God. Oh, there it is. Okay. Let's try that again. Okay. So let me share the desktop. Alrighty, sorry, Ruby. That is it. You may resume. Yeah.
No, I have to think about that. I really read through a lot of the text. Anyway. Oh. Okay, that's better. Yeah, and the second study is building, evaluating. Okay, so to put in context, this is what we've done. We're up to GP NAPS, which is the second part. It's really about auditing antibiotic prescribing in general practice. So we actually collected over 570 antibiotic prescriptions, and these prescriptions were manually assessed for compliance and appropriateness according to therapeutic guidelines. So we assessed them with a panel of experts, including GPs, RD physicians, pharmacists, and microbiologists. So from the first study, a qualitative study, we found that many factors, such as GPs' experience, patient factors, practice culture, cost and access to guidelines, hindered the GPs' use of guidelines when they prescribe antibiotics. The GP NAPS study found that there were 40% of antimicrobials were inappropriately prescribed. So now that we have the knowledge of the data collected from these two studies, I'll talk about how we use the knowledge to design, develop, and evaluate a practice solution. Now,
Setting up some new lighting.
so we once again know that appropriate prescribing in general practice is not optimal. So we want to know what can we do to assist GPs to use guidelines and appropriately prescribe antibiotics. So what we actually did was we went to a simulation lab. Now I want to say that it's nothing as flash as what Wendy simulation lab is when she talked about this morning. It was still okay. So the simulation lab, we invited 8 GPs into our co-design session. So we first asked them, what are the 3 most important must-haves? And 3, what they don't want in a clinical decision support tool. So there's 3 things that GP or have actually said, the top 3 were that the computer should learn predictive and behavioural things that they're going to put into a computer. The solution design has to work around the workflow, which is what we talked about this morning, and not too many pop-up, please. And if the pop-ups are there, they should give you options of antibiotics for these specific conditions. 3 definite don't want. They don't want a clinical decision support tool that has a lot of words. They especially don't want the clinical decision support tool to make them look silly in front of their patients. And they all said 3 clicks and they're gone. Okay, so these are the really important things that we actually took from this co-design session. We also then asked them to follow the patient's journey and tell us where they want to access therapeutic guidelines in their electronic medical records and other patient information during their consultation. So through the session, so this is best practice. So through that session, we came up with a clinical decision support tool. As you can see, we've got a therapeutic guideline button up there. So when they click on that button, they'll be able to type in whatever conditions that they think they want to look into the guidelines, and it's preemptive text as well. We also have the therapeutic guidelines where they prescribe on the prescribing screen. We also have a panel down the bottom. So this is the information panel that they can tailor whatever information or links that they want to have for their patients, any drug information, and also they think it's appropriate information for their GPs during consultation. So to evaluate the system, 2 patient EMR files, so we created 2 mock patients, were developed using demographic information, medical history, prescriptions, and pathology results. So the first case was a 61-year-old woman presenting to the clinic with a recurrent symptom of a urinary tract infection. So the case was actually a complicated case with antibiotic allergies, patient has comorbidity, and previous documented resistance as well. So this is really designed to be a complex case that the GPs were more likely to have to go into therapeutic guidelines to work out what is going on. The second case was an 18-year-old girl that presented to the GP with symptoms of a sore throat in the context of the mother wanting her to commence antibiotics because the child has an upcoming VC exams. But this condition is consistent to a viral infection, so antibiotic treatment was not recommended. So we used the system usability scale and the post-study usability questionnaire, so that reflects the overall usability of the website or the application based on the respondents' experience. And we were also able to track the GPs, how long they actually use the use therapeutic guidelines for, and what sort of information they can give to the patients. At the same time, we also use think aloud interviews that they can go through their thought processes as the GPs were talking about the tools. So this is the simulation session in the laboratory. So we made it as real life as possible. We did have a camera, but nothing as flash as the sim lab that Wendy talked about. We have a little camera sitting on a tripod. We also have, information within the EMR that we can see how long they've spent in each section as well. We also made it as real life as possible. So we had a patient bed, we had a computer, we had all the equipment, examination equipment, printer, so the GP can print out information resources. And then after the 2 back-to-back patient consultations, then we actually had a chat with the GP and did the Think Aloud interview, as well as just an interview to ask them what they thought about the process. So just quickly, some of the what GP have actually said. They said having access with multiple screens assisted their clinical workflow. So that was really good. We're able to put in the main screen as well as the prescription screen. This is the part that everyone was really happy about. They actually related the therapeutic guideline logo to the Nike tick and also the golden arches. Okay, so I'm sure there were quite a few very happy people that think that this is amazing. Most importantly, integration with the EMR into the electronic medical records facilitate access to guidelines and patient resources. Now, I just want to say that this clinical decision tool, it's not really integrated, okay, but actually made it look like it's integrated. So that made it really useful for the GP. So the tool was acceptable and had high usability and was actually influenced by the co-design phase. So participants who didn't regularly use guideline actually said they found value in this tool because of the patient information down the bottom, panel down the bottom. So from that study, we thought, well, the clinical decision tool can be further developed and implemented in a pilot antimicrobial stewardship quality improvement program in general practice. So that's exactly what we did. So we developed a AMS quality improvement program, incorporating an audit and feedback tool with education and quality improvement support by the Northwestern Melbourne PHN. What we found in this study, which I won't go through because it's not really part of knowledge to practice, we found that GP view AMS as important, and that receiving the audit results and feedback actually assisted with the goal setting and reflected on the practice was actually considered was acceptable. But most importantly, high prescribing doesn't equal inappropriate prescribing. And we've talked about this as well, and we did talk about during lunch, at lunch. So we need to differentiate between what is appropriate and really what is really inappropriate. So however, we know right from the start that it's not possible to manually assess prescribing, especially in general practice and primary care, because we do prescribe 80% of all antibiotics. It involves line-by-line assessment of the patient condition against the reason for prescription, antibiotic prescribed, dosage, frequency, duration. Okay, so we can't move this to scale. So knowing that we can't manually assess antibiotic appropriate assessment at a large scale, what can we do? So that brings me to the next knowledge to practice study. So 18 months ago, one of our academic GPs used a patient data set that extract electronic medical records from 11 general practices, not the same 11 as we talked about in GP labs, it just happened to be 11, over a 12-month period. So after cleaning the data, which took a long time, we look at 5 common conditions. So we looked at acute cystitis, cellulitis, tonsillitis, acute otitis media, and acute rhinosinusitis. So during that period, there were just over 4,700 records of antibiotics for these conditions, which he then manually assessed against appropriateness against therapeutic guidelines. We found that there was only 40% that was considered as appropriate. 54% were inappropriate and 6% were considered not accessible. So it took a while for him to manually assess these antibiotic appropriateness, which is 4,700 records, even for just these 5 conditions. But most importantly, we won't be able to produce feedback report in a timely manner to our GP. So it's not seen as appropriate. However, in December last year, we were approached by a master's student I've forgotten who actually said this morning about how their phone must have heard what they were saying. Because around that time, 2 days ago, before that student contacted us, I don't know if it was me or Joanne or even Cass, I was actually saying that I was really disappointed because I was unsuccessful with a faculty CR ROPA grant. And the CR ROPA grant was actually talking about, getting machine learning happening and this to assess appropriateness. So I was really disappointed, but I was only disappointed for 2 days, okay? So all I want to say is one door closed, many will open. Well, for a lot of us anyway. Anyway, we were approached by a master's student from Harvard University wanting to do a project on data and machine learning. We're going, oh, he fell out of the sky for us. From the 4,700 antibiotic prescribing records that were manually assessed, that's just how bad that is. 80% of these records were used to train machine learning algorithms, and the remaining were used to validate their accuracy internally. So the model used 6 variables: antibiotic dosage frequency, age, gender of the patient, and disease condition to code for appropriateness. Using this 2-tier model, we achieve an overall accuracy of 93%. Okay, don't publish this yet because it's not published, but we will. So we have demonstrated that machine learning can automate that process. Okay, so this is actually courtesy of Alistair Queen, who is the master student, and we shared this wonderful student with Daniel, who, I think he's left, in the Centre for Digital and Transformation of Health. So what do we do now? So the next step is actually to validate this machine learning algorithm with an external data set. So using the funding for my faculty ECR grant, which I did get, I was able to analyse a separate patient data set that was extracted from 8 general practices across 2 time periods. So August to November 2019 and August to November 2020. So there were a total of 27,000 antibiotic prescribing records for these 5 conditions, and I've manually assessed the appropriateness against therapeutic guidelines. So based on the same methodology as what the academic GP did to assess this, the data set will then form the external validation for the machine learning model. So once we've actually validated using this machine learning model, we can move this to the usability and acceptance testing, where practices will be provided with audit and feedback using automated appropriateness assessment against therapeutic guidelines. So that's what we're hoping to do next. So what have we actually learned from these 2 studies? So that machine learning model provides good internal accuracy, and we are now going to move to a new data set to test external accuracy. We, as in everyone here, and this, ANCAS and the department and all that, we have strong record in big data. We have a lot of expertise in qualitative and quantitative methodology, as well as co-design methodology. So what we really wanted to know is to make sure that whatever we develop are going to be used by our end users. Accessing to tools such as clinical decision support tool and big data set, and with automating antibiotic appropriateness assessment, we can deliver meaningful audit and feedback reports to scale, which is really our goal. So I just dragged this quote somewhere, that machine learning doesn't replace people, thank God, but rather help people do things better. Thank you very much, and happy to take any questions.
Do you have any questions here in the room? Please put up your hand. That was a lovely talk, Ruby. Thank you very much, and great effort. Yeah, I'll let you go
now.
Yeah, you're free. You're relieved.
Now, can I please invite Kirsten up? Kirsten, I'm going to tell everyone about you. If I can just make my thing come on. Yeah. So This is Dr. Kirsten Bailey. She's a research fellow in antimicrobial stewardship at the Melbourne Veterinary School. After graduating from UQ, she worked in mixed practice. That means for those of us who are not familiar, working with both large and small animals in Victoria and the UK before deciding that equine practice was the place she wanted to be. And after 10 years with working with horses, Kirsten decided to do a PhD on diarrhea in foals and has worked as a lecturer in production animal health at the University of Melbourne. Now, as a research fellow, Kirsten investigates patterns of veterinary usage of antibiotics and explores strategies to improve AMS in vet practice. Please take it away.
Okay, so I'm going to, hopefully most of you were here this morning and heard James talk. So I'm going to recap a little bit, but not too much, but give you some of the results of some of the work that we did with our stewardship trial. So I just wanted to highlight a couple of things about the veterinary industry that, particularly about veterinary antimicrobial stewardship. I started with NCAS at the end of 2015, which is when the animal stream was established. And at that time, there was definitely, people didn't know what stewardship was. I still get a lot of people when they say, what do you do? And I say, I work in veterinary antimicrobial stewardship, that give you that blank look, but it's getting less. There's about 4,000 vet clinics in Australia. The majority of them are privately owned, about 70%. And the structure of the vet practice may have a practice manager and a number of veterinarians, a number of nurses and some receptionists, or it may just be a vet and a nurse that do it all. So there's quite a lot of variation. There might be multiple branch practices for the same practice structure. So we have very different setting to human hospitals, and trying to find motivation to get veterinarians to do stewardship, we're really quite dependent on their goodwill. We don't have any regulatory mechanism to make them do it. We don't have an accreditation requirement for stewardship. We don't have a registration requirement, although that is maybe starting to change. So this was the landscape when I started, that AMS in veterinary practice was not a formalised thing. And then at the same time, we didn't really know much about antimicrobial prescribing at all. We started off doing some surveys. We looked at antimicrobials prescribing for surgical prophylaxis to start with. And in that work, we identified that often the drug choice was appropriate, but the dose rates were not, or the timing or the duration. And then, as James mentioned earlier today, we were lucky to be able to assess this pet insurance database and look at prescribing in dogs and cats. And this is sort of the first real population level data that we had on veterinary prescribing in Australia. And so we could see in the dogs at the top, these are just different conditions that we could pull out from insurance data along the bottom. But essentially these blue bars and the orange ones are, the blue is amoxiclav and the orange is cefalexin. So they were the two favourite drugs in prescribing for dogs, and the prescribing rate was about 18.7%. Then in cats, we've got amoxiclavs, pretty popular, as well as cefavecin, which you've heard a bit about today. That's that third generation cephalosporin that comes in an injection that lasts for 2 weeks. So we had some information here about that there was some medium importance and high importance drugs being used quite frequently. But this was before we'd done all the vet compass and the machine learning things. And prior to setting up the stewardship trial, we did do some qualitative work to try and find out from veterinary practices what the barriers and enablers might be to establishing antimicrobial stewardship programs in veterinary practice. And then use that information to inform trying to create a stewardship program for veterinary practices. We've heard many times today about one size doesn't fit all. We have very different size practices, different locations, so they might be more rural, they might be on the fringe of the city, or really busy city practices. We were actually approached by this corporate veterinary group to undertake a stewardship program for them. And so our research team and the chief veterinary officer of the company, as well as their regional clinical directors, had quite a few meetings trying to work out what sort of interventions we could do and how could we do it. And so that was, I guess, the extent of our co-design at that point. So we came up with a program. They had about 152 practices at that point. They had, some of these were specialist practices and some of them were emergency hospitals, but they were a very small number. So we excluded those and we excluded any clinics that joined after we'd started the trial. So we had 135 general practice clinics. And James mentioned this earlier, that we randomly assigned them into 3 arms of an intervention trial. And then they had a look at them and reshuffled them around based on who they thought would cope with this program or didn't have the staffing for this. And so you'll see later that that possibly added some bias to our results. They then, so the 3 groups were the control group, which was, they got the prescribing guideline and the educational webinars. AMS 1 was the, as an intervention arm that they had this top level, as well as all these things in purple that James ran through this morning. And then AMS 2 got to do everything on the screen. And so we had our planning phase from about July in 2018, and then we released the materials in, we sent them all out to the practices in October 2018, and then spent a number of months liaising with the regional clinical directors and the veterinarians, trying to get them to implement it. And then after about 7 months or so, we felt that everybody was up to speed. And so we've divided our analysis of this trial into 2 years before. So there was a pre-trial, and then there's an implementation phase, and then a post-implementation phase. So what happened with this antimicrobial stewardship trial? We've analysed it in 3 ways. I'm going to present 2 of those ways today. So we did a survey of veterinarians, which was, I guess, having been in the Learning Health Systems course, I guess this was our evaluation of how it went. We've looked at antibiotic use analysis, and then one of our master's students, Susanna Richards, has conducted interviews with vets, nurses and practice managers, but we won't be presenting those results today. So we had 135 clinics, but we got survey responses from 108 clinics, and that was from 267 vets. We only surveyed the vets, and 2 out of 3 vets thought they had an AMS program, which, given that 2 out of 3 clinics probably had a fairly structured AMS program, that was good, except it didn't quite split out like that. It was across the board, 2 out of 3 thought they had a program. Overall, 43% had an antimicrobial stewardship champion at their practice. And again, if these are the different colours, so we've got the yellow for the control, purple for AMS 1 and blue for AMS 2. You can see that there was fairly even uptake across all 3 programs, even though it was only part of AMS 1 and AMS 2. But of the practices that did have a stewardship champion, 86% agreed that the champion was an effective advocate for appropriate use of antibiotics in our clinic. I've just cherry-picked some of these results. So we've been talking a bit today about the traffic light colour code system and the visual reminder. So again, 36% of vets implemented this traffic light system in their pharmacy. This time we had higher uptake in the 2 arms of the trial where it was actually an intervention they were meant to do. And then of the vets that had implemented the traffic light system, 71% thought this had changed their prescribing approach. One of the interventions was delayed prescribing. We had 59% of vets say that they were using delayed prescribing, and we had pretty high uptake across the 3 arms again of the trial, even though this one was only part of the AMS2 trial. What we don't really know is how they were using delayed prescribing. We think probably some of them were using it in an informal way, in that they would get a client to come back in a couple of days if the animal wasn't getting better and to pick up drugs, rather than actually giving them a script and saying, this is a piece of paper. I guess because veterinarians prescribe and dispense, it works a bit different than in human medicine, where they're still given a piece of paper and they've got to go somewhere else. But of the people that use delayed prescribing, 90% thought that it was a useful way of reducing unnecessary antimicrobial use. And so we created this leaflet that they could give to their patients with some things that they could be doing at home to help look after their animal, and also to try and manage their expectations for how long some of these conditions, I guess these are our veterinary versions of otitis and sore throats and things. We've got cat flu and kennel cough and feline urinary disease, cystitis, so similar sort of conditions. This is just a quick overview of all those interventions that we have. So in green, we have the percentage of respondents that said they used the intervention. And so you can see the things at the top, like prescribing guidelines, delayed prescribing, having a champion had relatively high uptake. The things that were a bit harder to implement, like audit and feedback and restricting high importance antimicrobials, had a lot lower uptake. But then in the grey bar, we have whether what proportion of respondents thought that if they use the intervention, whether it improved their prescribing. And so you can see with the audit and feedback, we had less than 20% of practices take that up, but close to 90% of respondents thought that it was a valuable way of changing their prescribing. So that's the sort of evaluation from the veterinarian's perspective of the stewardship trial. And then we did an analysis of their antimicrobial use over the trial. And so this data came from Vet Compass, which has been explained already today, but briefly it's essentially data from their electronic medical records in the veterinary practices is automatically extracted daily and goes into a central database where it's de-identified. And then we had access to that. And through Brian Herr's PhD and his machine learning work, we were able to extract the information we needed to do our analysis. We only looked at systemic antimicrobials. We didn't look at topical or any other routes like intra-articular or intraperitoneal. And we did some basic descriptive statistics, but then we also looked at high prescribing clinics, and we defined these as the top 25% of antimicrobial prescribers in the pre-trial period. And then we did some modelling as well. So you had a bit of a spoiler this morning. You've already seen this slide too. So our vet clinics ranged inside from 1 to 9 vets per clinic. We had more than 8 million consultations with about 250,000 prescriptions of systemic antibiotics. 8 antimicrobials accounted for 94% of the total antibiotic use. The most common was amoxiclav, followed by cefalexin, and then metronidazole and cefavecin. So 3 of our most commonly used are medium importance, and then the cefavecin is the high importance drug. This table is showing the prescribing rates during the pre-trial period. So that was the 2 years before we introduced the stewardship trial. And so you can see this is where the reallocation of practices into the different arms of the trial may have skewed our results, because we've used the control group as the reference, and we're looking at our incident rate ratio. You can see that our AMS1 group had 20% lower prescribing rate, and our AMS2 had a 22% lower prescribing rate before we even started the study. The other thing is that the prescribing rate over the pre-trial period was actually decreasing so as James mentioned earlier, just merely talking about introducing stewardship seemed to have an effect. This is looking at the overall prescribing throughout the trial. So down here on the left, we have the pre-trial period where we had an incident rate of prescribing of 3.7. During the implementation phase, this dropped to 2.4, and we actually had a steeper rate of decrease during that period compared to over those 2 years of the pre-trial. And then that decreasing rate continued in the post-implementation phase, and we dropped down to 1.9% incidence rate. Now we're going to look at prescribing by arm of the trial and importance rating. So this is just a reminder of what some of the low importance antimicrobials are that we're talking about. Things like amoxicillin and doxycycline would probably, and TMS. So in the pre-trial period, the solid line is the control group. You can see that all three groups had an increased use of low importance rated antimicrobials, but we had a much steeper increase in the AMS2 intervention than compared to the other two. Then if we look at the medium importance rating, and you can, and having a look down here at the proportion of antimicrobials, you can see that we're around 76% of our total antibiotic use was medium importance antimicrobials. We saw a decrease. It was less marked than the change we saw in the low importance antimicrobials. And the key thing from this graph, the control group in the solid line and the AMS1 are fairly similar, but we had a steeper decline again in the AMS2 group. Then looking at the high importance antimicrobials, this is our control group up here. You can see that all groups had an increase in their use of high importance antimicrobials, but the AMS2 group, which is this dotted line in the middle, was the most stable, with the others increasing. And so it seemed that we could reduce the proportion of medium importance antimicrobials and we could increase the proportion of low importance antimicrobials, but we didn't have as much effect on high importance. And so possibly this reflects that it's not about importance rating that is influencing why people are using these drugs. It's other factors that are making it a common choice, like it's easy to inject and lasts 2 weeks, and those convenience factors, unfortunately. Then looking at the high prescribing practices, this was really interesting. Regardless of the arm of the trial, there was a much greater effect in the high prescribing practices than in all the other practices. So we have the pre-trial prescribing rate here, and then the trial prescribing rate for high prescribing clinics. And then we're looking at this mean difference. So this is our mean difference for high prescribing clinics compared to all the other clinics. So it's nearly double. So this could just be that it's the low-hanging fruit. If you're a high prescribing practice, perhaps there's a lot of things that you can easily fix. It could partly be to do with the way that they were allocated to the different arms, and that, or potentially that the regional clinical directors knew more about the practices and so put more effort into some practices than others, and so we're able to show more change. So this is something we need to do some more work on, and maybe the qualitative interviews that Susanna has done will shed some more insight into this. So we had a positive impact of 3 different AMS programs in a large group of general veterinary practices. We saw a 50% decline overall in antimicrobial use. We did see a shift in use towards prescribing of low importance antimicrobials, and the greatest impact was seen in those high prescribing clinics. We do need to do further research to evaluate the experience of veterinarians involved in the trial to investigate the impact that these interventions may have in practices that see horses or other production animals in addition to dogs and cats. And our next phase, so we're in this cycle phase, so we've sort of done one full cycle of starting off trying to find out how vets in Australia are prescribing. We've tried to look at what barriers and enablers there are to antimicrobial stewardship. We've trialed some antimicrobial stewardship interventions, assessed the efficacy, and now we're going to modify the program and go around again. And as James mentioned earlier today, we're looking at having a benchmarking platform as well, and we'll trial some. We need to look more into auditing and feedback and some other interventions too. So thank you to everybody that helped make this trial happen. Through Vet Compass, obviously support through NCAS, and Green Cross Vets was the corporate group, and their leadership really helped implement this, and all our students as well. Thank you.
Thank you, Kirsten. Would anyone like to ask any questions? Go ahead.
I think, okay. So the question was, do we currently have the ability to assess appropriateness? With Brian's work that is about to be published, we are getting close to being able to do that. We can certainly look at dose rate and duration. Indication is not recorded very well in many veterinary records, and we're also using machine learning to try and pull that indication out. And without using a standardized nomenclature, that is challenging. We do have a paper where we manually looked at about 4,000 Cefovecin records, which is the 3rd generation injection. And we published it. I can't remember what the proportion of those was that the indication was not recorded for. The label does actually state that you're supposed to do culture and susceptibility before use, and I think the rate of susceptibility testing was less than 1%. But yeah, hopefully that will get built into the next cycle as well, is being able to do more appropriateness. And yeah, we need to, I guess we've just looked at overall use, and yes, we definitely need to look at what are the common areas that they're being used in, and then dive down deeper to see what's driving that and what we can do to change that.
Any other questions? Are there any online, Courtney, that I need to be aware of? Okay. I might just slip in a slightly tangential one, which ties in a bit with what our Queensland colleagues were talking about earlier about community-acquired pneumonia. I noticed that amoxicillin clavulanate is hugely popular, although amoxicillin is what is actually recommended. And I noticed also that there's a really high percentage of amoxicillin clavulanate use in companion animal practice. Would you like to hazard any guesses as to why across both of these settings, and maybe Nolene might have something to say about aged care as well, but any theories as to why vets and apparently some GPs are a bit obsessed with adding clavulanate?
I think when I graduated from vet science in 2000, and that was around the time that a particular veterinary pharmaceutical company was really taking off with their promotion of amoxiclav, and I used amoxicillin on its own when I graduated, but there's definitely a real transition to using the amoxiclav because it was better and it had palatable tablets for dogs and cats. And I think it was a really successful marketing campaign, and that we didn't really understand why we were using the clavulanate. I think now it is also, it covers more, so it's a bit of a safeguard, probably. And I guess it's easy when we're looking at these things retrospectively to say, oh, well, they could have just used this for that. Once we know what happened at the time, they don't always, well, they often don't know exactly what organism is causing the issue. And so if they give the amoxiclav, it's broader spectrum, it catches more.
Great, thank you. Now to aged care, and Associate Professor Nolene Bennett is an infection control consultant employed at the National Centre for Antimicrobial Stewardship and the Victorian Healthcare Associated Surveillance System, which we call VICNIS Coordinating Centre. She is also the project coordinator for both the Aged Care National NAPS and the VICNIS Aged Care Infection Indicator Program. And today we're going to hear about knowledge to practice in residential aged care.
Thanks, Ri. And thanks for the opportunity to speak today to NCAS. So the title of this presentation is AMS Knowledge to Practice in Residential Aged Care Facilities, Challenges and Solutions. As I often do, I start with the acknowledgements. I want to pay tribute to all the residential aged care facility staff and vital work that they do, and those staff that have participated in the aged care NAPS, the VICNIS Aged Care Infection Indicator Program, and the National Infection Surveillance Program for Aged Care NISPAC project. You are our champions. I also want to plug the session next Thursday, excellent topics and outstanding presenters. So across Australia, there are 845 providers for not-for-profit, private and government homes, of which there's 2,700. There's 217 places. about 57% are managed by not-for-profit providers. So this presentation is divided into two main sections, background and AMS framework, and they're aligned with the knowledge to practice goals, that is making knowledgeable action, making knowledge actionable and shareable, and generating tailored messages for decision making. So I am going to spend some time talking about the background, and it's really, really important in aged care to do so, I believe, so that we can fully understand the current contextual factors that will or may impact on the establishment or maintenance of an efficient and effective AMS program in Australian residential aged care facilities. So starting with the Royal Commission into Aged Care Quality and Safety. This was established in October 2018. There were 3 reports, the interim report, the COVID-19 and aged care report, and the final report. In the final report, the findings were stark and clear. 148 wide-ranging recommendations were considered necessary for fundamental reform of the aged care system. Does anyone here in the audience want to guess which medicines were most identified as being misused and overused? Sorry? Careflex? No, it wasn't an antimicrobial. Yeah, for those online, it was the psychotropic medicines, correct. Just finding the switch button here. So noting no recommendations specifically referred to the establishment and implementation of AMS activities. Listed on this slide are 22 recommendations that I think will or may especially impact AMS activities in residential aged care facilities. Now, time does not permit. Our chief organiser, Courtney, said I only had 20 minutes that I explain all of these 22 recommendations. So I'm going to focus on the 5 red highlighted recommendations only. Starting with the quality standards. So aligned with recommendation 19, the Department of Health and Aged Care is currently conducting an urgent review of the aged care quality standards. The proposed standards focus more strongly on the older person and ensure the design of care and services are orientated around the individual. There are 33 proposed outcomes. Of interest to us from an AMS perspective is probably 5.2 and 5.3, preventing and controlling infections in clinical care and medication safety. Note under outcome 5.2, it says older people, workers and others are encouraged and supported to use antimicrobials appropriately to reduce risks of increasing resistance. Okay. The National Quality Indicator Program aims to help aged care service providers to measure, monitor, compare and improve the quality of their services. Aligned with recommendation 22, new quality indicators are to be introduced in the first half of 2023. Of interest, perhaps, however, from an AMS perspective, is that residential aged care facilities are already collecting quality indicator data about medication management. That includes the percentage of care recipients who were prescribed 9 or more medications and the percentage of care recipients who received antipsychotic medications. But note in red here, what's not counted is short-term medications such as antibiotics and PRN medications. Okay, aligned with recommendation 5 in the aged care and COVID-19 special report, each residential aged care facility has had to appoint a nurse to be the lead person for infection prevention and control. This is an ongoing requirement. Aligned with recommendations 38 and 64, the Australian government intends to implement a new measure to embed pharmacists in residential aged care facilities to improve medication management and safety. Through this new measure, we are told that residential aged care facilities will receive government funding to enable them to employ or engage pharmacists to provide clinical services on site, meet the needs of individual residents and the facility as a whole. And aligned with recommendation 108, the Department of Health and Aged Care is partnering with the Australian Institute of Health and Welfare to progress a national aged care data system. I'm calling this the digital revolution. We are looking to improve or develop a national aged care data strategy, a national minimum data set, and a national aged care data asset. We are told that the information in the data set and in the data asset, that the information will be de-identified, but it will have many benefits. Now, at the start of 2020, and as the Royal Commission continued to share its stark findings, could it get worse for aged care? It sure could. In Australia, the aged care sector has been disproportionately affected by the COVID-19 pandemic. If we look at a national snapshot on the 27th of October, just gone, it continues to be affected, the aged care sector. As of that date, there were 1,203 active COVID-19 cases in 196 outbreaks across Australia. To date, there's been over 4,000 deaths, 18 in the last 7 days. Perhaps the most outstanding, the 7 words that stay with me, having read the aged care and COVID-19 special report, is that those working in aged care are now traumatised. So if I can just pause there as I finish the first section of this presentation. I think I've outlined to you the enormity of at least 5, and if I do my maths, that's about 3.8%, the total 148 recommendations by the Royal Commission into Aged Care Quality and Safety, and the devastation of the COVID-19 pandemic. This is what's been presented, only briefly. Again, I think it's really important, if we're going to be looking to support our aged care colleagues, that we understand the context in which they're currently working. So with that in mind, if I move to section 2, and I'm going to talk about an antimicrobial stewardship framework. And of course, in that context, it has to be efficient and it has to be effective. The example I'm going to do is some work that we did, let's call it cottage care. I love the names of our residential aged care facilities. Often they look to change them, but this particular example we're going to call cottage care. Before I do look at that framework, however, let's just remind ourselves, is there a problem really with antimicrobial use in our residential aged care facilities? Well, what you're looking at is some preliminary results from the 2021 report. Next Thursday, Kirsten will be outlining more so, but if I could just highlight that in 2021, the prevalence of residents prescribed at least one antimicrobial was found to be 13.7%. That's higher than previous years. That might be because our cohort is changing. We've got new participants, and so they might be contributing to that higher percentage. 13.7%, is that good or bad? Well, when we compare ourselves against the Europeans upon which we based our aged care NAPs, their similar surveys, yes, we are higher than our European counterparts. And so, yes, we do need to improve our antimicrobial use, just simply looking at our numbers before we even start assessing the appropriateness. Other continuing issues are the prolonged duration of antimicrobial use, the high rates of PRN as required prescriptions, high rates of topical antimicrobial use, prolonged prophylaxis for conditions where they're not recommended by guidelines, and the incomplete documentation of indication and review and stop dates. So let's look at one AMS framework. This is the one that we worked with cottage care. And we look to use the CDC publication, the core elements of antibiotic stewardship for nursing homes. There are 7 core elements that are recognised that needed to be addressed. So we started with looking at the aims for each of those core elements. Note that we combined reporting and tracking and called it surveillance, and we added communication to education. We added communication, yes, to education. We then, and when I say we, this was very much based on a team first looking at the evidence-based literature and then stakeholder consultation. And we looked at what were the potential barriers to meeting those aims. So for example, leadership, the aim, commit to preventing infections and improving antimicrobial use. A potential barrier was the low awareness and support of AMS programs. Accountability, to identify individuals accountable for AMS activities. The potential barrier was the inability to find a qualified leader. And action, if I just move along, implement AMS policies and practices, the overwhelming scope of interventions that were possible. So then, having listed what we thought were potential barriers, we looked at what might be the tips for success. And so again, under each of those core components, we looked to list, we being the internal stakeholder consultation. And so if we come back to accountability, we thought maybe if there wasn't a leader as such, that we needed to be reminded that we could appoint a strong, influential clinical leader, a nurse. It didn't have to be a GP, as we had previously thought. In action, one of the tips was, well, hey, if so much has been done about our psychotropic medicines here, why don't we just piggyback on the back of what's been done in that space? And so these were, again, from the internal stakeholders, their ideas about how we could address especially those potential barriers. We then moved on at looking at resources. Anytime anyone heard about a resource out there, they looked to add to this list. And that, of course, included the Aged Care NAPS Antimicrobial Prescribing Survey, that every facility in Australia is eligible to participate. And so finally, we got to listing what were we going to do for each of those components. And so let's call it the primary task to start with. We wanted them to be desirable, feasible, and sustainable. And so we also too were very mindful, we wanted some quick wins. We wanted to bring everyone along. And so we were looking very much that we were going to be able to achieve these primary tasks in a short time. So for leadership, if I come back, we looked to develop an AMS support statement or policy. We just copied the NCAS one. We included AMS related duties in our position descriptions, and we reviewed AMR and AMS data in monthly quality meetings, all very doable very quickly. Just moving across though to action, gee, this was really hard to decide, because remember what I said about the potential barriers. We felt overwhelmed by where to start, how many interventions there were out there that supposedly we should be doing. And so what we did was we went back to our Aged Care NAPS dashboard report, and what became very clear very quickly here is that our documentation of review or stop date could be improved. 52%, we were above the national aggregate, but hey, still nothing to be proud of. We also went and had a look at the companion document to the core elements of antibiotic stewardship for nursing homes document, and worked our way through the list of suggestions for policy and practice actions. We went further and we looked at the activities recommended by the Aged Care Quality Safety Commission, the Commonwealth, the Australian Safety Quality in Healthcare, the Australian Commission Safety Quality in Healthcare. I spent so much time trying to get those two commissions right. And then the prescribing guidelines. And then after that, what we decided to start with then was simply to look to document the key prescribing elements for all medications, antimicrobials use, that we would look to improve. Remembering what I'm saying, so much work was already being done in the psychotropic medicine space that we wanted to just, hey, if you're going to be looking at those medications, we'll just look at antimicrobials at the same time. And so I challenged them that if I turned up, just pretend I'm your accreditor, if I turned up and I looked at your medicine charts, then all of them should be aligned. Any prescription for an antimicrobial should be aligned with the Antimicrobial Stewardship Clinical Care Standard that says that there should be appropriate documentation for prescribed antimicrobials. And that looks to include the indication, the name, dose, route, intended duration, and review and stop dates. And then, of course, we needed to review. We needed to evaluate whether this framework was working. Remembering, we're aiming for efficient and effective framework here. We have to. We cannot go to aged care and offer anything less. And so to do that, over time, very quickly, because remembering our primary tasks, they were quick, we asked ourselves, have all the primary tasks been successfully and easily implemented? That was an out and out yes. These two questions here, of course, we couldn't answer at this stage because the framework was not yet settled. It was immature, but in time we will be able to answer, has appropriate antimicrobial use improved and have preventable infections decreased? So the evaluation, all important, trying to keep it simple enough for our residential aged care facility colleagues. And so then what? Well, we start again. Steps 1 to 6. We look at the aims. Are they still appropriate? We look at the barriers changed. Any more tips for success, anyone? Resources, anyone heard about more? And then we set ourselves up for our secondary tasks. Again, we look to participate in the aged care NAPs. That's the data that's feeding us, driving us. And we also, on this occasion, look to instigate the Aged Care Quality and Safety Commission's Dip or Not to Dip campaign, because we identified in our aged care NAPs that we had a problem with our urinary tract infections prescribing. And so is it efficient? Is it effective? Well, efficient, I think we're on our way. Is it effective? Still probably too early to answer that. So in summary, if I start with the background, there are many major unprecedented fundamental reforms underway in the aged care sector at the moment. The COVID-19 pandemic continues to adversely impact the aged care sector. We have to understand that when we knock on their front door and tell them we're coming to help them with an AMS program. The AMS framework summary that I've presented, in summary, improving antimicrobial use in Australian residential aged care facilities remains a priority. All residential aged care facilities are required to demonstrate AMS tasks that encourage and support older people, staff and others to appropriately use the antimicrobials. This is in the draft quality standards. The exact implementation of an AMS program in a residential aged care facility is dependent on their priorities and resources, and hence may vary from other residential aged care facilities. The AMS framework that I've presented here is just one of many that may be used to initiate or expand AMS activities in residential aged care facilities. It's based on the CDC core elements of antibiotic stewardship for nursing homes. Our facilities are encouraged to work in a coordinated stepwise fashion, implementing only 1 or 2 tasks for each core element over time. Evaluation of any framework is important to ensure it's both efficient and effective. And lastly, that said, we have to think any task taken to improve antimicrobial use in residential aged care facilities is expected to reduce adverse events and lead to better outcomes for their residents. One last slide. I know I've already said it, but truly excellent topics next Thursday, outstanding presenters. Can't plug it enough. And I'll finish there.
Thank you so much, Noeline. That was very interesting. Any questions from the crowd in the room? Aged care.
Yes.
Nolene, you're an experienced infection prevention consultant, and in our many years of going through the standard 3 accreditation criteria, it's been a massive challenge for infection prevention nursing staff that have lumped with having to actually implement standard 3. And I can't even imagine what it would be like actually in an aged care home, the average aged care home. So given that it's unlikely they're going to be able to fund pharmacists, senior nurses, all the people that we actually know they need, but the funding's not going to stretch that far. In how many nursing homes are there?
About 2,700.
2,700 nursing homes. That compares to 750 public hospitals. How are we going to close the gap and be able to deliver high quality care? Sorry, I know it's an impossible question, but
well, I touched on one slide. We have this role now that aged care IPC leads, and the introduction of that role really has to be evaluated too. They were brought in very quickly, and in my view, some very unrealistic expectations have been put on them in the context in which they're working. My goodness, I'm a senior IPC consultant. The idea that, you know, for me to have experienced what they have in a residential aged care facility in the last 3 years would have tested, you know, the most experienced. So I think they need to be supported, and I think we have to evaluate the introduction. The pharmacists, the consultation paper that went out for their role, I've been told that those pharmacists, a model will be made available, or will be told about the model that they've chosen that's to be implemented mid next year. So I'm not aware of exactly what that model is. The consultation paper that came out, which NCAS put a submission in, made comment on, it has suggested several different models, but I think time will tell with that program too how successful it is. Because Kaz, I agree with you, our facilities, if COVID's taught us anything, they need this expertise to support what they're doing. So, goodness, and in our roles, you know, I work at NCAS, and Kaz, you know, you look to support this too, you know, as best as we can to provide that expertise. But, you know, we can't cover, we're not, you know, up to, let's round it up to 3,000 facilities and be there each day. We have to fund, you know, these positions.
I should make a shout out actually for Nolene and the whole NAPS team here, because you may or may not be aware that we actually provide help desk support. That means when you contact NAPS, you will have someone like Nolene or a senior clinical pharmacist assisting you. Now, you can imagine that most of the principal, you know, many of the bigger hospitals, you're very independent now. You don't need our help. There might be some technical challenges or login or, you know, sort of issues around something around the platform. Yeah, the help desk support I'm talking about for NAPS, it's quite another level when we're talking about help desk support for ACNAPS. And it's down to things like, I'm not sure how to find it on the internet and how to log in. And I don't know what this means. So I don't know whether you want to loose that on that. It's actually quite a labour intensive activity of our team. But the reason why we still provide it, it's actually so important. So some of our remote regional NAPS auditors, for example, when we first started in the Kimberley, the feedback from them was very profound. They said we had never looked at what we were doing in our organisation, and we fear that, you know, patients will have had to come to harm because we weren't doing the right thing. And now we have really tangible data to feed back to our clinical teams to improve practice. So, and I think that's a similar experience that the ACNAPS staff have when they do.
Yeah. If I can just follow on, thanks Kaz for what you've said. To our residential aged care facility colleagues out there, I think you feel, you know, maybe intimidated that you're feeling a bit behind on this AMS concept. I encourage you, please don't hesitate to contact us. No questioning is dumb. In fact, I'll just let you in on something. You know, when you start with saying to us, oh, you'll be able to answer this easily. I have palpitations because I think maybe I won't be able to answer it. So truly encourage you to contact us. And we are at the start of this AMS framework, and we've got a way to go with evaluating what's going to work best. And we are incredibly mindful of what you're going through at the moment, but we can work together. So, yeah, thanks. We're just checking if there's any more questions. Otherwise, I think it's afternoon tea time for the team, the group here. Questions coming, everyone. Might be one of those ones I can't answer.
A question from Nadine. Thanks for a great presentation, Nolly. I was wondering what your thoughts are on how feasible it is to roll out EMR systems in all aged care facilities. Nice and easy. And how long you think this will take, and what other barriers may present in how successful EMR will be in this setting.
Nadine.
There's another
I might be
question.
retired.
You can both, you can share along.
Well, what I did make mention, to be fair, there is a digital revolution. Aged care recognises that they are too far behind with their their technology and the data. So there is work going towards that, but how long EMR, everything else it's going to take? Oh my goodness. The other thing I'll say, it is complex too, of course, because remembering in the aged care space, we've got, of course, got the government, the Commonwealth that oversees a lot of initiatives, but we have got private companies too that have recognised, hey, this is a, potential good space to come and knock on the door. So, these aged care facilities have got a lot coming at them in regards to technology. That's just one recommendation, remember, out of the 148.
There is actually a very large project that's been led by Professor Joanna Westbrook. Some of you may know Joanna, and that is actually around the EMR rollout in aged care, and it's a quality use of medicines focused rollout. So I think it will be really important, and we will actually obviously be contacting Joanna to make sure that we're at the party, because I said we talked to it before about EMR, why AMS needs to be at the table at the time you're planning it. So I always say to people, in hospitals, it's analgesics and then antimicrobials. Second most common antimicrobial class. You need to have that structural influence in how the EMR is actually implemented.
Yeah, I second that, because we really have to be at the table now when they're thinking about it. Any more questions, Courtney?
Just a quick one from Teresa. Just wondering if there were resources like antibiograms available in aged care facilities to support.
Yeah, not yet. Certainly an area that we've talked about at NCAS and how we can support that, but the short answer is not yet. Yeah.
Okay. Oh, good. All right. Well, we'll give everyone 20 minutes. We'll start back at 3:30. So if everyone wants to have a quick little break, there's some afternoon tea up there for those who are here in person. And as always, everyone online, please send through your questions. They've been really, really good. And back
thanks
at 3:30.
everyone.
Thank you.
Thank you.
All righty, last session of the day. Welcome back. So if you don't know me already, my name's Courtney. I am a postdoc fellow here at the NCAS. I'll be chairing the final session on practice to data. So completing the learning health system circle. So we started with data to knowledge, using that data to generate new knowledge, then knowledge to practice, using that knowledge that's been generated from the data to inform practice. And now this last bit is then from those changes to the practices, what are we doing to measure the transformation of services and outcomes? So we have our last lot of presenters. So I will introduce to you for the first up session. So we have Jenna Malecki. Jenna is one of the AMS pharmacists at the Royal Melbourne and a project officer at the guidance group here at the Doherty. She was involved in the development of the new guidance program and the rollout of the pilot program at RMH earlier this year. And presenting with her is Nan Ha Trong, who is also a pharmacist by background and specialises in implementation and AMS program development. Nan Ha provides training and support to our guidance users across all the partnering hospitals and leads projects for implementation of our guidance digital health programs. Come on up, guys.
Thanks, Courtney, and good afternoon, everyone. So we've heard some great presentations about the other sections of the learning healthcare system today, as Courtney said. So others have talked about using healthcare data to gain knowledge to understand a digital healthcare issue, and then using knowledge to design and build a digital health solution. So now in the practice to data part of the cycle, we're going to present how we implemented a digital health solution for AMS at the Royal Melbourne, focusing on implementation of the...
I just need to share the screen properly. So close yet so far, sorry.
Yeah.
Now good to go.
Okay, thanks. So yes, we're going to focus on implementation of the redesigned guidance program at the Royal Melbourne and how we went about setting up an evaluation plan and considerations for ongoing sustainability and scalability. So a bit of background for those unfamiliar, the guidance program was initially developed 17 years ago at the Royal Melbourne, and since then much has evolved in the AMS space with setup and maturity of hospital AMS programs, the evolution of accreditation and clinical care standards for AMS, as well as technology needs in healthcare. More and more, we're also seeing a higher regulation of the development of software with the software as a medical device regulations as well. So the guidance development team wanted to meet all of these evolving needs and future-proof the program for the coming years, and also keep key parts of the old program, such as approvals and documentation of interventions for AMS reviews. So included was the need to improve workflow for AMS teams and prescribers, who are often the largest group of end users of the program in hospitals. Also a must was for the program to have high usability and ease of use and enable improved ability to use data for targeted action. The guidance program is a web-based application designed to support systems-based antimicrobial stewardship in hospitals. So one of the key functionalities of the guidance program is to facilitate the hospital formulary restrictions policy for antimicrobials, and many use the traffic light system. It's the program that prescribers use to obtain approvals for restricted and highly restricted antimicrobials. And when prescribers do this, they move through the inbuilt clinical decision support pathway that assesses whether the antimicrobial they've chosen is appropriate for that indication. And in some situations, the system will recommend an alternative if that's appropriate. Prescribers will also have access to any local Royal Melbourne guidelines and therapeutic guidelines at the time of obtaining their approvals as well. So the approval and the related antimicrobial information is stored within the guidance program, and that's available for our ward pharmacists and nurses who want to review this information. And it's also the information that the AMS team uses to prioritise patients to see on an AMS ward round. So with over 50% of all inpatients on antimicrobials at any one time, the Royal Melbourne Hospital AMS team would need to prioritise review of these patients. And in particular, they focus on high-risk antimicrobials or indications, and also do assessments of appropriateness, then make recommendations that are fed back to the prescribers. So for all patients seen on AMS ward rounds, the quality assessment and recommendations are documented in guidance, and this makes it easy then to create reports and provide targeted feedback about antimicrobial prescribing by specific units and prescribing groups. And so the new guidance program was completely redesigned based on years of experience and feedback about the existing guidance MS system from our end users. And one of the most popular requests was to enable approval by indication rather than by antimicrobial. And so that was built along with the enhanced decision support for indications. They also wanted a more user-friendly process for editing content and recommendations within the program. So the team has built functionalities to encourage adherence to the hospital restrictions policies, including clear antimicrobial restrictions and inbuilt assessments to help nudge towards optimal prescribing. We've completely redesigned the reporting functionality, which allows the AMS team to provide more regular and specific feedback to stakeholders and the ability to target quality initiatives. And also we've ensured the program to be able to interact with other systems to enable seamless workflow for end users. The pilot program at the Royal Melbourne went live in September this year. So I'll hand over to Jenna, who will speak about the implementation part.
Cool. Thanks, Nanha. So when we went about implementing the guidance program at the Royal Melbourne, we first ensured that we obtained approval from our RMH AMS committee to proceed with the implementation. We then identified our key stakeholders and set up the project team and set out all the key activities and agreed on timelines. The technical steps of the implementation involved installing and configuring the software, which was achieved by first setting up a test site where we could test out all our system integrations and perform user acceptance testing and spend some time resolving any issues we identified. The RMH AMS clinical team were required to review the content and all the decision workflows that were built within the guidance program and make slight modifications to make it relevant to our RMH setting. So this required training of the guideline writer program, and that's where all the content for guidance is managed. The biggest component of our implementation plan involved communication and education of our end users. So it was really important that the hospital executive were aware and supportive of the change. And this included our executive sponsor, service leadership, quality managers, as well as the AMS committee. But as prescribers are the main group who will be using the program to obtain approvals, most of our education was targeted towards them, particularly our junior medical officers who do most of that day-to-day prescribing. Nurses and pharmacists also have a role to play within the guidance program. So we also ensured that we provided education at our NUM forum and our clinical pharmacy meetings. We also developed several resources such as presentations, short videos and tip sheets, which outlined what the guidance program is, why approvals are necessary, and how to obtain them in guidance. And all of this was communicated via many different mechanisms, from in-person presentations, workplace posts, and hospital-wide emails sent from our executive sponsor. On the actual go live day, we set up a run sheet of activities. There were requirements not only from the guidance team, but also the Melbourne Health IT teams and our EMR team as well. So it was really important that we had really good communication between all those key stakeholders to ensure that the go live day went as planned. And then lastly, we developed a support model, and this was just to make sure that there were systems in place for if users were having any issues, they knew who to escalate to and how to do that. So not only was it important to ensure we had adequate education and support in the lead up to and during go live, it was also important for us to consider what supportive measures that we needed to put in place to promote that prescriber engagement and use of the program in the period immediately post implementation. We were able to monitor approvals that were being obtained through guidance, and we had daily contact with our prescribers to obtain feedback on the program and identify any issues promptly. Education and training about the guidance program cannot just be a once-off. It needs to be an ongoing activity. So the resources we developed are easily available on our hospital intranet, and we have education sessions planned for our new staff. Then lastly, we considered how we were going to evaluate the success of the program, and that will be the focus of the next part of the presentation. So just reflecting back on our implementation, one of the great outcomes was that we were able to roll out the new program on time. And this wouldn't have been possible without really engaged project team members and those regular meetings to keep everyone on track. We had really great stakeholder engagement with support from executive who were able to assist with the promotion of the new program.
Any showstopper issues were able to be escalated, which allowed appropriate attention and resolution of the issue. And we were really able to reinvigorate interest in approvals and raise the profile of the guidance program, as well as our AMS service at RMH. And this was particularly important given the last few years with everyone's attention diverted to COVID. One of our main challenges was with an issue on how guidance opens from the EMM system in an old browser that doesn't support the new guidance program. Unfortunately, for technical reasons, the browser couldn't be updated during the implementation project, but this was really outside of our control. However, we as a team assessed that the clinical impact of this was not going to be a showstopper, and we did come up with an intermediate workaround and decided to address this post-go live. A couple of key lessons that we learned from this implementation project. Firstly, that the go live day is definitely not the end of the project. The ongoing monitoring in that immediate post-go live period was essential. And this gave us opportunity to really gauge the initial experiences with the program and reinforce messaging about our mandatory approvals policy. In hindsight, we would have allowed for more dedicated time from the AMS team to monitor the uptake of the new program in this immediate post-go live period. The communication between the different stakeholders is also essential. So having those regular short meetings with our project team really allowed us to discuss and prioritize activities and helped us stick to our initial deadlines. So as mentioned, one of our immediate post-implementation activities was to design the evaluation plan for the redesigned program. So for our evaluation, we really wanted to be able to justify the development and the ongoing use of the guidance program. There was a systematic review by TM Rawson back in 2017, and that looked at the existing methods that are used in studies to evaluate the clinical decision support programs for antimicrobial management. They assessed a range of studies against a framework they developed, and that included a description of the development of the program, feasibility and piloting, evaluation and implementation. The idea being that if each of those domains were covered, then the reader would have a really good understanding of the rationale for why and how the system was developed and how its effectiveness was evaluated. The authors found that there was a very varied approach to evaluating these clinical decision support programs, and most of the outcome measures reported focused on total amounts and appropriateness of antimicrobials prescribed. They found the studies failed to report on the end user workflow and generally found that engagement with the clinical decision support systems by clinicians was poor. So the socio-technical evaluation is a key component of our evaluation plan, as we really wanted to understand the usability and acceptance of the program by our end users, as that is key to the success of the guidance program. The other areas we want to evaluate are for clinical improvements, particularly measuring the impact of our clinical decision support, and then lastly, an economic evaluation of the program. So I'll mainly be speaking to our socio-technical evaluation today. So the first step in designing our evaluation was to establish which framework we were going to use to understand the usability and acceptance of the program. From our research, the two frameworks that best fit our needs were the Technology Acceptance Model, or TAM, and the Unified Theory of Acceptance and Use of Technology, or UTAUT. So these two models have been widely used in studies of health information technology, and they look into the individual's perceptions and intention to use the system. In TAM, it suggests that the user's perceived usefulness and perceived ease of use of the program determines their intention to use. And the UTAUT model builds on the TAM framework, and it summarizes behavioral intention into 4 domains. The first two, performance expectancy and effort expectancy, are essentially the same as what is covered in the TAM model. However, UTAUT also includes a domain around social influence, and that's how much an individual thinks that's important that others believe they should use the program. And it also takes into consideration facilitating conditions. And that's whether the user thinks there's the organizational and technical infrastructure, that exist to support the system. Then all the factors, gender, age, experience, and voluntariness of use impact those 4 domains. This all then affects the user's intention to use the program, and that influences their actual usage. So given the UTAUT model covers essentially what was in TAM, that was the framework we used when designing our study. So the aim of our study is to understand the factors that contribute to the experience of end users of the guidance program. And we really want to use the results of this study to improve the system and implementation of the program at future sites. We've designed a mixed method survey study with Likert scale and open-ended questions. And the survey will be sent out 6 and 12 months post go live to prescribers at all levels of practice, and will also offer the opportunity to provide further feedback via follow-up interviews. So these are a few examples of questions that we've adapted from each of those domains in the UTAUT model and made specifically relevant for the guidance program. So for example, the first one there on performance expectancy, we plan to ask about whether those decision support questions built out in guidance help prescribers to select the most appropriate antimicrobial for their patient. Moving on to our clinical evaluation plan, there's already been published literature on the previous version of Guidance MS by our colleagues, and that's demonstrated a reduction in broad spectrum antimicrobial use, antimicrobial costs, and C. diff rates after implementation. One of the main changes with the redesigned guidance program is that enhanced decision support at the time of obtaining approval. So our question is whether the decision support pathways actually help to improve antimicrobial prescribing. We aim to assess the appropriateness of antimicrobial prescribing for indications that we've previously identified with lower appropriateness of prescribing. The data will be collected 1 year post go live by repeated point prevalence snaps, and this will be measured as improvements in appropriateness of prescribing. One of the challenges in AMS is always to demonstrate cost savings, and we know that drug cost savings are not reflective of the true value of an AMS program. So we're planning to compare patients who have no approval or AMS reviews to those patients who have had an AMS review, and to demonstrate cost benefit using patient level costing data, including length of stay and bed costs. The guidance program is really key for this type of evaluation, as it supports that system-based approach to AMS and thereby accumulates data from many different AMS and quality processes. In particular, we can use the post-prescription review data and correlate that with our healthcare cost data, such as admissions and bed costs. So now hand back to Nanha to talk about our strategic planning.
Thanks, Jenna. So part of the practice to data component of the learning healthcare system cycle addresses planning for transformation, which includes strategic planning after implementation and evaluation are complete. So although sustainability and interoperability factors are considered much earlier in the design phase, we also address these here to take into account our learnings from the implementation and evaluation processes. So interoperability is key to the success of many digital health programs, and the guidance program included. So using data from user security and patient administration systems has always been essential for the guidance program, even with the previous version. Whereas in more recent times, the need to integrate with electronic medication management systems has just occurred over the last few years as hospitals have implemented them. So we have been able to successfully achieve several phases of integration with the EPIC system here at the Royal Melbourne. One is the implementation of a dynamic link, and the other is development of an antimicrobial report upload into guidance, which enables oversight and triage of priority patients for review. So Jenna will describe this in more detail on Monday's workshop, so that's a plug for that for Monday. To extend the level of integration with EPIC, we're currently working towards using CDS hooks to better improve workflows and data transfer. So we'll be looking to simulate the integration with using the Validitron at the Centre for Digital Transformation in Healthcare. So that's very exciting. One other thing that we'll be looking to integrate with our business intelligence systems for better use and data visualization. And I should also mention that the new guidance program has incorporated the SNOMED coded universal indications list for both indications and antimicrobials. So this list allows for data to be cleaner and more streamlined, which will allow much easier reporting and data interpretation. And what would be great to see is other systems using this standardized terminology in the future. In terms of scalability, the current Guidance MS program has been implemented at over 40 sites across Australia. So enabling the system to work in many different technical and workflow environments was a key consideration in the redesign of the program. So the new guidance program is designed to better cater for both metro and rural regional hospitals with and without electronic medication management systems. And as we recognise that many hospitals are still paper-based. In private hospitals where AMS setup is quite different and visiting medical officers just don't do approvals, we've been able to leverage pharmacy system data to help identify priority patients and enable post-prescription review and auditing. There is also a nurse-led model in one guidance hospital, and this has been very successful. They've recently had an 86% compliance rate reported. And lastly, the guidance program also needed to support AMS in a telehealth model where we can help support AMS services delivered remotely, particularly for rural regional hospitals. Coming back to the learning healthcare system cycle, we're currently in the practice to data phase where we have implemented the redesigned guidance program and are gathering data about its experience and impact. So we'll then move back to our data to knowledge phase, whereby we review the data from our evaluations and assess areas for improvement. So there we'll scope out the feasibility of these potential improvements. And then this will then feed into the knowledge to practice section where the development team will create the next version of improvements for release. And then the whole process starts again with continuing improvement of our systems for AMS. And through ongoing engagement with prescribers and AMS teams, we hope to gain useful insights and improve the program design to continue to meet their needs in the future. Thank you.
Thanks so much, Jenna and Nanha. Oh, there's lots of claps online on Zoom. No questions online just yet. We'll open it up to the floor if anyone has any questions before I start. Anyone at all? No? I do, but before I do, Kaz?
Yes. Yep. So the Monday session, sorry, Kaz's question was about our Monday session. So we'll be going through kind of more of the data to knowledge, I guess, section. So talking about the redesign and development of the program and we'll give a bit of a demo about all the new functionalities based on the feedback that we've received from end users. And I'll talk a bit more about our integration with the EMR system at the Royal Melbourne as well. So if anyone's interested, it'll be a really great session for you to come along to.
Thanks. I guess my question for you guys is to give context to everyone else to get to this point of implementing. How long did, if you had to put a number of months to it from that whole concept of redesigning before, going live?
It's like a while. The actual the implementation project of it, I think took about 3 months to for the work that we spoke about today, but obviously there was a lot of work behind the scenes to get up to that point to plan for the actual implementation of it. So yeah, it was a big team effort by everyone over a few years.
Fantastic. All right, thanks so much, guys. I will now so our next speaker is Caroline Chen, who is also an AMS pharmacist with the guidance group at the Doherty Institute. She has been involved with the National Antimicrobial Prescribing Survey, or the NAPS, since its establishment, 10 years ago now? Five. Oh, sorry, that's all good. Let me. And is currently managing the redevelopment of the NAPS platform. So take it away, Caroline. Thank you.
Thank you very much, Courtney, and thank you to everyone who's still here. Towards the end of the day, we're almost there. So I'm really pleased to be able to speak to you about the NAPS, which I think is a program that most of you are familiar with, and to talk to you about some of the work and some of the discussions we've been having behind the scenes for quite some time about where we take the program into the future. So I'll talk a little bit about the program as a whole, how far we've come in the 10 years and our past approaches to evaluation, and then really try and take a step back and use some of the learning health system principles to look at a big picture evaluation to help with some of our strategic planning for the NAPS as a program, as well as an actual platform into the future with a view for scale, scope and sustainability. So Jenna and Anne have done a really, really beautiful job at articulating a lot of the work that's been required to design an evaluation plan and to properly plan for the implementation, which is, I suppose, the first little part of the practice to data. And so my talk, I'm really going to be focusing on that final stage, which is planning for transformation. And so the data that we talk about in this stage of practice to data is really everything that we've learned over the years. And because the NAPS has been running for quite some time, we've gone through a lot of these processes of obviously we've commenced and we've done evaluations as we've progressed, and we've obviously implemented all the different modules and components of the program. But really where we're up to now is this strategic planning phase to think about what we want for the new program going into the future. So the NAPS program at the moment is a suite of auditing tools really designed to interrogate the quality and appropriateness of antimicrobial prescribing. And so as part of our core program, we have 5 modules across the hospital and aged care domains. And we've been very fortunate to be able to expand that to multiple countries. We're obviously very established here in Australia, but we've probably got 4 countries now that either have it as a properly funded national program or approaching that very soon. And then lots of countries, which is a big growth area in terms of piloting the program. We've also done pilots in general practice and the veterinary space, but we did sort of recognise that our traditional approach to auditing wasn't quite suitable for those 2 settings. And we've done smaller pilots along the way as particular needs have arisen. And so we're in a situation now where we have hundreds of facilities that participate every year. We've got a reasonably large data set, which is available for research. And a lot of the key NAPS fundamental concepts are really embedded into policy and standards and practice. If we think about our NAPS hierarchy of needs, everything that we've done and everything that we will continue to do is with the core view that it needs to first and foremost be important and useful for local quality improvement. That's the foundation of everything in the NAPS. And so all of our questions that we put into the survey content is to really interrogate the quality of the prescription. The participants, the local AMS clinicians do it themselves, and we design immediate feedback and reports for them. And we have actual dedicated clinicians on a help desk here upstairs to really help our users to do that, and that it's not just purely an online platform. And so with that really strong foundation and with the ability to have a standardization of data fields and indications, we enable peer comparison or benchmarking between participating facilities, and bringing that up even further for national reporting to have real data-driven insights into how antimicrobes are being prescribed, and to also feedback problem areas to inform national clinical guidelines, which we've done in the past. And then finally, for the fact that we have quite a rich data set to make that available for research. So we've been around for a while, and it was the early feasibility pilots in 2011 that really kick-started this whole process. But really the national AMS landscape has changed so much since then. And the program, the hospital NAPS was our flagship survey, and the audience that it was designed for back then is actually in some respects quite different to what it is now. Back in 2011, there was no AMS in accreditation standards. There was no national strategy or guidelines. There was no, so as in national AMS guidelines. The workforce was, I suppose, relatively new, particularly in private hospitals and rural and regional settings. And really it didn't exist very much in aged care at all, apart from some really key champions and early adopters that were trying to push this. And from a digital health point of view, I think we were all still on paper records. I think some hospitals might have started scanning records, but certainly nothing like the EMR situation where we have at the moment. And so fast forward to 2022, where AMS is really embedded into so many national strategies and standards. We have the AURA program, and actually our workforce is becoming quite experienced, particularly in hospitals. And it's really emerging very nicely in aged care. From a digital health point of view, I think probably every state and territory, sort of with the exception of Victoria, because we're a bit all over the place, has a statewide AMS, has a statewide EMR, or is in the process of getting a statewide EMR. And then even in the private hospital and aged care space, there's some rapid movement towards either EMRs or digital health records. And so just as the AMS and digital health landscape has evolved over that period, evaluation has been really, really key to ensuring that the NAPS program has evolved too. And so we've used a variety of methods to be able to do this, and from a variety of sources, from our end users as well to our funding bodies, and also just our kind of own internal team reflection. And actually many of the fundamental core concepts and approaches of NAPS have all come about because of evaluation and feedback, right down to even the process of doing appropriateness, of having an electronic platform, of having peer comparison came from those early feasibility pilots. But we've probably come to a point where those sort of small scale evaluations of improving the platform year on year within our current constraints has probably come as far as we can go. And whilst we have a very agile team, and so we're able to act on those findings and implement them reasonably quickly, I think amongst our group there's an increasing recognition that actually many aspects of the platform architecture and structure is potentially falling behind where it needs to be moving into the future. And so our approach at the moment is really to take a big step back and look at a big picture evaluation, look at everything that we've learnt, and put all of that into practice to really transform the platform into something that will be suitable for the next 10 to 15 years. So in order to do that, we've used this sort of SWOT methodology to help us articulate some of the strengths and weaknesses. Arguably, I think the fact that we're really the only auditing tool out there that does appropriateness as well as guideline compliance, it's got some limitations, but really I think it's a really important and fundamental of the NAPS. We've had very, very strong uptake, and it's embedded into standards and policies, and particularly with our international expansion and sort of expansion into other healthcare settings, we have sort of demonstrated that it is largely transferable and generalisable, and we have had relatively stable funding. In terms of the weaknesses, there's a really big recognition that it's still a very much manual auditing process, which in itself is important, and the act of AMS clinicians doing their own auditing is sort of associated with reflection and improved practice. But nonetheless, with the rapidly emerging digital landscape, is that really still going to be sustainable under the current system in 10 or 15 years' time? Arguably, the UI is a bit old and clunky, and we've got some really, really advanced AMS users out there, and we need to make sure that we're meeting their needs. The reports, which whilst they're great, they are static, and perhaps it actually definitely could be improved. And from a technical database point of view, there's so much of it that is quite cumbersome to maintain. In terms of our opportunities, a really big one is intelligent reporting and data aggregation. We also need to be very mindful of interoperability with other systems, particularly with EMR. And for us, the international market is a really important one to explore, particularly in low to middle income countries. And we've had lots of opportunities to explore that as part of various other grants and programs too. But we need to be mindful of the threats to our system. And so it's really important that we remain relevant and useful. Our participants have a lot of competing interests, and we really need to understand our role in the future national strategy. And also, as always, the security of ongoing funding is an important consideration. So what I've done is used, this is a framework in the learning health system. It's an article by Lefebvre, which was published last year. And while she describes these concepts in the context of low to middle income countries, actually they're all incredibly relevant and incredibly appropriate for anyone who's trying to move an intervention, a program, a platform from your early piloting where you've actually demonstrated that it makes a difference into making it transferable and sustainable in the long term. And so the first thing that she talks about are identifying all of the drivers of equity and innovation. Who are we missing? Are we systematically missing out on certain people? And so for us, for NAPS, we know that we have very good participation amongst public metropolitan facilities, but our rural and regional and private hospitals have lagged behind. And so is there a systematic reason for that? For our low to middle income countries, some of them have very, very poor IT infrastructure. And so with NAPS being a desktop application that requires a continuous internet connection, are we just kind of discriminating against them or not really meeting their needs when actually the content of it is precisely what they need? We have a lot of users of NAPS, and so we need to identify all the users' needs, but really always be focused on prioritising our end users' needs, and that is the AMS clinicians. The more that we have involvement from a national policy and a research point of view, I suppose the temptation there is to keep putting more data fields in to meet those purposes, but we need to be making sure that it's very useful for end users, and because we don't want the program to lose its impact, we don't want it to be an administrative tool, and we really want it to continue to have an impact on patient care and service delivery. And a lot of our users have used the NAPS in an innovative way, which we perhaps didn't realise, and so it's important to leverage that. The QI NAPS, when we first developed it, had a very limited scope, but actually people use it as part of an actual AMS program tool. So one of the pilots that we've done in Pakistan, for example, it was actually perfect in terms of not just auditing their antimicrobial use, but helping them to enable their actual AMS program. In terms of the second section, so it's making sure that NAPS is designed to be part of a digital ecosystem, and that we don't want it to be a standalone program with no interoperability and very siloed away from other systems. We think it's sort of really crucial that we invest in this interoperability, particularly with EMRs, because that's, you know, essentially every single healthcare service in Australia is probably going to have an EMR or some sort of digital record in the near future. And being able to build common data models to enable future data linkages is really important. We need to design the system so that it can evolve for evolving needs. both from the point of view of, I suppose, evolving technical needs, as well as the actual evolving needs of our users. And so that will help us to be sustainable in the long term. And so a lot of what we've talked about is, well, how will people use the NAPs in 10 years' time? And so it's crucial that we're looking at extracting data from EMRs, this sort of really advanced analytics, building the capability to support suggestions of appropriateness, so it's not necessarily manual all the time, and having really intelligent BI style reporting. And then a big piece of work that we're doing is to enable that we've got really strong data governance and data integrity, because even though NAPS doesn't have a direct impact on patient harm or patient safety, it's our data integrity is our equivalent of patient safety from a risk point of view. And so it's making sure that the key requirements from a legal, regulatory point of view, cybersecurity, protecting personal information is fundamentally built into the platform. And then finally, things that need to occur to have NAPS integrated into actual systems. So we need to articulate our long-term vision for how we're going to implement it, all the cost and the resources that will be required. We've been really successful in having it included in routine government funding up to this point, but it's really important that that continues. Defining what evidence matters. A lot of the time with public health programs that are funded by government, we need to demonstrate that we're actually making an impact. So it's easy to have that information in terms of reach and coverage, but are we actually improving appropriateness? And one of the slides that Kaz presented this morning, which show the improvement in appropriateness amongst certain segregations of hospitals, is really vital for that. And obviously to cultivate multiple champions, it's important that this is not dependent on one single person sitting at a policy level or a government level to make it successful. And so we've taken all the learnings and the discussions as part of that. And so our priority at the moment is to really funnel that and to articulate our requirements for the new system with a view for scale, scope and sustainability. In terms of scale, so I suppose we sort of achieve scale to some extent, but really in the long term, we need to be supporting different countries, different clinical settings, facilities with different levels of AMS program maturity, different IT infrastructure, different digital health maturity, and also different languages. And so some of the key requirements that we put into the scope of the new NAPS obviously is to retain some of the flexibility that we currently have in methodology and customization of data fields, and to obviously really keep the survey content focused and relevant. For countries that have really poor IT infrastructure, we need to make sure it's suitable for both desktop and mobile devices. And whilst it's fine for pilots to be done in English, in order for it to be a properly funded national program, it needs to be in their native language. And really investing in extracting data from EMRs, particularly for things like patient demographics and allergies and antimicrobial information, things that don't necessarily need a person on the ground or an experienced clinician to be collecting that data. And putting a lot of energy into advanced BI style reporting and analytics so that we really present back to you guys, the AMS users, as to what is important for you to focus on as part of your program. And in addition to that, embed a lot of the key principles of privacy, cybersecurity and data governance into the platform. We are very cognizant that we don't have unlimited time and money and resources to build it. So we need to optimize the scope so that we're not starting completely from scratch. We have a lot that works really, really well. And so we need to leverage that and not just try and reinvent the wheel. And obviously we've got 10 years worth of data that we need to make sure is still incorporated and consistent with the new system. And so really a lot of the key data fields, a lot of the survey content and the methodology need to remain fundamentally consistent. We, at the moment, all of our reports are custom built. That is not sustainable at all. And so using existing BI tools that are widely available in order to enable intelligent reporting. But apart from that, there will be lots that is new. In terms of making it sustainable in the long term, so there's some things we need to be thinking about, from funding and cultivating relationships to make the program sustainable. To make the platform sustainable, we need it to be built in a way that we can enable new surveys to be easily plugged in, so to speak, to suit different healthcare settings, and have a much greater improved user experience and functionalities, and really improve integration with EMR to have more decision support for assessments of appropriateness and guideline compliance, and improve sort of coordinator functionalities for our other countries. And also the technology itself needs to be sustainable. It needs to, the database architecture needs to be built so that it contains all of this scope in mind, built in a modern web application framework. And so our vision is to really go boldly. Continuous evaluation has enabled the program to grow to maturity and scale, and we've been able to do that over the years as part of an iterative approach to improving the NAPS. But we've really got an opportunity to transform and sort of future-proof the program. We're very cognizant we have varying needs of clinicians, healthcare setting and countries, and it's really strong that we lay a very strong it's really important, that we lay a very strong technical foundation. We should be looking to simplify auditing where possible so that AMS clinicians can spend less time entering data and writing on bits of paper to actually engaging with prescribers. And so 3 of the key things as part of that is to optimise information from electronic records, supporting assessments of appropriateness and having really intelligent reporting. And I suppose the final thing to say is that the NAPS program has always been bold, and I think it's that bold vision that has really held us in good stead to where we are now. And so that same boldness, together with all the supporting frameworks that we've learnt about today, will enable us to remain a strong and relevant program into the future. Thank you.
Thank you, Caroline. That was like lots of claps online too. And I think, if we asked everyone in the room, raise your hand if you've used the NAPS program before, then yeah, 90%. Yeah, so it's been great to watch the program progress. I know I'm biased because I'm currently the program manager, but in 2016, when I was an AMS pharmacist in a small regional hospital, like the NAPS is what we needed to get our program up and running, and it's great to see it evolve over time. I'll put out a quick question to the audience and then we'll move on to any other presenters. There's one online. Has there? I can't see any questions online, so all good. Thank you. Lucky last. So to round out our presentations today, very grateful to have both Hassan and Olivia. So Hassan is a human-computer interaction researcher at the Centre for Digital Transformation of Health and the University of Melbourne. His current research focuses on user experience design and evaluation for novel interventions in digital health. Previously, he was a lecturer at Deakin University, a research fellow at Microsoft Research Centre, completed his PhD with the University of Melbourne and a Master of IT with Monash. His research interests are focused on digital health, user-centric design approaches, and social and collaborative use of technologies. Olivia is a senior research fellow and behavioural scientist at the University of Melbourne. Her programs of research focus on developing and evaluating digital health tools, including leveraging smartphone, wearable, sensor, and other digital technology to assess and treat physical and mental health conditions. Welcome, Hassan and Olivia. I'll just make sure. Yep. So they see that.
Yeah,
Yes,
great.
take it on.
Thanks so much, everyone. I think on the program you have, it mentions my colleague Mahima, who's not able to be here today, so I'm presenting for her. Just also take my mask off thing. And thanks for sticking with us the very last presentation on a Friday. We'll try to be quick. Yeah. So yeah, just want to acknowledge country. I know that's been done today, but just acknowledging that we're speaking from the lands of the Wurundjeri people. And I know you've probably heard a bit about the centre today, but just to recap in case you've forgotten it from this morning, I think this is a really nice slide that summarises what we're doing at the centre, which is really taking that multidisciplinary approach to bringing together all of the professionals that are needed to solve complex health problems using digital tools. It's really necessary to work in a multidisciplinary way to do this, and that's what we do best at the centre. And I know that Professor Chapman would have shown this morning, but I think it's also really helpful to talk about digital tool evaluation with this slide. We have a very good, clear process for drug development from drug discovery right through to being on the market. And of course, clinical trials are a huge portion of that. And it's a very clear step for what you want to do if you have a new drug discovery. But when it comes to digital health, we have a big gap there when it comes to what do we do and how do we evaluate it. And again, that's a mission of the centre to work on filling in that gap. And you've heard a bit about the Validitron and other sorts of things today. Oh. I think, again, a lot of what we talked about today is digital health already. And as researchers and clinicians, you already have really clear ideas of what digital health is and the tools that you use. I think it can be helpful to think about some of the things we've heard about today, and then it naturally leads into why it can be challenging to evaluate them using traditional methods. So digital health includes things like software and hardware or both that's focused on improving the healthcare system efficiency or other aspects, but it doesn't really have a measurable patient outcome benefit. There's also lots of instances of mobile digital health that might be via a smartphone or a web-based platform that's designed to do a whole range of different things, maybe to different groups of people, including patients and clinicians with the same tool. And so, the platform might be both informing and monitoring, as well as encouraging behavior change and self-management. And then, of course, clinical decision support tools, which again, we've heard about today, those prediction models that are guiding treatment or, delivering active monitoring or calculating or diagnosing. All of those things, of course, are digital health. And that makes them different to traditional simple interventions. And I use the word simple not in a disparaging way, but simply because when we look at this image, you can really see whatever your drug intervention might be or your standard intervention, it's some amount of components that are packaged together into this intervention box, and then it's delivered to participants in more or less the same way. And that's easy to compare in a randomized controlled trial because you're comparing this intervention with some other comparator, and that gives you a nice model for effectiveness. Of course, that's the clinical trial model. And pairing onto that, when we pick a methodology like an RCT, it's very easy to kind of select what our traditional outcomes might be. So in this instance, for some, kind of more simple intervention around changing antimicrobial prescribing habits, your primary outcome would be something like this, such as decision to prescribe, selection of the drug, duration of the treatment, guideline use, concordant use. And then you might have a series of secondary outcomes such as these. And again, all that's well suited to traditional interventions. But digital interventions or complex interventions look a lot more like this. So you've got one participant who might receive all of the elements of the tool. You might have one participant who's either a patient or a clinician who only needs to access other elements of the intervention. And then maybe a third is using one component, and then time passes. And then when it's relevant, they're using another component. So the key thing here, of course, is that it's just a lot more messy and complex. And they're all receiving the intervention that you've designed. So that makes traditional methods really challenging. So these are some of the challenges. And again, we've heard a bit about this already in this session. Digital tools tend to have different components, and that makes them complex systems. The way they work is often on-demand use, which is based on personal need and preference. So there's no specific prescription or dosage in the same way that we see for drugs or more standard interventions. And that makes it really hard to attribute causation and outcomes. And there's also lots of questions around what do we measure, how often, how do we measure it, and then how often do we do it? So this leads us to lots of challenges around evaluating digital health solutions because they're complex, especially when they're not related to patient improvement specifically. So Mahima's team have been working really hard at this, and Hassan's going to speak a little bit more about some of the experiences he's had. But I think three nice key takeaways that you can have on a Friday afternoon are really around this. And I guess just to preface this by saying the digital health team at the centre
no one in the world has the answer to this yet. We're all kind of working it out as we go. But some of the things that I think that can be really helpful when you're developing an evaluation plan for a digital health tool in whatever field that might be, and again, an earlier speaker did this exactly, is if it's difficult to measure effectiveness because your digital tool is not designed to target effectiveness directly, or just the nature of it makes it challenging to apply a methodology to measure effectiveness, you can use things like logic models to kind of work upstream and see what elements are impacting effectiveness. So here, if your digital health tool, if you're interested eventually in effectiveness, we know that patients won't be benefiting if they don't use the platform around efficacy, and they won't use the platform if they can't use the platform. And so you can focus on aspects that are upstream of effectiveness, like usability, which we know eventually will impact that. And setting out this logic model is really critical at the start of an evaluation plan for a digital health tool, because first of all, it kind of, again, characterizes the mechanism, it clarifies the mechanism of the tool's impact, and then that leads really naturally into the kinds of outcomes that you might select to measure. Some of the challenges, again, that Mahima's team have had around matching outcome measurement is really that most PROMs or patient-reported outcome measures are not really developed with a digital intervention tool or a complex intervention tool in mind. So this example is taken from a project that she did working with survivors of brain tumor, brain cancer, and their carers. And they were both using this digital tool. And again, the sorts of things that the platform might be designed to change aren't necessarily related directly to these sort of health factors that you might see in patient-reported outcomes, but that nevertheless doesn't mean that the tool itself is not effective. So she worked really closely with patients and carers to kind of modify the language that you might typically see in a PROMS in order to be able to kind of measure whether that digital health tool was actually having the effect that they were looking for. And then a third thing to really consider, and again, we have heard a lot about this already today, so just operationalizing what's already been discussed. In an evaluation plan for a digital health tool, it is really important to understand those implementation barriers and facilitators, because again, as I think most of you who've worked in this area kind of know, is that even if you have a great prototype with great pilot data, lifting that into a setting, a healthcare setting, has a huge amount of implementation challenges. And so this information in your evaluation plan is really, really rich, because it helps you understand if effectiveness or your other outcome measure hasn't changed, or even if it has changed, what does this mean going forward for the life cycle of this tool? So things like platform quality and usability, accessibility, personalization, particularly we've heard a lot today about data security, legal liability issues. That's really critical, as well as any interface that's occurring with the healthcare system. So, oh, really doesn't want to, okay. So Hassan's going to talk a little bit more about some aspects of this in a completely different field. But again, I think the digital health challenges apply regardless of what kind of population that we're working with. So I'll just hand over to him.
Hello, everyone. So today you have seen a lot of very important and successful projects. Now I'll talk about some failures and lessons learned that I have experienced in the past years. So today, the first project that I'll talk about involves Christmas. So Christmas is approaching rapidly this year, and as it happened in about 5 years ago, in 2017. So the city of Melbourne decided to develop a Christmas themed application. So Pokemon Go, if you remember, was all the rage at that time, and we tried to develop our own Pokemon Go in the Christmas theme. So they commissioned an industry partner here who developed a location-aware treasure hunt in the Christmas theme. So the aim was to engage the city dwellers, people's children, everyone, the families that are visiting the city at that time, to engage in a city-wide treasure hunt so that everyone can play, and it was in Christmas theme. Here's a small commercial. If you have experienced that application.
Just a little bit more.
Yeah. So it was targeted towards families where they came to the city with their smartphones, used the application, and it required them to complete a storyline by visiting different parts of the city and unlocking different features of the application. So they placed augmented reality-based markers in 6 different locations. So 2 prominent locations at Federation Square and Bourke Street. But the real objective was to engage people with the very little laneways that we have in this city of Melbourne, to engage with the rich culture of the city. Okay, so our own Pokemon Go. Now, at the university, the research team, we conducted an independent evaluation of how the system worked, what were the concerns, and how we can improve in future iterations. And we identified a lot of issues. So first of all, the application was downloaded more than 20,000 times and used more than 20,000 times by different people. However, when we analyzed the log data about how many people completed all the tasks and finished using the application, we found that I think less than 5% of the people completed and traversed all the locations. Okay, so still thousands of people, but not the intended outcome that we expected. Why? First of all, we noticed, because our research team, we were in the field, we observed people. One of the main issues that people experienced was the battery issues, because it took more than 1 hour, about 2 hours, to complete all the, to visit all the locations. Smartphone batteries could not sustain that high level of graphics and continuous use of it for that 2 hours. So augmented reality based applications draws a lot of battery. Then we found that while 20,000 people use the application, many more could not use the application because they were not ready to use it. So they visited the city for other purposes and they saw the advertisement, the kiosks to use it, and they wanted to use it, but they could not download it at that time on the go because of the large size of the application. It was like gigabytes of data at the time. And we also noticed that many people, when we analyzed the data, that they traversed all the locations in this line, but not the last one. So that was a bit away from their regular path of journey. Okay, so while they were very much okay to do some Christmas shopping, move around the city and enjoy the application, but they did not bother to complete the journey. We guess that due to these location issues. So some lessons that we learned from this user study while and use it for the next iterations in the Melbourne Knowledge Week and subsequent applications. Another project that I can highlight today is done with the Department of Physiotherapy, where we followed a user-centric design approach to solve some of the problems that they face in their classrooms. So physiotherapy is often taught with this kind of 3D anatomical structures and 2D posters. And we identified through a user study different needs of the students. And this is our final outcome. So based on their requirements, we designed this projection-based augmented reality application to be used in their lab. So a few of the problems that we tried to solve in this application, first of all, recordings, because in physiotherapy lab, they are not allowed to record the lecture, but due to privacy concerns, but we could record a 3D anatomical model because no humans will be recorded here. Note taking and other issues was identified, and we tried to solve this using a tablet application. So this is the first iteration of the application where we developed a projection and associated tablet application. So the teacher and the students could see the live anatomy avatar in their tablet. They could freeze that application and take notes, draw on the body. At the same time, the lectures was recorded audio and the anatomical model. However, in our primary evaluation, we saw that this tablet was a big failure. Okay? So we spent months and thousands of dollars in developing the tablet application, but failed because it was too heavy. So students was required to stand in the classroom with their tablet in one hand and drawing with the other hand for hours, and it was not very practical for them to do so. So in our 10-minute lab exploration, it was fine. In the classroom, it failed. And we also noticed that there was an attention split causing by this tablet interface, that the tablet, when they are taking notes, the tablet interface is frozen for allowing them to take notes, but the visual continuum was broken because the live projection was showing something different. So with those feedback, we modified our applications and discarded the tablet to allow drawing directly on the body instead of drawing on the tablet. So coming back to here, that while these two examples is not strictly related with the antimicrobial stewardship, but I believe the lessons are still very relevant. So in all my user studies, I found that most common failure came from our own enthusiasm with technology and our research, and we often forget about the user. So while we have all the good intention, but in practice, our enthusiasm and technological affordances often cause us to not notice the user-centric problems that may arise. So to conclude my discussion, so I would always encourage that test early with real users and in real life settings. Do not assume that what works in ideal settings, such as in the lab or in the development phase, will work in the real field for many different reasons. And testing should be integrated in all stages of development.
Thanks, Hassan. So I think, yeah, just to kind of summarize some of the points that we're trying to make, and again, there's so much in this field and happy to have a continued discussion about this. But to clarify the causal assumptions about an intervention, a digital health tool, to really determine different factors that impact effectiveness so that you can kind of, when an RCT is not well suited, and that helps you really guide those research questions and the outcome measurement and develop kind of concrete evaluation plan. And consider as well outcome measurement, whether it's on the patient end or the clinician end, that if it needs to be modified in order to really understand the kinds of impacts that we expect our digital health intervention to make, so that when we conclude whether the intervention is effective or not, it's not due to the fact that we weren't able to measure what it is we thought would change it. I can't emphasize that enough. And then also continuously, as we've seen from Hassan and some of the challenges, really consider and continue to measure digital health implementation barriers. It's constantly surprising how much even a really well-developed laboratory-based prototype that just fails to translate into the real world for lots of different usability reasons, implementation reasons. Okay, thanks for sticking with us the whole day. I think that's all from us.
Thank you, guys. Kaz is itching for a question. Go for it. Do you want to come? Just come on up.
I purposefully, and to all the people online, I purposefully wanted this to be a really important session, because it is really something that's done very poorly, if it ever, by all of us who put programs in, and whether it's digital or not, thinking about how you evaluate things is actually really important. But many of us are actually struggling in our EMR environment. So as a question to you about the tension between how we have to fit in the, I guess, the parameters and governance around these EMRs, and then what we would like to do if we're trying to think big.
Yeah, thanks. So I think, I hope I'm not overstating it because it is Friday afternoon. I think that's actually one of the biggest challenges that we have, maybe the biggest challenge when it comes to digital health, regardless of the patient or the population. How do we integrate this big data or an effective digital tool into the healthcare system that already exists? And yeah, certainly don't have a lot of the answers there, but I guess, to really plug the Validitron that we have at the center, that's exactly one of the purposes of the Validitron. So it's both a physical space and it's also a digital space where you can use simulated EMR data to see if it can integrate with your digital tool. And yeah, it's one of the facilities in the world just at the center here that has the capacity to do that. So we are trying to solve that problem by creating environments where you can play and work with your digital tool and the healthcare system that we have, so that you don't have to enter into a hospital to try to figure that really critically important problem out.
I've just had a look. There's no other questions online, so we'll just take questions out to anyone in the audience if anyone has any questions. No? Oh, good. Well, thank you so much, Olivia and Hassan. We really appreciate having you here today. It was a nice round up to our last session about evaluations. Thank you.
So just back to the Learning Health Fellowship, and some of you may have the opportunity to apply for that, particularly in the precinct here. Each fellow is paired up with someone like Olivia or Hassan, actually. So as you start to design out your project, you're matched to a mentor both within your organisation as well as from the Centre for Digital Transformation of Health to help drive you through your project. And, you know, it's been an interesting journey for the first batch of fellows. It is a 12-month funded position. And what we're finding is that because of the complexity of having to design the evaluation at the time you put your project together, this is often a very steep learning curve for someone who hasn't got a research background. You know, developing up the project plan, the ethics submission, you're getting your learning health community, going through the design phase. So the current fellows that I'm involved with have really got to close to the end of the 12 month, and they're really only just starting. So like everything, and you know, you heard the chuckle in the room when we talked about the guidance and the NAPS redesign. This is something that takes enormous effort over many years. So any project that you embark on, you would expect that it's going to take a bit of time. There's nothing in this world in digital health that either is easy or a quick fix. So I think if there's one thing we can take away, that there really does need to be a very considered approach in how you do it. So I guess
there's just one comment online from Tan Van Hoek.
Yes.
Thanks for sharing your experience. Yes. We are developing similar digital systems for infectious diseases surveillance and pandemic preparedness planning in Singapore.
Yep.
Evaluation and validation are things we are still learning. So I think we're all in the same boat.
Yeah, so I had the great pleasure of meeting a number of the ID and AMS team in Singapore last week at the World One Health Congress, and have invited them to watch today, because we actually shared some common challenges around how we did it. And some of their team have actually been embarked on some data science initiatives in prediction of infections surveillance, similar to our team. So it's lovely to have you online, and we look forward to future collaboration with you. And you know, they're very happy to participate in Australian and bilateral projects. So that would be fantastic. So I guess that comes to the wrap up part of the day. Rod, you here?
He's hiding at the back.
Yeah, so first of all, the first thing I'd like to say is thank you to you, Courtney, because I don't think, Courtney, you have been incredible, and the whole team in building out the program, but you can imagine the challenges of putting together not only today's forum, but the 12.
Yeah, there's 12 webinars,
next week that she's also been working with. The registration of everybody online today. There's been almost 100 people.
Well, I mean, they've seen me navigate Zoom today, so it's got to be a long week.
This is from So there are many collaborators who are going to be involved in either today's program or the programs next week. All of these, many of these are fellow research collaborations that many of us involved in, but also some really key groups. And we have had the Department of Health online watching today, Australian Commission of Quality and Safety, who will also be involved in our workshops. And thank you to everyone online who have been involved or participating and be working with us over the next week. Seriously? Yep, this time.
So we just mentioned.
Oh, okay. As I mentioned before, the catering today was from the Australian Asylum Seeker Research Centre. Thank you, Court. And again, to reiterate the importance of giving back to our community and providing donations to the Vets for Compassion, as well as the Indigenous Literacy Foundation in lieu of presenter gifts. So on behalf of me and all the team, thank you so much for our presenters. Lisa, for coming down and giving your time so generously today. Thank you. And then a final shout out to our trustee working group, and who met, very frequently in the last few weeks. Many of them are obviously here and some are online. Nadine, thank you. Cheryl in South Australia, Fiona, who's up in Queensland. Arjun, trustee Arjun, has been our NCAS manager, is over in West Australia studying nursing, but has been a constant presence in the background.
I annoy him a lot. So,
And
yeah.
we couldn't do it without him and his knowledge, because he has organised previous antimicrobial awareness weeks forums. Sarah and the Queensland team as well, who have come down, Kristen from the Commission, who's up in New South Wales, and of course our amazing local AMS team, Jenna, Ruby, so we've had, and Nolene from Aged Care. So thank you so much. I think it's been a fantastic program today. I'm sure you agree. I hope that all of you have been able to take away some learnings from what you've heard today. We are absolutely open for you to contact us, either to ask questions, to participate in research with us, to ask assistance with your analysing your data and how to best, or how to develop a program. We're very, very happy to participate and support you. That's what we do. We've been doing it for a long time. And that's, I'm sure, the animal team as well as the human teams for human streams. And thank you for all of you who've made it. It's been absolutely amazing to reconnect with many of you that I haven't seen the last couple of years through COVID, and it's really great to have had you come in today. So thank you. And
the next one is just, I've put it on the link on the chat for everyone online, but that's just the QR code to just a couple questions. I've kept it very short, just some feedback and evaluation for today. We've just had a whole session on evaluation and trying to improve our educational events and future AMS and Antibiotic Awareness Week events. And I guess this is the first time we've had this theme of a learning health system. So we really would appreciate your feedback on that and any ideas or topics going forward. So, we target this to you guys. We want to be, covering what you want to learn and going forward. So, and then that leads us to next week. So there is a whole series of workshops. So these are all the links, the registration links are on the NCAS website. These are all free to attend online. So on Monday, we have our guidance team, so Jenna and Ron, about the guidance program. And then in the afternoon, we have Jason Tribbiano's team applying the same learning health system to their approach to antibiotic allergy delabeling. Tuesday is a big one as well. So in the morning with Lisa Hall, who you've met here today from the CSIRO, it's now going to be online only, not face-to-face and online, about innovating antibiograms. Minyon and Sarah from our Queensland statewide AMS team are talking about making AMS sustainable. In the afternoon, we have a nursing program more targeted at our clinical nursing staff. And then in the afternoon, later in the evening is our CRE Respond collaborators in Queensland with how to dose antimicrobials during renal replacement therapy and ECMO.
Encourage your please encourage your nursing staff to join that nursing workshop, because there are some fantastic speakers and it's really pitched at the clinical nurse, the ward nurses particular.
Then by Wednesday, we have antimicrobial stewardship in the perioperative setting, another session looking at more specialised settings like pediatrics and dentistry. Then we also have a session with our international colleagues with the Fleming Fund. Do you want to quickly touch on just a little bit about the Fleming Fund?
The Fleming Fund is a UK-based program, and Doherty is a partner institute who has been mentoring fellows in both antimicrobial resistance and antimicrobial usage surveillance from several countries, such as Bhutan, PNG, Timor, Nepal, Pakistan. Is that right? Am I missing anyone?
Oh, there's probably more, but
There's
I think
probably more. And many of our team have actually visited. So I went to Bhutan a couple of years ago. Really amazing experience. And Rod is one of the key leads for that project. So many of those fellows have come to the end of their fellowship and have started to implement programs, including the NAPS, for example, in their own organisations. So they're always really interesting to listen to.
Oh, and then can't forget about you, Ruby. Sorry, that evening is a GP workshop. So it is targeted at GPs, but we also have lots of pharmacists and other allied health professionals attending that session as well. Then to end off our week on a Thursday, so Kaz is chairing the first session on AMS in the immunocompromised patients. And then Nolene, who you met earlier today, is running this fantastic webinar on priorities for AMS in aged care. And I'm very certain we've already got over 150 or nearly 200 people registered for that. So it's going to be a great session.
So just last year alone, with our fully online program, we had over 1,000 participants over the week. So you can imagine. So please join those when you can. If you can't join, everything's going to be recorded and be uploaded onto the NCAS website.
Yep. I mean, I'd say it's our intention to record pending technological problems, but it'll all end up on the NCAS website. And then just plugging a couple of events from our collaborators and sponsors at the Centre for the Digital Transformation of Health. So on the 30th of November, the LHS Learning Health System Academy Symposium. So members that have completed their fellowships are presenting on their projects. And then later in the afternoon is the Digital Health Problem Pitchathon. So some of our colleagues that have been completing this learning health system course have been approached to, pitch their problem in, I think it's only a minute to go through it. So if you want to hear what other people are doing to address their quality improvement and other clinical problems from a digital health perspective, highly recommend. And there's some codes there as well. And that's it.
And that's it.
We are
back to the very confusing slide, but hopefully that's not so confusing to you all now, since you've had a whole day of being inducted into learning health.
And that's got the QR code for the actual short course itself. So I myself, we've started in August and we've got a couple of weeks left, and then the next course will start again in March, and there's time to start looking at that and registering to start that program if you're interested. So I'm nearly finished and I highly recommend it. Yeah, that's it.
So wrapping up, thank you everyone today. I hope you had a great day, and we look forward to your ongoing interest in collaboration, and happy Antimicrobial Awareness Week.
Thanks everyone.